lecture to all of you. And I also would like to acknowledge Dr. Debashis Das from Calcutta, who was coordinating for this meeting. And the topic will be on post-operative catheter interventions. I would like to state that post-operative catheter intervention can be sometimes be predictable and sometimes be predictable. Let's see what are the predictable post-operative interventions. Those that are known to occur with a particular frequency. So that means we are well prepared for it. Let's assume we are doing a neonatal coarctation surgery. We know that there is a definite incidence of recurrence. Similarly, a post-op arterial switch, supravalvular pulmonary stenosis, the post-VSD closure, a complex VSD closure, a residual VSD. Percutaneous pulmonary valve implantation for pulmonary regurgitation after 2 years. After a complex VSD, the post-sinus venous defect, surgical closure, SVC stenosis, or whenever we are doing an RV to PA conduit and predictor. In this, there are proven strategies. Let's assume if there is a post-popish balloon dilatation or stent angioplasty is a proven strategy. It's better than a repeat surgery. There are certain procedures with established guidelines. There are definite RV volume criteria, RV function criteria, and there are studies that show which is the best of the modality. Let's assume that there is a post-pathology pulmonary artery stenosis. If it is simple balloon dilatation is going to recur and stenting is far better. So there are methods to know that which modality is the best. There are certain standard incubation criteria. Pathology of follow. If there is a new in some of them, in order to postpone the next stage of surgery, for example, we have an early degeneration of the conduit, then to check postponing the stage by doing a conduit stent. So, an example of a neonatal subclavian flap surgery, and then the patient develops at around 4 years of age a significant retractation. We initially try with a balloon, and if the balloon fails, that means you don't achieve a gradient of less than 20 millimeters of mercury, then go for a stent angioplasty. So, this is an established indication for an intervention. Some of these pericardial patch reconstructions will go into restenosis. So again, stent angioplasty is an established modality. Balloon standard interventions. Post-arterial switch operation, if there is a tight supravalvular pulmonary stenosis, then the stenosis. In a similar way, residual ventricular septal defect after a complex DORV repair. So in this patient, there are multiple tracts, and here you can see there are 2 defects and there are 2 devices that are closing off. Another example will be percutaneous pulmonary valve implantation after a tetralogy of fallow repair, where pre-pulmonary regurgitation is clearly known. There are specific criteria for how much RV can dilate, how much RV function can go down, or how much QRS dispersion can happen before we put in a percutaneous pulmonary valve. And what you see here is a percutaneous pulmonary valve, a venous valve, which has been implanted, and it's arrests the pulmonary regurgitation. The last will be an early truncus getting operated. There is a very early degeneration of the conduit leading to severe stenosis. And hence you stent that conduit in order to relieve the gradient and then postpone the next stage surgery. What is more challenging and more important are post-operative complications that are not expected in routine practice. These are unpredictable problems. This will offer challenges as they may not follow a steering. Patient would not have been counseled of these unexpected complications in the routine tools also. Let us go into an example. A patient who gets a mitral valve replacement and an aortic valve replacement gets a large pseudoaneurysm from the submitral annular stretch, and this leads to a large expansile pseudoaneurysm across the left atrioventricular junction, spreading around the heart. This is very common in patients who have rheumatic mitral stenosis, those who have annular calcifications, those when the valve is oversized, if it is a female, if there is an extensive decalcification, in such cases this may happen. So this is a catheter that enters, because this is a mechanical double valve, and enters into that pseudoaneurysm. We can appreciate the pseudoaneurysm here, and that is getting closed with a large occluder device, which is measuring around 22 millimeters in order to close off that aneurysm. Similarly, another example, a post-double valve replacement. This is when a large prosthesis has been implanted. The stretch leads to a very large expansile pseudoaneurysm, which is actually guarded by the collapsed, measuring almost double the size of the left ventricle. So in such a case, again a similar sort of strategy, going through the apex in this mechanical valve and entering into this large pseudoaneurysm, closing the mouth of that pseudoaneurysm with a large occluder device, which will result in a little bit more closing of the pseudoaneurysm. Ascending aortic, a coronary artery bypass surgery, and twice presented with ascending aortic recurrent pseudoaneurysms, twice operated. The first time was operated with a bovine pericardial patch, and the second time need repeat large, and this is being closed because of already one coronary bypass surgery and two surgeries for the ascending aortic pseudoaneurysm, and still recurrence large pseudoaneurysm. So it's getting closed. This is another example of an aortic valve replacement surgery. And aortic valve replacement has been done for a calcific aortic stenosis. The cannulation site, the cannulation site spreading all across the left side of the aortic arch and extending up to the sternum, enter into that pseudoaneurysm and position a large muscular VSD device, which is measuring 24 millimeters, and occlude the orifice of that aneurysm. So these are some of the ascending aortic pseudoaneurysms that may be possible to address. Another examples will be very complex innominate artery pseudoaneurysm and a large graft has been placed from the ascending aorta going all the way into the innominate vascular junction, and this distal graft is now getting dehisced, and in such a case there is a distal anastomotic leak where the graft is entering the carotid artery and the subclavian artery. At that area, we position a large covered stent graft and also close off the subclavian artery mouth with a vascular. It is filled, and subsequently there is a vertebral filling. Here you can appreciate the vertebral artery coming down and filling the right subclavian. So thereby we may be able to address recurrent pseudoaneurysm. Yet another complex problem will be a post-Bental cases where a leak can happen around the anastomosis with us. Complex left coronary artery button anastomosis dehiscence. We can appreciate that the left coronary is giving off and there is a leak that is button's inferior orifice, which is actually filling the entire and by a vascular plug of the mouth of that aneurysm. And we can appreciate this is the original aneurysm around the graft. It's actually clotted off, and this is the device that is placed on the mouth of that left coronary artery button dehiscence, which is of the peri-aortic pseudoaneurysm. Similarly, there can be a post-ventral right coronary button anastomosis. So this is a right coronary button anastomosis. We have entered the perigraft ascending aorta. We can appreciate the large perigraft ascending aorta in this point. So this is the perigraft aorta. On the right coronary artery button leak. So this is the right coronary anastomosis. We can appreciate the leak arising from that right coronary button, and that is getting closed by a device on the inferior margin of the right coronary button, which is causing that pseudoaneurysm. So to sum up, operative complications are sometimes very predictable. Pulmonary artery stenosis after a tetralogy repair, pulmonary valve implantation after tetralogy, late long-term corrections, residual VSD closure, recoactations. But what is unpredictable complications? Unpredictable complications are more challenging because neither the clinician or the team is prepared, nor the patient was counseled in the earlier phase. It is imperative for the cardiologist to understand the surgical anatomy by closely watching complex surgeries so that the cardiologist can offer some catheter-based solutions in these unpredictable problems. Because stereotyped procedures like coarctation, dilatation after recoarctations, these can be handled by anyone. Whereas, in order to understand an unpredictable complication such as some of these pseudoaneurysms, the cardiologist needs to watch many complex surgeries at a close quarter, thoroughly understand the surgical anatomy, get information from the imaging such as CT or MRI, and then he should sit with the surgeon and then try to find out some catheter-based solutions in complex, difficult, unpredictable problems. Thank you very much for your attention.
Thank you, Dr. Shiva. Dr. Tendulkar has a question if you are around. Thank you.
Dr. Shiva?
Anyway. Sir, I'm able to hear you, sir.
Okay. No. First, congratulations for an excellent presentation. Only thing, putting a device for a coronary button dehiscence in a Bental, aren't you worried about occluding the coronary ostium totally?
Yes, sir.
So how do you ensure you don't do that?
That is where we need the surgeon and also an extensive analysis of the CT scan data. We need to clearly identify the exact location where the leak has happened. In fact, one of the coronary button dehiscence that I showed was published in the Annals of Thoracic Surgery. We need to have a very close, clear delineation of the aging, and then subsequently we should sit with the same surgeon who of ascending aorta, or it was a direct coronary anastomosis. And the third one will be to have a protective strategy, like putting in a down into the left anterior descending coronary artery in order to keep the lumen widely patent, and then subsequently deploying the device. And before release, having multiple checks on the angiogram to confirm that the device is not going to be impairing with the coronary flows. Now, if you talk about a metal sitting on the ostia of the coronary, there are many left main coronary artery stents that are getting implanted throughout different parts of the world. And so metallization is not considered to be a big difficulty as long as you are giving appropriate antiplatelet or anticoagulation strategies. But I do agree that we need to, for extensive discussions.
Okay, thank you.
Yes, Shiva, this is Dr. Hiremat from Satyasai. Regarding the RSOV device closures,
is going to restrict the mobility of the aortic valve leaflets. We need to identify the precise orifice of the aortic orifice of the RSOV, which means at the level of ventriculo-aortic junction, and not to extensively oversize these devices. If you oversize a lot, it is going to hold on to the leaflets and prevent it from having a free mobility, and that may have some amount of aortic regurgitation. Anything that is more than grade 1 to grade 2 aortic regurgitation at the end of the device deployment is unacceptable to be sent for surgery. However, in a large majority of the patients, aortic regurgitations may not occur to a clinical significance, grossly oversizing the device.
so you expect some amount of residual RSOV in going in for a little smaller device in such cases?
No, sir. Actually, we have to occlude that ventriculo-aortic junction. If you don't close the ventriculo-aortic junction, the residual flow that happens across the edges of the device will lead to hemolysis, because it is a very high pressure jet, especially if it is something like an aorta.
So when you don't have mild plus AR, in the follow-up period, you will not have AR according to you after the device implantation.
Usually AR does not progressively increase after an RSOV device closure. We published our data of RSOV, especially in a very controversial indication. For example, let's assume there is a patient who is having a restrictive perimembranous VSD or a restrictive subpulmonic VSD, which is on medical follow-up for many years. And then at around 30 or 40 years, that patient, the onset of heart failure was created by the new onset RSOV. So traditionally what we have been following was take up these patients for surgery, close the VSD surgically, close the RSOV, and if there is significant aortic regurgitation, maybe change the valve also. However, we took a strategy to analyze some of these patients, and if the VSD was extremely restrictive, leading to a very negligible shunt, address only the ruptured sinus of valsalva aneurysm with a device, leaving behind the VSD residual. We published our data on 12 patients in pediatric cardiology for a median follow-up of 6 years to find out whether the small dilatation more than the basal level. And we found that the moment we close the RSOV and leave behind that restrictive 4 or 5 millimeter perimembranous or a subpulmonic VSD, they do not cause any major problems. Like, of course, the risk of infective endocarditis may be there as before. However, and so the title of the article itself was, if there is a ruptured sinus of Valsalva associated with a restrictive ventricular septal defect, which has been there for many years, is it mandatory to go and close that restrictive VSD? The message that I want to convey is, in RSOV, if we close with a device that is not extremely oversized, aortic leaflet mobility will be preserved and AR will not happen. Long-term aortic regurgitation also are very less common, very less seen after an RSOV device closure. The third thing is, if there is a restrictive associated VSD which is causing a very negligible shunt, we need not go behind that restrictive VSD and put an additional patch for that. A small VSD with a very small shunt can be left behind and an RSOV alone can be addressed.
Thank you.
Shiva, can you hear me, Shiva?
Yes, sir.
Dr. Shukla from Velo. See this restrictive VSD
Yes, sir.
that you are talking about. My gut feeling is that this is a VSD and it is getting restricted because of the prolapse of the sinus and the entire anatomy going wrong. I have yet to find a restrictive defect in an RSOV. It is always large.
Exactly, sir. It is the same thing what you are saying, sir. Actually, in a subpulmonic ventricular septal defect, the right coronary cusp prolapses and restricts the size of the VSD. The prolapsing right coronary cusp and this sinus of Valsalva aneurysm becomes, it leads to rupture towards the similarly in a restricts the VSD, and these the sinuses progressively keep enlarging over a period of time and they rupture. So the ruptured sinus of Valsalva aneurysm in the perimembranous VSD will be either on the coronary cusp, which is called as the Sakakibara type 3A or type 3V, depending on where it ruptures. The problem is precisely what you mentioned. It is a coronary cusp prolapse that starts off in very early childhood and keeps on getting progressed, which is absolutely not detected at all. And one fine morning at pre-existent perimembranous or a subpulmonic VSD, some of these patients may they were told to be on medical follow-up. It's a very common history that we get. I totally agree with you.
Thank you very much. Let's proceed with the next topic.
Aortic leaflet prolapse. Yes, sir.
Thank you, Dr. Shivkumar. And I request.
Thank you, sir. Thank you.
Thank you, sir. May I request Dr.
To be there,
Vinayak
but-
and Dr. Surendra Agarwal to take the session forward? Yeah, you sit there and take it forward. No problem.
Procedure with a supposedly longer long-term survival. And this question is not new. It's been sort of debated for more than 2 decades. And these couple of publications show the earlier one way back in 1996 is a high-risk biventricular repair always preferable to conversion to a single ventricle repair. This was during the early days of the single ventricle repair. And then more recently, questioning as to how far we should push the envelope of congenital cardiac surgery. As congenital heart surgeons, we are sort of almost hardwired into trying to bring every patient to this so-called normal biventricular circulation where we have two ventricles pumping into the two different circuits, the systemic and the pulmonary artery circuit. And when you actually look at what exactly is a normal, healthy biventricular heart, we need to fit all these criteria. And as congenital cardiac surgeons, we try to push every patient into finally achieving all these criteria, having atrioventricular and ventricular arterial concordance with normally functioning inflow and outflow valves, and more importantly, having both systolic as well as diastolic normal functions. And last is important, that these hearts, because you're operating at a young age, should have an ability to maintain normal growth and function as they grow. And this is the sort of target end result for all repairs for congenital heart disease. That's the aim. And so in trying to achieve this, we do not always achieve the end result. And in many situations, these are the sort of end results that we would have with the repairs that we do. Ideal, of course, is a biventricular heart with the left ventricle as systemic ventricle. The next option is to have a biventricular heart with the right ventricle as systemic ventricle. Failing that, we may achieve a 1.5 ventricle repair with the left ventricle as a systemic ventricle, or alternatively with the right ventricle as systemic ventricle. And then the sort of less favored is a univentricular pathway, achieving a Fontan circulation. And of course, the worst subgroup is where we cannot achieve any form of repair, and we leave them with some sort of a definitive palliation, which may be a systemic pulmonary shunt or a pulmonary shunt or a pulmonary artery band. And if you look at the long-term survival, as you go down this pathway, the long-term survival for these patients keeps declining, the worst being, as I said, the ones which do not have a repair at all. And this also fits in with the sort of hazard ratio for mortality in these subgroup of patients. If you look at this chart, the best patients are the ones who have a good biventricular repair, like the simple ASDs and ventricular septal defects. And down the line, the patients with the Fontan circulation have a hazard ratio of 20 times that of the normal population. And also, if you look at some of the end-stage treatment modalities like heart transplantation, which many of these would end up with, if you look at patients who have a biventricular heart with a left ventricular systemic ventricle, they have the potential for the best survival and the least complication following a heart transplant, vis-a-vis patients who have a single ventricle situation, where the hazard ratio for survival after a heart transplant is again much high. So again, going to indicate that as far as possible, the ideal situation, even if you have to have a late failure, is to have a patient with a left ventricle as a systemic ventricle. And so over course of time, although the Fontan circulation, the Fontan operation has improved considerably in terms of survival and late complications, but the perceived dismal late deterioration of the Fontan circulation, it pushes surgeons into trying to achieve a biventricular heart with preferably a left ventricle, despite the technical challenges and the multiple operations that may be involved. And this really is the question of testing the limits of the biventricular repair. And this didn't start recently. It started way back with the advent of the arterial switch operation, when initially the atrial switch operation sort of became well established as a treatment for transposition, but it left the right ventricle as a systemic ventricle, and then the push towards the anatomical switch, so that the physiological repair was thrown out of the books and the anatomical arterial switch became the gold standard. And this extended then on to patients with corrected transposition, ventricular septal defect, and pulmonary stenosis, where the Fontan was a much simpler operation with very low early risk, vis-a-vis the complex double switch, including intracardiac routing of the left ventricle to the aorta, doing atrial switch, and then an extracardiac conduit from the RV to PA, a much more complicated operation, but it very soon picked up and pushed the Fontan out of the treatment pathway for this condition. But then all patients are suitable for a biventricular repair, and there are many hurdles to trying to achieve a straightforward biventricular repair. The ventricles may be hypoplastic or borderline in function. The ventricular-arterial connections may be discordant, and the VSD may be remote, precluding a direct connection. There may be straddling atrioventricular valves. There can be complex venous connections, like in heterotaxy syndromes. and also a common AV valve with unbalanced ventricles. And these are situations where biventricular repair may not be achievable, at least in one stage. And therefore, here is a question of a choice between a complex biventricular repair vis-a-vis a univentricular pathway. But on the other hand, also, not every patient is a candidate for a univentricular pathway, because we all know that for a Fontan procedure, we need to meet certain criteria. So let the situations, look at the situations where there is a left ventricle, but it is not adequate to do a primary biventricular repair. And this may be a regressed left ventricle, which is anatomically normal, but functionally not normal, like in case of a late transposition. You can have a borderline left ventricular hypoplasia, which is common in patients with critical aortic stenosis or hypoplastic left heart syndrome, or in a situation unbalanced AVSD. Or lastly, where there is extremely severe left ventricular hypoplasia associated with mitral atresia, and these are situations where biventricular repair is an absolute no-no, and these patients have no choice but to go down a univentricular pathway. So in solution is somewhat relatively simpler in a normal LV which is regressed, as in a transposition with intact ventricular septum presenting late. And in this situation, time immemorial, this has been a pathway where the left ventricle is prepared prior to doing an arterial switch operation, or it can be prepared after doing an arterial switch operation with the use of mechanical support. And this was published way back in 1989 by the Boston Children's Group. And from our own institution, we had also published our initial experience showing the effect of or the value of serial echocardiography in channeling these patients down this pathway of retraining the left ventricle rapidly and performing an arterial switch. And we were very happy that we could convert these patients into a successful biventricular repair with left ventricle as a systemic ventricle. But lo and behold, was this the ideal operation? 20 years down the line, some of these patients now have a left ventricle which looks like this. So obviously something which we thought theoretically was an ideal procedure down the line proves not to be so ideal. When you look at hypoplastic left ventricles associated with critical aortic stenosis, again then the choice whether to do a primary biventricular repair, or are these patients going to fail a biventricular repair? And there are many, many echocardiographic criteria which have evolved over course of time to try and predict the survival chances following a primary biventricular repair in patients with critical aortic stenosis with a borderline left ventricle. Needless to say that in the long term, many of these so-called successful biventricular repairs also end up in late left ventricular failure. And this has been extended even to fetal life, to try and predict in the fetus as to see which left ventricle might go down the pathway of a univentricular heart and which will go into a biventricular heart. And then went on to trying to convert these patients from a univentricular to a biventricular heart by trying to do a fetal aortic balloon valvotomy. And this was one of the initial procedures, which is now slowly gaining ground, so that some of these patients who might intrauterine progress to a hypoplastic left heart syndrome might actually improve their left ventricles and achieve a biventricular repair postnatally. And then for the last challenge remains in patients with hypoplastic left heart syndrome. Traditionally, the Norwood procedure going down onto a Fontan palliation has been the established mode of treatment for these patients, and with time, the results with this have substantially improved, and many patients lead a fairly reasonably good life in Fontan palliation. But then now there's a push towards trying to recruit some of these left ventricles and trying to convert these patients through a complex series of operations into a biventricular heart. And this is again spearheaded by the Boston group. And you can see that the procedures involved in trying to recruit these left ventricles are quite substantial. You need to do a complex aortic valve commissurotomy and repair, a complex mitral valve repair, and then many of these patients have significant endocardial fibroelastosis, so an extensive procedure to remove this fibroelastic endocardium through multiple stages of procedures in trying to recruit these left ventricles. But at the end of all these procedures, not all of them succeed. Third of these patients actually progress to a biventricular repair, and through their studies, they have managed to realize that unless you achieve a left ventricular end diastolic volume of more than 30 ml per meter squared, or if end of these staging procedures you end up with an LVEDP of more than 13, then these patients will fail a biventricular repair. So situations where a patient would have done fairly well with a straightforward univentricular repair, at the end of all these complex procedures, you have a patient who has significant pulmonary hypertension or a patient who does not survive the surgery. Yet again, another push. If you can't maintain that left ventricle as a systemic ventricle, let's use the right ventricle as a systemic ventricle. So 20 years ago, the Senning procedure was damned because you left the right ventricle as a systemic ventricle. But now you're quite happy to do a complex operation because these patients have unseptatable hearts. You do a biventricular repair having the right ventricle as a systemic ventricle. So in this complex situation, this is the procedure that has been described. It's the patient with a heterotaxy, unbalanced AV canal with a hypoplastic left ventricle and a TAPVC. So the procedure involves repair of the TAPVC, intracardiac baffling, doing a ventricular septation, and then finally a left ventricle to a pulmonary artery conduit. The question is, how are these patients going to do further down the line? Yet another condition, transposition ventricular septal defect with a left ventricular outflow tract, who are fairly good candidates for a single ventricle palliation, but then we have these multiple complex procedures involving root translocations, a double root translocation, moving the pulmonary root backward, the aortic root backward to the left ventricular outflow tract, or doing a complete half-turned truncal switch operation in which you take off the entire aorta and pulmonary artery block, rotate it 180 degrees and reimplant it. Extremely challenging and complex procedures, all aimed at trying to achieve a biventricular repair, but with absolutely no information available as of today as to how they're going to do in the long term. And what happens when these repairs start failing? You juggle between one system to the other system. So if a systemic left ventricle starts failing, you try and convert it into a systemic right ventricle. If a Fontan starts failing, you try and convert it back to a systemic left ventricle, ultimately trying to avoid this final common pathway that all these patients ultimately, when they fail, they become candidates only for a heart or a heart-lung transplantation. And this again then is a question of testing the limits of biventricular repair. So we knew in the beginning that patients who had a Senning operation and started failing, that they could be converted back into an arterial switch by retraining the left ventricle. And this was described initially by my mentor, Roger Mee, and initial series of patients. But not all of these patients could be successfully converted into an arterial switch operation. Yet another more coming now is the switchback operation. So a patient with an arterial switch operation has a failing aortic valve, which was initially the pulmonary valve, and then you go back and you take out that pulmonary valve and put it back in the aortic position, doing a so-called switchback operation. Patients with an unbalanced AV canal who have been pushed down the single ventricle pathway, then again these patients are picked up, and if the left ventricle seems sort of recruitable, then this again is the Boston Children experience, that they can be reconverted back into a biventricular circulation. And then now people are talking about what are the considerations for biventricular conversion of the Fontan circulation. Should it be done electively or only for a failing Fontan? And then what is the feasibility? But then again, we have to come back to the same question, that we are doing all this because we perceive that the Fontan circulation is a bad circulation, that eventually all these patients will fail. So we must try and achieve, no matter what happens or how complex the procedure, try and achieve a biventricular repair. But then even in a condition like corrected transposition, where we know that the Fontan is technically a simpler procedure as compared to the other complex biventricular procedures, the long-term survival has shown that the patients who have had a Fontan circulation in this subset have the best survival, not just in terms of survival, but also in terms of preservation of the ventricular function. So 20 years down the line, whatever theories we proposed 20 years back, with follow-up, we are sort of being shown that this is probably not the right track to follow. And this is just a simple case which was a commentary by Baluddin, who commented on the paper from Boston Children's where they were aggressively trying to convert biventricle. And this was just a case report to show how these children can really suffer during this process. And this is, I'll read this out because the child was born with borderline left ventricle, mitral and aortic valves. He underwent first stage palliation followed by a Glenn. Before the Fontan, he was considered for a biventricular conversion. Subsequently, he underwent 3 operations towards achieving this goal. These entailed atrial septal defect closure, takedown of the DKS septal myectomy, resection of the endocardial fibroelastosis, aortic commissurotomy, ascending aorta patch, mitral valve repair followed by replacement, pulmonary artery patch, and takedown of the Glenn with the superior vena cava patch. Although the size of the left-sided structures at that point seemed adequate and systolic function was normal, his recovery was prolonged and complicated. Invasive and non-invasive studies demonstrated significant diastolic dysfunction and pulmonary hypertension that improved over a few months, allowing hospital discharge. Nevertheless, he was readmitted 2 months later with heart failure and diastolic dysfunction. Despite the challenges of mechanical support in patients with diastolic dysfunction, he had left and right ventricular assist device implantation due to evolving end organ failure. While clinically improved, his transplant waiting time was long due to sensitization, and he developed embolic complications and subsequently died. So the question is aggressively pursuing biventricular repair always the right pathway? So my take-home message is that when dealing with complex congenital heart disease, the dilemma for the surgeon, as I mentioned, is deciding between a low-risk operation with poor long-term prognosis and a riskier operation with better long-term prognosis, within quotes. In many situations, what seems theoretically better turns out not to be so, as we have more long-term follow-up data. And while restoring anatomy is desirable, one must remember that physiology does not always follow anatomy. And probably a shorter life of a better quality may be better than an attempted longer life with poor quality. Thank you very much.
Sir, the take-home message is really appreciable. Sir, one doubt I have, like how do we convince the parents when such a case comes down, and what is the time factor you spend, and how would the parents get convinced on this? That's what I would like to know, sir.
Essentially, only the parents who will argue with you are those who are Google savvy. So they may have read a lot of things on Google and then try to pressurize you into trying to do something. So ultimately the question is that first of all you have to convince yourself that this is the right path to take, and once you are convinced yourself that it should be relatively easy to try and convince the patient as to what pathway to take. So as I mentioned, there are 2 aspects to this, and you have to also consider that in our own setting, whether a family can afford multiple reoperations, can they afford the sort of ICU care or the ICU stay that many of these patients will entail. These are questions which are very different in our scenario and our setting. And so these are challenging procedures. So even a question of trying to retrain the left ventricle in a regressed ventricle in a transposition, are you going to be better off doing an atrial switch with a pulmonary artery band, which is a much simpler procedure, than trying to do a 2-stage arterial switch or a switch with ECMO support, etc.
Okay.
Thank you very much, sir. I'm sure all of you here will agree with me that the take-home message which sir has posted, he must have typed that in 20 seconds, but it must have taken him a lifetime to assemble all that. And it is very true. I don't disagree at all. Thank you very much, sir. Shall we, any questions? Shall we proceed with the next speaker, Dr. Debashish Das?
Yeah, okay. Morning, everybody. First of all, thanks to Dr. Gaurav and Dr. Bhupesh for giving me this opportunity to speak in front of this august audience. My job has been more or less made very simple by, we actually realized by Dr. Iyer sir's presentation as to the sheer amount of complexity involved in decision making as well as the technical challenges for doing a complex biventricular repair whenever we are faced with a situation of a borderline ventricle situation. So what I'm going to talk about is what is the role of advanced 3D imaging and 3D printing in congenital cardiac surgery. I have actually got, if somebody from the audiovisual teams, I've got 3 soft printed models there. I had kept it on the chairperson's desk. If they can be given to the audience for them to have a feel, these are 3 soft silicon models of 3D printed, 3 different type of DORVs. One is a Taussig being heart, which has been sort of corrected already by in a demonstration. So you can have a feel how it feels to be. Now, why do we need advanced imaging? No. So mainly we saw what is the level of complexity. The first presentation itself kind of illustrated what we deal with. So the anatomical features are very complex when we deal with complex congenital heart disease. We deal with a wide spectrum of diseases. It is also like for us, a second time, third time, even a fourth time redo situations are very common. And there is a significant amount of advantage if we use this technology for training purposes, as well as for parental counseling and education to actually explain, and if we are planning something very complex, what exactly does it entails. So this is just a very busy slide to illustrate as to this is the level. So we have got multiple classifications to deal with. We have got multiple different varieties of the same pathology to deal with. The echo imaging planes are severe. The cardiologist will come and tell you this is completely routable. When we cardioplegia and open the heart, it's a different situation. And there are also sort of different baffles to be planned, in which some of them in systemic, some of them in venous pathways. So, where gradients can actually lead to significant consequences. And the sheer complexity of the entire situation entails that there should be a technology which enables us better. So there is a paradox, we live in a 3-dimensional world. Our eyes have a stereoscopic vision. We see everything in 3D. However, most of the imaging that we use is basically a 2D imaging. And that is why we need to use a lot of imagination when we plan anything which is relatively slightly more complex. And for people who are starting off, I think even normal repairs would actually entail a significant amount of imagination. What 3D printing does, 3D, not exactly printing, the 3D imaging does is it simplifies this entire process. It obviates the need to mentally reconstruct these images. And it has been shown in sort of some preliminary studies that this entire process can actually be mentally draining. It leads to a higher amount of time during the operation and has a potential to increase complication. Is there any way that we can reduce this? And that is where this continuum of, there are certain terms that we need to understand when we talk about 3D imaging. So there is virtual reality, there is augmented reality, mixed reality, and when we actually physically print these models, these are 3D printed hearts. So a virtual reality world is where you are completely disconnected from your real world and you're only interacting, seeing the image. In an augmented reality, you have the option, you're still connected with your physical environment where you're present, whether it is the operating room or your discussion room with the cardiologist. And in a mixed reality model, you can actually interact with that model. So you can cut it into pieces, you can get inside the heart, you can look at the VSD from the LV side, from the RV side, and then take a call. And when you actually use a 3D printer to print this, that is what is 3D printing. So this is basically a continuum of terms which is used. The core of it is again an image acquisition. The image acquisition is basically most commonly a CT scan, sometimes an MRI, very rarely a 3D echo. That forms the basis for the image acquisition, which is then 3D rendered by a advanced software. And then you can either sort of not print it, because that is again sort of has its own challenges, or use a virtual reality model to see it, or use an augmented reality model to actually interact with it in various planes and understand the imaging better. So there is a process through which this goes. When we go down the printing pathway, it is basically first created in meshes and layers, and then further layers are added. The entire thing is checked whether it is actually representing what we are going to print, and then goes into a printer, which takes some time to actually recreate that particular patient's heart with the same amount of whatever is the pathology, whatever is the dimensions are accurately represented on that model. And So you require like devices like headsets, controllers, base stations, where you can manipulate these images. And it is a synthetic world, but it is a safe world where you can interact, you can use it to train people, to make other people understand. And also now there is a provision to add haptic systems into it, which can actually give you the tactile feedback as to what is the consistency of that tissue where you're dealing with. So I visited the VR lab in Amrita, and this is sort of Dr. Mahesh, who is a pediatric cardiologist, explaining to me a recent sort of complex DORV that they did in a dextrocardia situation. And I actually wore the headset and got inside the heart and had in the pre-op image, we could understand how the repair was planned. So it is very much possible. And as I said, when we advance it to the next level, you can use a mixed reality model where we interact with handheld devices, and you can cut it into pieces, have a look from either side. You can see the distance between, so let's say you want to see the exact distance between the tricuspid valve and the pulmonary valve to see how your baffle will look like. And you can actually do this well in advance before your surgery. But obviously these three modalities, virtual reality, mixed reality, compared with 3D printing are three different modalities. So when we print, there is a cost involved. So there is an initial setup where you'll require a printer, where you'll require sort of recurring cost of maintaining it and printing it. It is also a single time use, like these models that you saw are actually printed. You can't sort of change it or anything. Whereas in a soft model where it is VR or AR, you can go into the model repeatedly. It is less costly and probably has a wider applicability, because I don't think everybody will be able to have a 3D printer at their disposal. And I explained to you, so the core is a DICOM image. It then goes into a file format which is compatible with printing. It is then uploaded to the printer, and then you have various materials. So most of the Indian companies that print here in India do not have these soft material for print. What you saw in your hands is actually a soft silicon model, which represents the tissues fairly accurately. Whereas most of the 3D printers that we have are actually hard printers, where there is a resin which prints into a harder models, which is very accurately representative, but you cannot actually sort of suture it or anything to gain training. So the applications are endless. In clinical situations, we can have surgical decision making and planning based on it. We can have a surgical simulation sessions, as well as sometimes these in future, they will be used to tailor make your baffles, tailor make your individual. Let's say you require a contoured patch to do a DORV repair for LV to aorta tunneling, and you can actually print it beforehand, tailor made to that particular patient. You can print AV valves tailor made to that patient, and you can use it for a variety of training purposes, also for patient and family education. So this is an actual picture of a 3D printer that I took from the Amrita's lab. There, and you can print virtually. There is a transposition which is preoperative and then post-op. There is an AVSD, there is an HLHS which is printed. And all these models can be printed. If you have that silicon material available, it would be costly, but it represents it fairly well. So especially in complex biventricular situations, where situations are borderline, when people sort of are mainly embarking on it after having sort of done the baseline work in congenital heart surgery, that is when it kind of aids them. Sometimes in a very complex redo sternotomies, you actually can know what is lying underneath the sternum in a fairly accurate manner. We had a session in our Pediatric Cardiac Society meeting, so you can see Dr. Devaguru, Dr. Rajesh Sharma training our residents on complex DORV repairs on these 3D printed models. And you can have tailor-made patches, tailor-made valves for that particular patient using 3D printing technology, which will come in future. So the future is more or less already here. And the advantage is now you have something called as Microsoft HoloLens, in which a mentor and a mentee can wear this device and then interact with that image in a manner that you don't need to be in the same room. So this is one of the craniofacial surgeries in which the mentor was at a different station, and he was guiding somebody remotely using a Microsoft HoloLens and guided the entire surgery through that. So this is what it looks like. So in a mixed reality model, you have this headset, you haven't opened up the patient, you again revisit your image, you flip over your headset and then start operating. You need to revisit your image, you just have to wear the headset back, understand what exactly the pre-op anatomy, and then go back. It sounds a little bit more sort of futuristic, but these technologies are actually being used, and they'll have progressively increasing usage. Is there a need for it? Do we need to do this fancy stuff? Is there an evidence that it helps? There is some soft evidence that it does. And this evidence will keep on increasing as more data is accumulated. So there is a patient who underwent multiple VSD closures surgically, then with a device, and still had a significant residual shunt. This is a report in JACC in which they finally used a virtual reality model to plan it better and ultimately could get rid of the shunt. There are other reports also in literature in which they have used 3D modeling for guiding pediatric cardiothoracic interventions as well as surgery. This is a paper from India, it was published in World Journal from a Mumbai center, in which there are 5 different varieties of DORVs in which they printed those hearts and then planned the surgery. 4 of them ended up getting complex biventricular repairs with good results using this enabling technology. So this is sort of not that something very exotic. This is a report from Mumbai. And a very simple situation. So we deal with, so you have LSVC draining into an unroofed coronary sinus, and often this is associated with other complex things. You have a common AVSD with it, or a complex sort of TET canal situation along with it. And so this is a printed model in which what they have done is, you have printed it. Now there are options that you can mobilize the entire LSVC and then connect it directly, or you can put a conduit, or you can baffle it through the roof or through the floor. Now, this is a seemingly simple situation. All of us have dealt with it. But for a person who is starting off, maybe if he knows it before, which is the best option, like in this, they chose the option 3 and routed it intra-atrially through the roof of the LA. So these situations can actually enable persons more in a preoperatively, they can make them more prepared to take on this when they start off. So this is, and this we recorded in our hospital when the workshop was going on. So this is, in fact, one of these models is what I circulated. So this is a Taussig being hard with an aortic arch repair, which is being, and the trainer is actually remotely sitting somewhere in Canada and then guiding our trainees through do this. And the sutures, you can actually use suture it to the actual material like you would do in normal surgery. The dimensions are accurate because they're actually coming from the CT scan of the patient. So it has immense usage. These are again pictures from the DORV workshop that we conducted. And another thing is using it as a teaching aid. So in this model, you can sort of split open the heart in various parts. You can sort of use it to train sort of surgical trainees, to even sort of medical students, to make them understand the inside of the heart in a manner which was not accessible before. So these are far more better ways to tell somebody to understand how the heart looks like from inside, especially in medical education. But obviously, like any other technology, it has got its own limitation. A printer costs around $3,000 to $5,000. There is an immense amount of software cost. There is a maintenance cost. Some of these soft models would take as long as 7 days to print because it's a slow printing method. Then not always they can represent the image very well. So there is an effect of blood pooling where you're not able to capture your finer things like papillary muscles, the AV valves, semilunar valves very well. Integration of haptic feedback, it is theoretically there, but whether it actually represents what we would encounter when we are suturing it, it is very difficult to say, and it also sort of escalates the cost hugely. Depth perception and sort of in an AR model and reality can also be slightly tricky till somebody gets used to it. However, to conclude, I think this is a technology which is here to stay. So I think although it is costly at the moment, like mobile phone technology, the usage will dictate whether it becomes accessible to all of us or not. It has a potential to be used as a training tool. Complex repairs can be planned much better. And I think this is mainly a very important tool to flatten the steepness of learning curve in complex CHD repairs. And there is a soft evidence also, and it will keep on increasing as we have more data, that it does reduce the complication rate, the operative times in planning repairs, which are a little bit more complex than our usual variety of cases. So we as surgeons, I don't think we should shy away from this technology saying that it is too exotic. The more we use it, the cost is going to come down and it will contribute to its further advancement. There is a very good review article in Frontiers which actually describes, this is from the Sick Kids group who have been sort of spearheading it for quite some time as to what is 3D modeling and printing in CHD about. There are some Indian companies which actually, so like most of us don't have access to a 3D printer, but there are companies you can contact and they will sort of take the CT scan from you and then print it for you and give it to you for a cost. Thank you for your attention.
This is not a comment. First of all, let me thank you for this topic.
Thank you, sir.
For some strange reasons, I was involved in a project with Dr. K.M. Cherian.
Right, sir.
He has got 1,000 odd hearts from Dr. Saroja Bharati
Yes, sir.
lying with him in Chennai, in Gummedi Pundi, one place.
Yes, sir. I've visited and seen,
Yeah,
sir.
and he involved me. Don't ask me why he involved me.
Sir.
So he involved me in the project of 3D imaging heart specimens.
Right.
And I am told that CT scan or MRI of heart specimens is not possible. I don't know whether, because
Sir,
the top radiologist of Mumbai, Dr. Jhankaria, who is very much involved in cardiac imaging, told me categorically it just cannot be done. So we got hold of a company in Mumbai,
Right, sir.
which expertises in 3D printing for ornaments and statues, etc. And with the help of that company, we did do a 3D imaging of hearts from thanks to KM Pathology Department, Dr. Kinnared's
Right, sir.
Kinnared's stock. But for some technical reasons, we are held up, not allowed to enter Gummedi
So these
Pundi.
morphological specimens are now printed into a 3D model.
3D
right?
image, because for future generations,
Yes.
sir rightly wants those 1,000 hearts to be converted into
More reliable, right?
more reliable 3D
Which will
images.
stay forever.
And the company says that if we acquire adequate images, we can do cutting, whatever method you want. From echocardiographer, how
Yes.
it will look like. From a cardiac surgeon point of view, when the surgeon enters from RA, how the picture will look like. From PA, how the picture will look like. So it is just as you rightly said, acquiring image. Because they are using standard scanners
Yes.
with standard light.
Yes, sir.
The important part, for the same project, a foreign company had quoted $8,000 per specimen. While
Sure, I
this
can
company,
imagine. It's
by
much.
stretch, I purposely told them to quote more. Not my cut, just told them to cut more,
Right.
quote more. Still it comes to 5,000 rupees per heart. So from
Right.
$8,000 per heart,
It becomes,
and initially we have a project of scanning 100 hearts,
right, sir.
but is held up in some technical problem. So just for,
So currently these models
sir.
are expensive. Those models that you saw, if you consider that they were shipped from Canada, one model cost
posing
around
this question
30,000.
was not to tell you that I am involved with the project.
No.
It was pleasure staying with sir in his house and
Yes, I could never actually imagine that you could replicate a
yeah.
morphological
No,
specimen
my
into a
point
model.
was, will it really help cardiac surgeons, pediatric cardiac surgeons, or cardiac pathologists, or echocardiographer, if these specimens are 3D imaged?
Yes, sir, I think it will, because sir, you can interact with it in a much better fashion. Otherwise, these are sort of preserved specimens. They're very friable. They've been there for ages. You can't actually hold them, get inside them. Where if you have a replication by a model, you can print multiple models. People can interact. They can help it to understand much better. Sir.
But
So,
for imaging, we have to open them.
yes.
They are already opened
Right.
by the pathologists.
So I didn't know that you can actually sort of from a specimen you can acquire this image.
Yeah,
From a
so-
live patient, yes.
So we have achieved, and I got those images
good,
with
sir.
me right now
Will be very good to
in
know.
my mobile.
Right.
So
Why is this not a project that IACTS can take up?
Yes, I mean, it's
why
a
not?
food for thought. Yeah, I think so.
no, the problem is held up at the curator level.
Sir,
Sorry?
This is not brought to the notice of IACTS, sir. It was only.
No, who says that? I never said.
We would have taken initiative definitely, sir.
No, the problem is at the level of curator of the place.
Yes.
So that curator refuses, prevents us from even entering the place.
Okay.
So the problem is at different level.
Right,
But
sir.
meanwhile, I am very happy to inform you
Right,
that
sir.
if somebody
No,
has a
this is-
project that at a cost of 5,000 rupees, and believe me, this is by stretching 5,000, it can be even brought down. 5,000 rupees per specimen, a 3D image, not printing, 3D image can be
generated.
acquired by us. Sorry? Yeah. I have told KM pathology department the same problem is going to happen. Incidentally, we had to search for cardiac pathologists who can describe cardiac pathology specimens. And we found none. I had to take help of Dr. Shukla to get somebody from Vellore. We search. So I just the sad realization that cardiac pathologists who can describe cardiac morphology accurately are just not available in the country.
So this can be taken forward, sir. Let me, I think with this
Sure,
I'll
sir.
take an initiative. I can request Dr. Anderson to pitch in and also help us to make this reporting.
Problem is at the level of the curator.
No, let me
Enter
take it
the
forward.
place is the problem. That's otherwise we have achieved the technology.
No, that's very
and
good to know, sir.
And this is, believe me, we just spent half an hour in scanning. So if we spend little more time, proper lighting, proper everything,
It'll be even better.
we may even able to get a better image. But I have got the photographs. I will be
I'll
too keen to
take
show
it
you
from-
and
yes, sir.
take your help for
Yes, sir,
any
absolutely.
future extension of the project.
Sure, you can break it.
Break the heart. So break somebody's heart. Yes.
If you can't find a cardiac pathologist, who better can do that is a practicing cardiac pediatric surgeon.
Exactly. That is why finally Sir said, Dr. Cherian said that finally we will start describing
I think that's
the
what
hearts.
we should do. because-
Exactly. But this is not a question of describing one heart. There are 1,000 hearts. And Sir also rightly felt that if a cardiac pathologist of repute describes them, the value of that reporting will be obviously a little more. So,
Right, sir.
no, my point was about the scanning technique.
yes, sir. I'll see the
Simple
images from
scanners
you.
which are used for scanning ornaments. And this company expertises in ornament designing, statue making, and whatnot, 3D printing. So they were very keen. They offered very concessional rates. They came without charge to Chennai. We made to Gumedi Pundi, only to come back with a closed door.
Thank you. Thank you, sir.
The curator refuses. Curator is Sarasa Bharati, 90-year-old sister of Saroja Bharati. And she says, you cannot enter this place. You can't touch these hearts. So we asked her, madam, in a very polite manner, that what will happen to these in future? After 5 years from now, 10 years from now, 1,000 hearts, there are 66 jars. Level of my waste will go waste. Each jar has got around 10 to 15 hearts packed, and variety of hearts. There is no cataloging. There is no cataloging of these hearts. So we just wanted to make a beginning of first 100 hearts
And print them.
get an image, so we can cut it in any manner we want. So right from cardiac pathologist to echocardiographer to cardiac surgeon,
Yes, sir.
anybody can access these and see the inside the heart the way he or she desires.
It will be a very useful
Yeah.
resource, sir.
Thank you very much.
Thank you, sir.
Yeah, shall we, thank you very much, Dr. Debashish. Shall we move on to the next speaker, please? Dr. Sudesh Prabhu.
May I also request Dr. Vinayak Shukla to please come on the dais? Yes, we have sufficient, so the... And Dr. Agrawal, please come. Yes. You don't need an audio. Audio you need. So audio is also.
Then after that, video.
Yes, yes. Video will run. Just
I'm Sudesh. I work in Narayana Hridayalaya, and I'm talking on interventional extracardiac Fontan. Okay, there is no conflict of interest, and this interventional Fontan, it's not a new thing. It is already existing. The first article being published in 1996, but now over the years, over the last 20 years, it is getting evolved to a more safer and more universal application. So these are the initial 4 publications from Europe and from Canada, which initially explained, but all of the procedure had a conduit which was intracardiac conduit, and they had the issues with arrhythmias, the intracardiac thrombus and shunts, right to left shunt even after the Fontan completion, leading to multiple reintervention in the form of devices. So the intervention extracardiac Fontan, this was the concept of Professor Tom Call, which we published in World Journal in 2017. So then it later evolved to the present state, and these are the next 2 articles which got published again in World Journal, one by us and one by the South American team, where we worked together actually. So when with the current state, the ease is compared to the initial Fontans, the ease is better. There is universal application that any cardiac anatomy, including the juxtaposed atrial appendages or a CCTJ with the extremely small right atrium, also we can perform this procedure. So, and during the stage 1, there will be decreased CPB time and myocardial ischemia time, and so this can be done even in the absence of a radiofrequency probe by just using an electrocautery. So today in this 15 minutes, I'll be talking about what is interventional extracardiac Fontan and its advantages, the preparatory stage in the form of a video, the interventional stage in the form of a video, and mostly, if time permits, our results. So it is a bidirectional Glenn shunt performed along with the conduit anastomosis for the Fontan completion, with the pericardial dam separating the superior and inferior vena cava system, and completion is done via a cardiac catheterization procedure. So it will avoid a reduced sternotomy, CPB, and all the complications associated with this. So after the first procedure, so once we do the stage 1, we will have a Glenn circulation, physiologically a Glenn circulation, but anatomically there is already a conduit present for a future completion. And in the stage 2, all we do is we perforate the membrane which was put, and put a covered stent separating the heart from the systemic venous circulation. So the preparatory stage, this got, so there is a video. I will directly start the video. So it is. No, actually video is opened here, it's not coming there.
Okay, ये अपना साइड से.
Start from point 2. I like for it to be enlarged.
View, we see the dominant morphology,
Okay, I'll directly
the
start from
tricuspid valve straddle and override.
So the conduit preparation, it has a voice in it.
After sternotomy, a measured length of the PTFE tube graft is doubly inverted to expose the inner surface of the conduit, approximately 1.5 centimeters from the pulmonary arterial end of the conduit. An appropriate size Hegar's dilator is used as a scaffold for the conduit to facilitate suturing the patch. An untreated autologous pericardial patch with the smooth surface facing the IVC is sutured to this end of the tube using 6-0 PTFE continuous sutures separating the SVC and IVC circulation. The conduit is re-inverted so that the patch goes inside. Stable cardiopulmonary bypass is established. The next step of the operation is the right glen anastomosis. The right SVC is dissected and mobilized. The azygous vein is ligated in continuity. The right SVC is transected at the appropriate level and the RA end of the SVC is sutured in 2 layers. The glen anastomosis is then performed in a conventional fashion with 7-O-proline continuous sutures. The left SVC is mobilized in a similar manner and the cardiac end of the SVC is sutured in 2 layers. The PDA is dissected, looped and ligated. The left glen anastomosis is performed in a similar manner. Antegrade pulmonary blood flow is interrupted. The IVC is dissected all around and transected. The RA end of the IVC is sutured in 2 layers. An oval opening is made on one side of the PTFE tube, measuring approximately 1.5 times the cross-sectional area of the IVC. The IVC is then anastomosed to the conduit such that the pericardial dam lies towards the pulmonary arterial end. This anastomosis is performed using 6-0 PTFE continuous sutures. We prefer to do this anastomosis in an open fashion using a sucker in the hepatic IVC. After completion of this anastomosis, the IVC is recannulated and is snugged. The PA anastomosis is performed to the undersurface of the RPA using 6-0 PTFE continuous sutures. Following this, the aorta is cross-clamped and root cardioplegia is administered. The RA is opened adjacent to the conduit fenestration and held apart with stay sutures. Atrial septectomy is performed. The opening made on the lateral surface of the conduit is then anastomosed to the right atriotomy using 6-0 PTFE continuous sutures. To enable identification of the site of deployment of the stent as part of second stage completion, 2 radio-opaque markers can be placed to mark the site for future covered stent placement. The heart is de-aired and the cross clamp is released. The patient is subsequently weaned off cardiopulmonary bypass. At the end of this operation, we have bilateral bidirectional Glenn shunts with the preparatory Fontan circuit and the IVC draining into the RA through the lateral opening in the conduit.
Presentation.
Just close this and go back to your presentation.
I think there is next video immediately actually. So effectively after this stage 1, we physiologically have a Glenn circulation and anatomically we have a Fontan. So for a cardiac surgeon who routinely does a Fontan, the stage 1 is nothing different. Actually there is one extra side-to-side anastomosis between the right atrium and the conduit. So then usually we prefer to do the completion after 1.5 years. So this is the video on the completion. Again the after that there is an interrupted thing.
Extracardiac Fontan comprises of 4 key steps consisting of femoral and jugular venous access, perforation of the membrane within the conduit separating the superior and inferior caval venous systems, balloon dilatation of the membrane, and finally, deployment of a covered stent to complete the Fontan circulation. We use a 7 French sheath in the right femoral vein and a 6 French sheath in the right internal jugular vein for procedural access. Right femoral arterial access is obtained for invasive blood pressure monitoring. Baseline hemodynamics and pulmonary artery pressures are obtained. The pigtail catheter is advanced from the RSVC to the LPA. Contrast injection demonstrates well-opacified, good-sized branch pulmonary arteries with normal arborization. The MPA stump and the partition between the superior and inferior caval venous systems created as part of the preparatory extracardiac conduit is also seen. The pigtail catheter is passed from the IVC and advanced to the mid portion of the conduit. Contrast injection demonstrates flow across the surgically created fenestration into the common atrium, the well-contractile single ventricle, and flow across the aorta with no regurgitation or stenosis of importance. Simultaneous injection in the right bidirectional glen and in the extracardiac conduit in close proximity to the pericardial membrane shows the site of the pericardial membrane, the confluent good-sized branch pulmonary arteries with no focal stenosis and good arborization. A transseptal puncture sheath is passed from the right femoral vein to the inferior vena cava and passed below the membrane of the conduit. Through the sheath, a Brockenborough needle is passed with the tip just below the membrane. The needle position and the puncture site are confirmed by simultaneous injections into the glen and the IVC in 2 planes. To perforate the pericardial membrane, we use a standard electrocautery which is applied to the needle externally and the membrane is perforated under fluoroscopic guidance. The cautery is set at 70 watts in fulguration mode and the perforation happens by coagulative necrosis. The entry into the pulmonary artery is confirmed by the pressure waveform and injection through the needle. The tip of the Brockenborough needle shows the coagulative effect of the cautery on the pericardial membrane, which uses the physics principle of action of points. An 032 thermo wire is then advanced through the Brockenborough needle into the right glen and retrieved through the right IJV sheath using a 35 mm gooseneck snare. This is then exchanged for an Amplatzer stiff wire using a multipurpose catheter. A 14 by 50 Z-med balloon is then used to dilate the punctured membrane between the Fontan conduit and the RPA. This is the most crucial step as there can be an acute desaturation because the SVC blood will take the path of least resistance to the common atrium via the conduit. To prevent hemodynamic compromise, we have a balloon ready to occlude the perforated membrane via the SVC. If there is acute desaturation, a 12 by 4 tie-shack balloon is passed through the IJV and kept inflated until we have advanced our Mullen sheath from the femoral axis. Common atrial pressure is simultaneously increased by the use of Trendelenburg position and a fluid bolus. This was not needed in our case. A covered stent is passed through the Mullen sheath and positioned across the conduit from above the membrane to below the lower end of the fenestration, making sure to stay above the hepatic vein IVC junction. The Mullen sheath is then withdrawn. The balloon expandable covered stent is then deployed, followed by post-dilatation to achieve optimal apposition of the stent with the conduit. Post-deployment angiogram shows the IVC draining into the pulmonary circulation through the Fontan conduit, separating both the systemic and pulmonary venous pathways with unobstructed hepatic venous drainage into the IVC and a completely sealed off fenestration to the common atrium. If indicated, a fenestration can be created in the covered stent prior to crimping, similar to a surgically fenestrated Fontan operation.
So give a perspective, our cardiologists take around 20 minutes for the entire Fontan completion. That is the time I take for painting and draping of a reduced sternotomy patient. So, and extra time which I take during a Glenn procedure to prepare the stage 1 is around 20 minutes of CPB time extra and around 20 minutes of cross clamp time extra. So I work for 40 extra minutes during the stage 1, and the completion will be done in a cath lab in less than 20 minutes by our cardiologists. Now they have actually become experienced in this particular procedure. So advantages is it avoids the sternal re-entry and the morbidity and the mortality associated with it, avoids the CPB and the cross clamp time during the completion, reduces the in-hospital stay. In all the completed procedure, we are yet to have a pleural effusion patient, and better than than doing a primary Fontan. For example, if a patient of a 15-year-old comes for a primary Fontan, this gives a better outcome just because the hospital stay, the morbidity, mortality, everything is low. And the financial benefit to the healthcare system is obviously present, as most of us know that a Fontan patient gets admitted, and the length of the hospital stay is very prolonged because of the recurrent pleural effusion and associated things. The cost in our hospital for the stage 1 will be around like combined will be in Indian rupees, it will come around 6 lakhs for the stage 1 and the stage 2. In this, the most expensive thing in the stage 2 is the stent. Because of the COVID, there was unavailability of the stent. So now we have one Gujarat-based stent company which provides stent for around $1,800 like when converted to Indian rupees. So, and this particular technique can be used for taking down of a surgically failing Fontan. So we can just put a membrane and convert, and as we know that 50% of the failed Fontan can get a re-Fontan, and the completion can be done again in the cath lab whenever they get fit for the re-Fontan. Thank you. I won't be able to tell the results. Thanks.
Thank you. It was a very interesting presentation. Do you have any long-term data on these procedures?
The first of this procedure was done in Brisbane, who is doing good actually, and in Narayana we have done around actually across 4 centers in the world we have crossed around 40 stage 1s. There are no mortalities in the first 40, and all are doing good. In Narayana we have completed 8 with no mortality, no complication, no pleural effusion, average hospital stay of around 5 days, and first 6 we intubated and did the procedure. The last 2 procedure we are not even intubating the patient. We are doing under sedation and local anesthesia. And so the first patient, the 2017 article which was published, that was completed in around 2015. We published the article around 1.5 years later. So the longest follow-up is that patient of 9 years now.
Okay, that's a wonderful job done. Any comments and questions from the audience?
Sir, actually at present we are taking 4 years or 12 kilo. Right. I am not supporting any industry here, but sure. Now some PECA people are providing us a expandable graft. So I actually spoke to our boss, telling that we have to buy that so that we can do it in a smaller weight also, because these grafts, if they can get expanded, I can use a 14 graft for a say 2-year-old right. baby with 8mm branch PS.
All right. Thank you. That's what I wanted to know, because there'll be smaller babies.
No, we have
if
not done it, but I'm planning to do it, because I yesterday only saw everything outside, so I was like going through their catalog. Then I was like, okay, this we should use.
Thank you. Very interesting presentation. Thank you.
Thank you.
Okay. Thank you. Can we now invite Dr. Tushar? He's going to show us with very interesting videos how to enlarge the aortic root in different situations.
So, good morning, and thank you, Gaurav, for inviting me to talk on this topic. Since morning we are talking about newer techniques, I'm going back to the olden days technique. And so it's part 2 of this conference. 2 days back I spoke about root enlargement technique in adults. This is the important article about the anatomy of aortic root, which has described wonderfully the anatomy. I am just going to show you, it's a repetition but still a harvested heart. I am going to show you the anatomy, how it looks. This is the harvested heart, which was actually taken for homograft bank, but it was not suitable because of HbSAg positive. To make exposure better, I am cutting the heart aorta between commissure of left and right coronary commissure and right coronary artery, and by retracting leaflets, there are 3 right coronary cusps, left and non. That is the septum anteriorly, and posteriorly there is the anterior mitral leaflet, which covers almost of 2/3 of left coronary cusp and 2/3 of non-coronary cusp. The corner where my forceps is going to be the membranous septum, that is the anterior mitral leaflet. The area between anterior mitral leaflet, that is the annulus, and the aortic wall is subaortic curtain. So this anatomy is helpful for posterior root enlargement. Now in that corner is the right fibrous trigon, and just beneath the commissure of non and right coronary cusp commissure is the membranous septum. So relationship of that membranous septum with conduction tissue and in relation with the tricuspid wall, it is related to the anteroseptal commissure of the tricuspid wall. So that is subaortic curtain, what I was showing. And now their white structure is the membranous septum, and that is the membranous septum. Beneath that is going to be the conduction tissue. When I illuminate it from right atrium, it looks like illuminated body, and it is in relation with the anteroseptal commissure of tricuspid wall, and the area is torus aorticus. So going back to the today's topic, why anomalies, or there is an arch anomaly associated with congenital aortic stenosis. So there are multiple techniques. Posterior root enlargement technique, mostly used in adult, and anterior root enlargement technique, which are used in pediatrics, that can be used even in adults also. One more procedure I'm going to, whatever is the demarcated red area, I'm going to talk about today, and special mention will be there for that inverted Y procedure, which can be used even in pediatrics. So these are some of the posterior root enlargement technique classically described. The most important and common surgical procedure which is done is conoraston aortoventriculoplasty. It is the anterior aortoventriculoplasty used for congenital aortic stenosis. It relieves both subannular, supraannular, and the annular narrowing. So this is a short video. Similar specimen, I have just cut open the aorta between commissure and the right coronary artery. So you cut, the first layer comes above is the right ventricular outflow tract. So once you open that, that is the right ventricular outflow tract. So once you open the right ventricular outflow tract, you are going to see beneath is the infundibular septum. And you see very close, pulmonary wall is very close. So if you go near commissure, you are going to damage pulmonary wall. So you have to remain in center and cut the infundibular septum. And you can see there is a, so this is what after cutting the infundibular septum it looks. Use a Gore-Tex patch to close the VST. Secure both the corners. Take a generous sheet of pericardium. So after you have sized and taken a generous patch of pericardium, folded in between and sutured with the wall in the anterior aspect. So wall is in position, and you cover that folded pericardial patch to cover the aorta anteriorly, and the lower fold you can use to cover for RVOT incision. So this is a standard coronarastan or the anterior aortoventriculoplasty. It looks like this, very simple procedure and good hemodynamics. So the technical tips are, you go exactly between the left and right coronary commissure and right coronary artery. If you deviate from either of these places, either you damage pulmonary valve or you distort the right coronary artery. Conduction tissue is far away from the area, so conduction is not going to come unless you cut the posterior limb of trabecular septum marginalis where muscle of Lance's is attached. So that is the landmark. Folded pericardium is best and can be used extensively. The pitfalls of these techniques are, there is no lack of growth potential, need for anticoagulation, and there are issues with smaller child, infants and smaller children. So the answer for them is Ross conical reconstruction. It gives a radical solution for multiple level LVOT obstruction. There is a growth potential as well. It does not require any anticoagulation and useful for infants and smaller children. This is a small video of Ross cono procedure. So here aorta and bicaval cannulation. Aorta is, the fat on the aorta is taken down till the coronary ostia. The aorta, after giving antegrade cardioplegia, the aorta is opened. Most of these patients are having subaortic stenosis as well. Create two coronary buttons. This is the right coronary button. Then excise the wall. There will be some amount of subaortic fibrosis or narrowing with infundibular or the LV muscle bundles. So you peel off the fibrosis from the septum using spatula or forceps. Do Morris procedure, extensive resection of LVOT. Now prepare a pulmonary autograft. So open the pulmonary artery just before bifurcation. Insert a right angle and take a good amount of infundibular RVOT muscle. Look for the LAD, which is very close. Now important thing is dissection on posterior aspect. You go at least 5 mm below the pulmonary wall and do excision of the graft in the posterior aspect obliquely to avoid the first septal perforator. So you do oblique cutting of the muscle and try to cauterize or put a glue on the area exposed. Try suturing the graft into the posterior aspect. Once it is secured there, remove excess amount of tissue from the annulus, and if required you can extend the incision into the ventricular septum, create a VSD if there is associated LVOT obstruction there. Try to cut off the muscle. This is if you create a VSD, it is going to be a Ross cono procedure, and if you just resect the muscles without creating a VSD, that is going to be a modified Ross cono. So finish the suturing part on the anterior aspect, take some interrupted sutures in between and secure doubly. Once anastomosis is done, create a punch hole for the left coronary button. Now start, after finishing that, do the distal anastomosis, posterior aspect. you stop halfway and then make a hole for the right coronary button. So once your button suturing is over, finish the anterior aspect of distal anastomosis. If there is a discrepancy, you can make a cut into the ascending aorta and complete the suturing part. Now RV outflow tract can be reconstructed using homograft or contegra graft. So do distal anastomosis first and then perform the proximal anastomosis. If it is, you can use same pulmonary autograft with RV muscle to close the VSD in conorastan, or you can use a separate patch to close the VSD. There is another modification, that is modified Roscono procedure, where you just excise the muscle, don't create VSD. This is also called a mini Roscono. It looks like this. The limitations are of this Roscono procedure is there is a progressive autograft regurgitation, aortic root dilatation, multiple reoperations, and there will be a late autograft failure. So to avoid that, Murin has used a subcoronary Roscono procedure, where the pulmonary autograft is fashioned in such a way and it is used inside the aorta itself. Aorta is going to be the native tissue outside and it's going to support, so it avoids dilatation of the autograft. And this technique was primarily used by Martin Misfield for adult patients, and it was popularized in pediatric by Murin as a subcoronary technique. So here you trim the aortic pulmonary autograft in a scalloped fashion and leave at least 3 to 5 millimeter margin on either side. The lower end is sutured inside the LVOT using interrupted sutures with pericardial felt in between, and upper part is sutured in a scallop fashion without cutting the coronary buttons. So you have to align that. If there is significant LVOT obstruction, it can be augmented by additional creating a VSD and closing a VSD patch, and if there is supravalvular narrowing, then you can use another patch into the non-coronary cusp to augment the aorta. So this has given a optimal autograft function, stable aortic root dimension. There will be no specific complication attached with this approach. I would like to mention about this inverted Y technique, which was primarily used for adult patients, and it was popularized by Yang. And here the conventional incision is used for Menogian procedure is taken, and the incision is extended beneath the annulus in the subaortic curtain in non-coronary cusp and left coronary cusp area up to the trigons, and this can use a rectangular patch of that big size, and then it can be used for augmenting the aortic root. This is a small video of that inverted Y technique, which was popularized by Bo Yang. So here the aorta is opened. This actually video is of adult patient, but can be used for grown-up child where they don't have subaortic stenosis. So this incision is going to extend it into the commissure between left and non-coronary cusp. Then in subaortic area, you extend that incision up to the left fibrous trigon, and on the right side up to the right fibrous trigon. Once this area is opened up, you measure the distance with the forceps, take a patch. Here the Dacron patch was used, but pericardium also can be used. Continue that same patch suturing towards the right fibrous trigon. bring up the suturing up to the cut of edge of aorta where you started dipping in. Fix them. Continue on the other side, same way. Then you size the aortic area. When you are putting a sizer, mark the posterior area with the marker pen to place your sutures in the annulus. Once you put sutures in the annulus, mostly use non-pledgeted sutures or a pledgeted suture with pledget facing ventricle. Try to secure the transition area of aorta and the patch. Just 1 or 2 slides are there. So once sutures are in, place the valve. It looks like this. So once you fix the valve, suture that patch further up till your aortotomy, initial aortotomy incision. You have to trim a patch according to the size required afterwards. So ultimately it will look like this. This procedure can be used for grown-up child where there is no subaortic obstruction and only annulus level narrowing is there. So these are some tailored strategy for infants and children. Thank you. You can increase size up to 3 to 4 size bigger with this technique.
So what in your case, what size?
This was the adult case. I borrowed the video, and this case had 29 size valve.
In a small kid,
yes.
what you?
Yeah, 27 size. Sorry, 27 size valve it was. It was not for small kid. This was for adult. You can use even 21 valve or 19 valve for kid also. Can be used this technique.
Any other comment from the?
Thank you.
Excellent presentation.
Thank you, sirs. We come to the end of the first session. May I now request our moderators, Dr. Vinayak Shukla and Dr. Agarwal, to hand over the mementos to our speakers. May I request Dr. Iyer, Dr. Debashish, Dr. Sudesh and Dr. Trushar to please come on stage. Dr. Iyer, sir.
May I also request my co-chairpersons, Dr. Shaunak and Dr. Amit, also to come to the podium and grace the occasion.
Dr. Iyer. Please stay on, sir, for a group photograph. Dr. Sudesh? Sudesh, okay. Dr. Trisha. Come this side.
Sudesh is not around.
Sudesh?
Thank you.
Thank you, sirs. We take a short 5-minute tea break and then we start again with the second session. Thank you. One of the 3D models that was in circulation has gone missing. So, we'll be grateful if that can be handed over to the rightful owner, Dr. Debashish. If anyone has found the 3D model which has gone missing, kindly hand it over to Dr. Debashish. and Dr. Hiremat to please come on the dais to moderate the next session.
Good morning, everybody. We had a very interesting and session this morning on pediatric surgery. Now we move on to a plenary session, open house on the future of cardiac surgery, the way ahead in healthcare and policies of the Government of India. The future of cardiac surgery is expected to be driven by advancements in technology, including robotic surgery, minimally invasive surgery, and the use of artificial intelligence and machine learning. These advances are likely to lead to improved patient outcomes, reduced hospital stays, and decreased healthcare costs. In terms of the way ahead in healthcare, there is a growing emphasis on the preventive care, early detection, and personalized medicine. With the use of wearable technology and health apps, now patients are becoming more involved in their own health care. So the healthcare providers are shifting towards more patient-centered approach. As per the government policies in India, the government has been working towards increasing access to the healthcare services, especially to marginalized communities. The Government of India has launched Ayushman Bharat in 2018, which aims to provide free healthcare for over 500 million population. The government also promoting the use of digital health technologies and telemedicine to improve the access in healthcare in remote areas. With this background, we have 5 eminent speakers going to talk you on the medical education policies, Government of India, Dr. Minu Bajpai, the group practice in cardiothoracic surgery, Dr. Vivek Javali, the NGOs and cardiac surgery, Dr. Surpreet Chopra, and Varun Guntur is going to talk on wide skills for cardiac surgeon, and Dr. Bhaskar Rao will talk on entrepreneurship for cardiac surgery. So now I request Dr. Minu Bajpai to give his first talk on medical education policies of Government of India.
Good morning. Thank you, Chairman. I would like to once again thank the members of the organizing committee of IACTS to invite me here today. I'll quickly move. Dr. Lokeshwar Sajja has already outlined some of the policies of the Government of India in facilitating healthcare. So at the outset, I would like to say there are 2 systems working in our country for postgraduate education. One is the National Medical Commission, which is a single system as far as the regulatory body for the National Board is concerned. The National Board conducts NEET examination, which is the entrance for the PG courses for National Medical Commission also. And then it gives about 2/3 of the seats to the NMC, which then goes to a large number of medical colleges, which are private as well as government. The 1/3 seats are kept by the National Board, which has hospitals under it, both government and private, but 2/3 are private hospitals. That's where the strength is. And so with these words, next slide please. I bring greetings from Dr. Abhijat Sheth, President of the National Board of Examination in Medical Science in India. Incidentally, he's traveling to USA, and in Philadelphia 2 days back he met his counterpart, the President of the National Board of the USA, you will soon realize that the modus operandi of National Board in India and the American National Board is identical. And that's some of the strengths that we bring in with that. So I'll talk about some initial years as far as the policies are concerned, major changes which have happened, which pertain to today, National Medical Commission, mostly about the current trajectories of the National Board of Examination in Medical Sciences, which its growth, its response to national needs, how we are addressing the specialist deficiency, how we are adapting to technology and the requirements at the ground level with the changing scenario. Remember, our health education is not under the Ministry of Education, it's Ministry of Health. So we have to keep our ears close to the ground about the needs and then navigate ourselves. And how we would improve the monitoring and imparting of training and its overall national impact. So I'll quickly go through these. So we, Ayurveda, have been the gold standard once upon a time. Modern medical education became in vogue with colonial era. 1835 is the recorded Calcutta Medical College of the allopathic type. 1916, the Medical Council Act was passed, it was changed, introduced in 2019, and the Gazette notification came in September of 2022, which is of NMC today. Again, it has gone a minor modification. The basic principles of medical education are two and revolve around others like patient-centered care, community engagement, holistic education, universal access, evidence-based practice, and continuous learning. These are the basic citadels. The key changes which NMC brought about were implementation of the national exit test, which is likely to happen from next year. It will be a single test where post MBBS, there will be a single test, rank them, and accordingly they will be given the seats, no second test for PG entrance. Introduction of the medical college assessment and rating has been another hallmark change which NMC brought about to improvise functioning. Introduction of the teacher eligibility qualification, replacing diplomas with certificate courses. They have removed fellowship and diplomas from their ambit. It has been there with the National Board and it has increased very gallopingly faster. It has many, many merits. Through diplomas, quickly let me tell you, we've been able to reach out to district hospitals. We have introduced in-service and sponsored candidate reservations to those people who have been working as MBBS doctors in district hospitals. They get priority and it has led to, in short, a significant improvement in infant mortality and maternal mortality rates. There is objective evidence to prove this. So National Board, what could be the future? It started off in 1975 as a working group by the then Prime Minister. Subsequently, it was given an autonomous status in 1982 and we moved to our building headquarters in the Dwarka. Currently, we have 13,000, the latest figures are 13,000 plus PG seats every year. As I mentioned earlier, we have government hospital and private hospital. If you see the slide very clearly, 2/3 are the private hospitals where our work area is. If you look at the course-wise breakup of NBMS seats, we have broad specialties, we have super specialties. Earlier DNB name was for both, but now we call it doctorate in National Board like MCH and DN. And to differentiate fellowships, diplomas, and post-diploma PGs also, PDCET. Now, as I said, that there has been a constant dynamic environment there based upon the projection by the national scientific organizations like IACTS, and similarly there are 100 boards. They ask for fellowship courses. We look at the data and when we are convinced, our board clears it. So 14 new courses were launched last year during our foundation day by the very dynamic health minister currently. Let me tell you, Dr. Mansukh Mandaviya ji, he came to, the first time a health minister had come to our board, he was there full day to listen to the issues. This is how ears should be at the ground to see what is required of the nation. We are very encouraged by these gestures. Notably, if you see, geriatric medicine was introduced. Our population is expanding at both ends. The elderly population beyond 65 years constitutes 6.8% of the 1.4 billion. 30 years ago, the population was 90 crore and the number of 65 plus was 3.3. Imagine the quantum. It's a good sign of, a high sign of good health for our country, but it brings challenges for the courses and all. We have introduced a 6-year course in emergency medicine, keeping that in mind. Critical care medicine has been there and we have increasing the seats. And so I'll tell you more what we are doing in that direction. Now, this is our minister during our foundation day. The next foundation day is in the middle of May, and we are introducing another 14 or 15 courses. Now, if you look at this data, the bars, in 2016, the number of PG seats every year contributed by National Board were 4,500, which has now increased to so much, almost 13,000. In fact, the current figures are 13,500 with the current results which have come up. This has led Niti Aayog to ask us to increase this to 25,000 per year. And because obviously they said that we have the flexibility to do it. And so we came to the drawing board to look at what holds us and what can be done. To accredit a hospital for a specialty board program, for a PG program, there are three criteria. One is that there should be enough number of beds and the load. Number two would be case mix. Each specialty has a spectrum of index cases and all. And thirdly, teacher eligibility criteria. When we looked into this, we realized that of the 70,000 hospitals in the country, the base of the iceberg is never participating. They may be missing in one or the other criteria. And as a result of this, huge amount of clinical material in our country remains untapped. Each bed is a teacher, and that is not being factored in. So on the drawing board, we looked deeper into it, and we realized if we come up with joint accreditation, allowing two hospitals to club their resources and we do externship, suddenly these will be participating. So as a conservative measure to begin with cautiously, we realized we've made flexible our policy. We started seeing changes, and this is the equitable distribution. In fact, if you see at the last part of the curve is steeply rising. The numbers are 3,000 in 1 year only. PG seats have increased. This is how the country's equitable distribution of hospital where DNB is present. Government is making a lot of efforts. We need a denominator. MBBS is a denominator. Unless that number increases, how can we have PGs? Currently, the ratio is less than 2:1. In America, it is 1:1. Every developed country would have a large number of specialists. So we need to increase that. We proposed to the minister, requested him that we can also consider private hospital for MBBS. They don't have pre and paraclinical, but we can support them through our medical colleges, through a tripartite agreement. So the college, pre and paramedical will be provided by the hospitals, the medical colleges, and the hospital space can be used for MBBS, for which he asked me to National Board to make a presentation to the CEOs of private hospitals and corporate hospitals within the ministry, within a week of our foundation day. And they were very receptive about it. So private hospitals are likely to have MBBS courses very soon, which will improve the denominator, and that will increase the numerator as well. So this is a figure. With the 70,000 hospitals, if we even begin with 10% of them, the number will be 7,000. So with 1,300 hospitals today and 13,000 PG seats today, if we have 7,000 hospitals, the number will be 75,000 PG seats added to the mainstream. And if we have 20% of them, we have 1.5 lakh PGs every year. And this will add to the existing numbers. So this is what will happen. So this is, I thought I will bring to your notice, because it has huge repercussions. Each one of us is affected by it, and we'll see that. Dr. Lokeshwar just mentioned about the technological advances which is happening in all fields. Major reconstruction replaced by minimally invasive surgery. In pediatric surgery, I used to do gastrocystoplasty, harvesting stomach on a right gastroepiploic artery, taking it to the urinary bladder to augment it with a long incision. I'm now using laparoscope, 3 ports only, to harvest this, bring it there. Imagine how much things have changed. And as surgeons, we have to adapt. Renal vascular hypertension, many years ago, angioplasty is not order of the day, although it only caters to 60% of the stenosis. Difficult areas and still need either open or robotic surgery. CTVS, I don't have to tell you how much things have TAVR and total endoscopic aortic valve replacement have taken place. The wire technology is very much there. There has been a shift in post-COVID into political thinking and social thinking as to what medicine can bring to them. Just like the preventive measures which were very common for communicable diseases, people now think this should be also applied to chronic diseases. So proactively, wellness clinics, OPD-based treatment will be huge. The if you take this growing Indian hospital market, which stood at 66.7 billion in financial year 2021, which was inpatient heavy, the expected next 2 years would be 120 billion, and this is driven by the prevalence of chronic diseases, OPD-based, multi-specialty hospital-based visits. The routine bed admissions will reduce, they will be replaced by critical care admissions. And that's where we have introduced the 6-year course in emergency medicine, responding to the needs. Government has, Prime Minister Modi ji has thought about it. If you imagine, let me pause and tell you that Ayushman Bharat was introduced before COVID happened. And look at how wellness is now center stage. So there are two flagship programs which are that of Government of India. Heal in India. The people should come from across the globe to get treatment here. Heal by India. Our doctors can go. 20% of our doctors are going anytime. It's a democratic country, nobody can stop. And this number would increase because the projected impact of health economy in the globe by 2040 is $12 trillion. Center of that would be doctors. Besides the other flab, two components of that hospital industry and the devices equipment, they all will. Where would the doctors come? It is only India which can produce these numbers. And we have to believe this, and we don't have to really think rocket science. Cuba, during a period of Latin American wars, offered their doctors, because of compulsion, realized that they are bringing in foreign currency to the country. They made it a proactive way to produce more doctors and started exporting them, the word export. 1.13 crore population of Cuba get $11 billion every year as currency. If we have imagine our population of 140 crores. So how many more minutes, sir? 3 minutes, quickly. So the numbers which are required, the deficit of 10 to 15 lakh specialists in our country has to be met, otherwise we'll fall short. There'll be mass exodus. We need surplus for our country and for the export part. Elsevier, a publication house, conducted a survey and realized with the data that technology literacy will be having a supreme hand over clinical literacy, because of which we have added a DNB fellowship with the 6 IITs of India. And I'm not going to details because the bell has rung. I've talked about it. There are many areas: medicine, obs, gynae, pediatric, general. Dr. Iyer is there, and others who are interested in pediatric. Cardiotocography, which is fetal monitoring of heart, is something which is totally AI-based. This itself, AI is expected to add $967 billion to Indian economy by 2035, 500 billion to India's GDP by 2025. So if we do not immediately chip in, that's where National Board is doing now. We have already gone to the last stage. This year we will have the fellowship with the IITs. We are started the National Skills Center in Kidwai-Nagar. Within a year it will be in place. It will be a state-of-the-art simulation lab for all specialties, including CTBS, and all of you will be the teachers for that as trainers. We have started our journal because there was a call that our residents wanted to publish. So we are into the 5th issue in May. This journal is available and it will be published in the first week of every month. Please subscribe to that. It's our journal. By the middle of this year or a little later, it will be indexed. ISSN will come up early and PubMed little later. We are concerned if you have a large number of people to be trained, the curriculum and standards should be uniform and high. We have 4,500 task force members drawn from all of you, all specialty boards. Lectures, symposia, complex case scenarios are transmitted through webinars. We have opened up our lines, and we have tried to introduce, and we have gone through with TCS in 3 stages now. They are now preparing an app which is available on the smartphone through an app. The curriculum of each specialty broken into digital numbers. At the end of a round or a OT or a clinic, a resident will punch what he has learned. It is for himself and for the teachers who are taking the round. It will not be punitive, but it will be sort of indicative of what they are doing, and it will improve a lot. G20 presidency has been taken up. the Government of India, health emergencies, prevention and preparedness, strengthening cooperation in the pharmaceutical sector, digital health innovation and solutions are three citadels. We are addressing it, and I'm happy to tell you about that. Lastly, there are certain areas which Dr. Tendulkar very genuinely pointed out, and all of us are concerned about that. And let me tell you, sir, that we are including workshop on effective communication and soft and non-technical skills, which include empathy proficiency, leadership, teamwork, critical thinking, situational awareness, emotional intelligence, all this because we are treating human beings. We are adding foundation courses for legal, ethics, and a variety of quality measures which should be applied. It's not that we want to increase number and show peace. We are really doing hard and digging deep to see that the quality of product is also very high. Thank you very much.
Thank you, Dr. Bajpai. We will take the questions a little later, but it's our honor and privilege to have you on behalf of the organizing committee. And he's holding so many hats: Dean of Academics, AIMS, Professor and HOD of Pediatric Surgery, as well as Vice President of the National Board. So I think we'll be very, very obliged to you if the IACTS can liaise with you directly, sir, and have some kind of forum where we can correspond with you. I'll invite Dr. Vivek Javali, one of the doyens of cardiac surgery in India, the past president of the IACTS, to give his talk on group practice, the way forward in CVTS.
I cannot see. Oh, yeah, thanks a lot. Thank you. My group, which is practicing as a group practice, is since 1990. We just sensed that this would give us more power in the corporate sector and will give much more assured quality to the patients. But as I see today, the markets have matured, patients' expectations are high, patients are enlightened and educated. They expect current practice and quality. The corporate managers can be very bureaucratic and difficult. So the need for group practice is more today than ever in cardiac surgery, which is mostly an institutional based practice, unlike a cosmetic surgeon or an ENT surgeon. Long back in 1900, the Bill Mayo and Phil Mayo told that group practice is not a financial arrangement except for minor details, but a scientific cooperation for the welfare of the sick. At the bottom of all this, whatever I talk, you would realize that the beneficiary is the primary stakeholder, the patient. So why group practice? Better offering to the patient, business compulsions, corporatization of hospitals are also compelling us to flock together, be powerful, evolved system of healthcare functioning, teaching, education, and clinical research priorities are more effectively pursued in group arrangements. As you heard Bajpai sir just now, I think if we are going to have 75,000 post-MBBS seats in this country in private as a major chunk, I think imagine the scope for a group practicing cardiac surgeons in training areas. A SWOT of CVT surgery, strengths, weaknesses, threats and opportunities. Strengths, increasing techniques and technologies, increasing clinical sharpness, rising numbers and consolidation of interventional cardiac surgeons. We saw a few weeks back a proper association being formed, and it will only rise in strength. Rising number of CT surgeons owning cath labs and hospitals. Weaknesses are crisis of trained manpower at junior level, indiscriminate PCIs, weakening of the gatekeeping role, weakening position vis-a-vis the managements and industry. Lack of unity despite of all the above, and that's one of the major threat. Opportunities are improved and improving infrastructures, maturing markets. It's actually an opportunity, because then you don't have to really sit down and explain and try to convert. Rise of focused subspecialty societies and training, which is making our practice only more standard and more sharp. Threats are dwindling enthusiasm for career in CVT surgery, which requires a lot of attention from the government. Curricula have to be changed because the technologies are changing, and also the incentives have to be looked at it very seriously. Otherwise, we will have a tremendous glut in the surgeons coming for cardiac surgery. Assertions of corporates and cardiologists, medico-legal threats, prying media, growing acceptance of PCIs by patients, Many newer technologies not covered by insurance and schemes. How to convert a weakness to strength and a threat to opportunity is left to common sense. But if you sit down tight as a group and do your homework, I think we will come to understand a lot of jugaad that all this can be done. The strength, weakness to strength and threats to opportunities. Group practice, converting the weaknesses to strengths and converting threats to, and that can give us a kind of a roadmap. But in a group practice, those things are more low-hanging fruit than high-hanging. Advantages for surgeons, stronger clinical services, round the clock, common incentives to grow businesses, defensive strategy to retain portion of revenue stream and or preempt competition. We as a group can decide who will come in the hospital because we may not have a good MICS, we may not have a good transplant guys. We could decide and not leave it to the managers. And that's actually good for the hospital, good for the patient, and good for the doctors. Control new recruitment, that's what I meant. New delivering model for the community, mechanism for innovative care management and delivery programs, enhancement in personal life quality, which is, I think, a very important aspect. I see surgeons starting early morning and going home midnight. If you are a group, then your quality of life will jump by leaps and bounds. Enhancement in, enhanced negotiational capability, possibility of academic growth. For the institution, of course, smoother services, easier consultant handling. I see my senior managers, their entire day goes in clinician engagement and firefighting with the senior clinicians who are threatening to leave. Efficient use of infrastructure. If there is a fragmentation, 5 surgeons fighting with each other, the infrastructures are always hogged, not efficiently used, which is a big problem for the hospitals. All this will vanish, zero. A counter to unhealthy practices. Can pave the way for joint ventures, smarter training programs, enhanced possibility of research and publications, enhanced positioning for branding and PR. For the community and the referring doctors, stronger round-the-clock senior cover, improved clinical care, improved OPD attention, improved patient satisfaction, easier relation management for the referring doctors. In the planning process, planning and deal execution are key to developing a sustainable partnership. So all the homework should be done, including legal, and the hospital managers, if they understand what we're talking, they're actually smarter than us in business management. So they also can sit down with us. The hospital lawyers can sit down with us. We really don't have to pay them. Otherwise, the lawyers can charge whatever they feel like. So with this kind of inputs, we can create a good planning and deal education. Preparation should encompass assessment of objectives, business planning feasibility, review of structuring options, including legal risk and reimbursement analysis. The reimbursement analysis can be different depending on one surgeon could be very senior and the entire practice could be on his back, or there could be equal partners like we have one team in Bangalore, or it could be any shades in between. Organization of the deal process. Critical questions are choice of partners. Then it again differs from group to group, but the most important thing is people with different subspecialty. Maybe people from different zones of that state who could bring different chunk of practices, etc., etc. Alternative options, financial feasibility, capital building, who will do what, and timeline for implementation. If we take care of all these things in planning, the planning would be perfect. What are the models? Whether to form a company, because closing a company again is a big headache. Proprietary, partnership, or private limited company. So first, whether to form a company at all on paper or not, or just keep it a loose federal arrangement. And if we do that, then one of the 3 models. Single specialty, or have an anesthetist or cardiologist involved. In the beginning, when I started my group, I had involved them. But then I thought I realized it was a baggage, and we shared that excess baggage. It is just cardiac surgeons. But what is important is that, do you want to get the PAs? Do you want to get some select smart nurses in your group? because otherwise they will be exposed to the bureaucracy of the hospital, and some of these horses and asses, horses are very few. These horses we do not want to lose the competition. So it may be a good idea to absorb these horses in the group. One leader or equal partners or a ladder. We could choose one of them depending on what kind of group it is. Employees by the group or employees by the hospital. In the beginning I thought the troublemaking area is money. So we decided this is the corpus, and we had a very good amicable relationship with the hospital management. I said these are the percentages, and the check comes directly. Check doesn't come to me, and the hospital will deal all the financial arrangements. So any grumbling, etc., can be dealt with directly financial department. That kind of reduces the friction. Employees by the group or the hospital, should the group employ PAs and select nurses? Legal issues, medical legal responsibilities, insurance, NMC handling if you are having teaching. I mean, who will do what, or somebody can just be on that handling NMC or handling all the other things. Contracts, legal consultation, and corporate lawyers. Most of the time, if it's a big hospital, if we have good relationship with the management, we really don't even have to pay for the lawyers. Reimbursement analysis, partners and employees, or partners versus employees. Reimbursement pathways. Considerations are exclusivity. Like somebody wants to live, then do we have any exclusivity clause, non-competition clause? We can take those legal advices and protect the group's interest. Because otherwise, sometimes the managers could be a little crafty in a corporate setup. Growth maps and incentives. Subspecialties, which is very important today, that we create a flock of subspecialists so that there are many sharp swords into one, and the patient gets the best deal from this group. The retirement and post-retirement paths. A surgeon who is going older, he may get into more robotic, where he is more comfortable, physically less harassed, and or he could become the person who is gaining businesses, traveling for CMEs, etc., and also kind of create a link between all the partners. He could take different roles. He really doesn't have to retire. And there are so many things that we could do with that kind of thought processes. Behavioral rules, penalty causes, dress code. Cardiac surgeons are a little cut above, and we should behave like one. And so we have these kind of rules. Meetings, clinical, social. Should social families be brought at all in this professional group? It's very different from group to group, but we could evolve from clear-cut professional to a social mix. And there are some anesthesia groups, vast anesthesia groups across country. They have really shown what a good role model can be. For especially in Pune, there is a group, they have shown what a good role model it can be for group practice. Performance criteria, baseline performance assessment, contribution to the business development. People can span across the state, maybe 4 or 5 parts, and bring in businesses from various parts of the state. The quantitative and qualitative. Then structuring, the qualitative could also mean academic. Academic papers and other areas are the softest but most elegant ways of branding and kind of advancing your brand of the group. Structuring of incentives. All this homework could keep a great clarity and viability and longevity of the group. Financial terms, incentive compensation. Achievement of new quality goals. So annually create goals and their qualities, and then how do we achieve, put a plan in action, targets. Contribution to growth in businesses, new program developments, and achievement of goals. Say for example, the group can decide that every year we would achieve 4 new procedures. And then we could fan out and we could say you do this, and then how do you do that? Go to the best in the world, watch, learn, come back, start doing, call that person for doing a workshop. That workshop also enhances branding, gets more patients from the referring doctors. There are so many ways of skinning the cat. Achievement, and also achievement of academic goals. Future perspectives are business growth in more than one direction. Surgeon hospital joint venture is possible. Many times hospitals are in doldrums. we could actually allow the hospital to sublet the entire cardiac surgical lot, OT, ICU, maybe a part of the staff we could take over. There could be a small joint venture. For example, cath lab ownership and interventions ownership. Cardiologists could do that. We could do that the same with OT ICUs. Controlling medical tourism. Otherwise, that is another very dirty area. But if we, as a group, take our own independence, not depend on the hospitals, Brian Buxton was the best example of, or even Victor Chang in the past. So we could control medical tourism by our own group, owning hospitals or departments. I won't go there, but it is possibility. If we become strong, if we become sharp, we could own departmental group practices in teaching institutions. This is private, but even in teaching institutions, if people bury their swords, bury their petty self-interests and minor interests, if they act like a group, even in a teaching department, I think that can make their life so much better. So ultimately, in the end, a major beneficiary of all this, if you think deep, is our primary stakeholder, the patient. Because whatever happens, unless it happens for him, it will not succeed. So thank you very much.
Thank you, sir. We call on the next speaker, Dr. Suprit Chopra, on NGOs and cardiac surgery. Is it sustainable?
Good morning, everybody, all the respected faculty members and students, if at all they are present here. I'm very thankful to the organizing committee for offering me to speak about this topics that is a burning topic, because we might have spoken about a lot of advances in cardiac surgery and the way forward, but unless we speak about the ground realities that the healthcare system is suffering, the ground problems that we are suffering at the ground level, and offering solutions, the CME, the symposium, would be incomplete. I would like to talk first about myself a little bit. I'm having my own NGO that I'm running in my name, and also have a few healthcare companies which are supporting this particular NGO. And what we have been doing is that this particular NGO that I have was built in 2015. We incorporated this NGO in Ministry of Corporate Affairs in 2015, which is a Section 8 company, and we have ATG and 12A certifications. Our programs are that we conduct free medical camps, and we have conducted more than 250 medical camps till date, and we have regular free OPDs, which are having cardiac consultations in community health centers and hospitals in Chhattisgarh. We have healthcare and health awareness programs and free cardiac surgeries for the underprivileged and free OPDs for the poor. We are currently associated with the Ministry of Health and Family Welfare, Government of Chhattisgarh, and are serving the underprivileged in various parts of the state. Our patrons are these particular companies, which are our own companies, and we have individual donations also coming in. We try to raise the funds from the community, and that is how we are trying to help the underprivileged of the society. Let us first talk about the ground problems in the healthcare situation right now. We have huge numbers of documented cardiac patients, cardiac disease. India is one of the countries which have the highest burdens of cardiovascular disease, and the annual numbers have risen from 2.26 million in 1990 to 4.77 million in 2020 documented. The coronary heart disease prevalence rate has been 7.4% to 13.2% in the urban population. These are the following government health insurance schemes that are running in India at national and state levels, which are helping the poor to a large extent. But I would like to talk, like we are aware that they are helping to a great extent, but I would like to talk about the problems that we are facing at the ground level within the gamut of these health insurance schemes. The problems, let me start with, is that we have formulated these national and state level schemes, but we have forgotten to talk about the cost-to-cost ratio, which has not been meticulously evaluated. We have not been, it has not been evaluated that we talk about the pathology, microbiology, biochemistry and labs, and cost of doctor remuneration, staff salaries, electricity bill, oxygen bill, consumables, sterilization charges, HR cost, all of these things, the establishment cost, the running cost, the housekeeping charge, all of this has to be, incorporated before we decide the cost of the procedures or the cost of the hospitalization. I think that has not been meticulously evaluated. Many of the common conditions, even till date, because you all have also been involved in these, like Ayushman schemes and other state level schemes, the common conditions and the procedures are not covered. The implant quality, which is within the cost range, the quality of that is doubtful. The problems in the healthcare system is that the financial literacy in doctors is poor. Not many doctors are entrepreneurs, not many doctors are financially literate. And the healthcare system is majorly guided by bureaucrats who are guided by their socialism and their populism, their activism. The majority population is below poverty line. They need free treatment. That is unquestionable. But the problem is, who is going to pay for the treatment? Who is going to pay? Is it me? Is it you? Is it the government? Who is going to pay? Because the charges have to come from somewhere. The approximate cost of one cardiac surgical unit, of one OT, is around 18 to 20 lakhs. Now we have to, these are the running charges. Now my own unit that I have, the cardiac surgical unit itself, is around 18 to 20 lakhs that I'm spending in one unit. The basic drugs that are there in the market, the generic drugs and the drugs that are there in the market is hardly any, difference in the quality. But the production to cost ratio of the drugs in the market has not been properly, it has not been properly evaluated. The drugs are capped. Now, who's going to pay for the difference? Who is going to pay? That is a very big question. Now let me talk about basically what an NGO is. An NGO is a non-profit organization. Any organization that is non-profit, it offers free service without trying to turn a profit from what it does. NGOs may advocate these wide range of social concerns, and medical aid is also one of them. The types of NGOs can be based on orientation, whether it's charitable, service, or participatory, empowering, or based on the level of operation. It can be community-based, citywide, national, or international. And what are these NGOs doing? They can either raise funds, they can offer services, or they can increase awareness. These are some laws and regulations. Now, the problems of an NGO. An NGO, we all know, is a non-governmental entity which is involved in global development, aid, and philanthropy. They have a definite mission, a goal that they have to achieve for the society. And through these bodies, they promote social welfare. Now, the problem is that they require aids, they require funding from various cradles, and they're dependent on private donation sources or memberships, and regardless of being an independent body, many of them are dependent on governmental funding and aid to function effortlessly. As non-profits, NGOs hunt for several funding sources, including memberships, private aids, sales of goods and amenities, grants from other non-profits, or government funding from NGOs, for NGOs, and sometimes CSRs. According to the Government of India report, India has right now around 50,000 registered NGOs which are registered in the FCRA. They enable citizens to work composedly and voluntarily endorse social principles and civic goals. They support community and local initiatives. Their work reflects at the grassroots levels, and they help governments achieve their health goals. Now, we all know what the NGOs have been doing all these decades, all these years. Now, we have to have a different outlook altogether if we want to go ahead in the healthcare system, if we want that the healthcare system should survive. Now, what are those different kind of roles? Now, those different kind of roles are based on the current problems that we are facing. The number one role that we have to have is awareness. Awareness of what? Awareness of the governments, awareness of the society, that these super specialty surgeons are basically an asset to the population. We are saving a multi-million-dollar healthcare system by creating cardiac surgical units. There was a time when people used to go abroad for cardiac surgeries. Now people can have those, state-of-the-art surgeries in our cities, in our tier 3 and tier 2 cities, which are available. All the cardiac surgical setups are available here in India. A panel to study cost effectiveness of cardiac surgery is also required. We have to plan for survival of cardiac surgical setups. NGOs have to coordinate with the government to develop cardiac centers. The government itself is unable to recruit many cardiac surgeons despite the fact that we are falling short of surgeons. They are enforcing bonds on fresh cardiac surgeons of around 3 years and 5 years based on the states they are residing in. And that is not the part of a solution. Cardiac centers, at least one, is required in each district hospital. Now, everything has to have a cost. So, providing low cost or free of cost cardiac surgery is not the part of a solution. NGOs have to help in proper auditing, proper cost accounting has to be set up in every state. In order to maintain healthcare infrastructure, at least 3 to 4% of GDP is required for healthcare. Now today we are blindly creating medical colleges and hospitals without any facility or soul. Last 1 year, 150 medical colleges have come up which do not have proper infrastructure. They will continue to work till break-even is achieved, and after probably a decade or so, they'll be able to develop some cardiac setup. Number 4 is we need to represent the healthcare system. We need to represent cardiac surgical team and the whole gamut of cardiac surgical services into the health minister. Today, around 142 crore population is there, which requires cardiac surgical and some kind of a cardiac help. And prevalence of cardiac disease is increasing by leaps and bounds. Mortality benefit is definitely there, and we have known that cardiac surgery is providing mortality benefit as compared to the other interventions. Large NGOs and big bodies like IACTS itself, they have to represent our field in the health ministry. NGOs should hunt for competent surgeons that they can represent in health ministry. Another one is fundraising. NGOs should raise funds for healthcare setup. They have to propose a plan, at least for elective cardiac surgeries in distant remote areas. Some surgeons can wish to do charity, but not everybody is in a mood of charity all the time. They have to feed their families, they have to feed their own financial burdens. Another one is creating a sustainable mechanism. The NGOs have to participate in providing or helping or facilitating a mechanism, or help the government in creating a mechanism by representing cardiac surgical setups. COVID has made us realize that ventilators are required in every setup, whatever is it. But COVID has been definitely represented, but what about the cardiac surgical team? It has not been represented in the healthcare ministry properly. We need a mechanism so that we can infuse well-diversified funds into the setup. CSR should be easily available if the setups are meticulously projected. When we create a setup and we reach a break-even, the banks take around 10 to 12% interest. But when big industries approach, they are given a loan at 8.5% interest. That is the kind of discrepancy that is existing currently. This has happened to us in our setup. Creating a sustainable mechanism can be achieved by having special loan segments, and tailor-made financial schemes should be developed based on the kind of setup that is existing, whether it is an MSME or a large-scale company. Based on that, the loan schemes should be tailor-made. NGOs need to represent cardiac surgical setups at world diaspora, central government agencies, and get CSR issued to support the cardiac surgical setups. They should indulge in funding of cardiac setups, and the government should be able to capitalize on the whole manpower that is existing in the cardiac surgical setup in the country at present. And there should be proper utilization of talent and skills. IACTS also can function as an NGO. There are many surgeons who are working in many parts of the nation who are still not satisfied doing the kind of job that they are doing at present because of inferior quality infrastructure. All non-government associations can behave like NGOs, and even IACTS can behave like that. We can have group insurance schemes. Every member can have that. We can aim to provide medical care to the last member of society. This is not just to promote the cardiac surgical industry, but also to promote research work. When we talk about Make in India, we've got 5th and 6th generation aircrafts made in India at par with the world in space technology. But the most neglected part is the healthcare industry. Medical devices, equipments, all of that has not been taken into consideration as far as Make in India is concerned. Our heart-lung machines, our MRI machines, CT machines, they are not made in India. The technology is existing for the past 5 decades or so. MRI, CT, and life-saving machines are not a luxury, whereas they are incurring 12 to 18% of GST, which is a huge cost. High import duties are there on life-saving machines and equipments. NGOs should be helping in formulating a financially affordable, sustainable, and scalable model, which can help these companies of India to make these machines in India. You all are aware of the Venezuela problem. Venezuela was world's largest oil producer. It was giving healthcare and education free of cost, and the model was not worked out properly, and we all know what happened after the recession. So from taking the lesson from Venezuela, we know that we have to tailor-make policies in order to support this healthcare system. Policymakers should realize that the system is working in series, just like the adult cardiac circulation. One component is going to affect the other in the whole system. Surgeons, industry people, technocrats, social activists, they all should come together and understand that it cannot be sustainable unless all of them together jump into this industry and take the reins in their own hands. The healthcare industry is crumbling, and it cannot take the weight anymore. The free medical services are there, but they are having high GST, taxes, and import duties on life-saving devices, medical devices industries in India is not yet matured. The future of healthcare industry, if adequate measures are not taken, the big multinational companies from outside with large capital will enter. They will make us slaves to their systems again after 75 years of freedom. They will decide and influence the market rate. They will then also influence public policies. They will influence legislators through their lobbies. And now what NGOs like us and IACTS we need to do, we have to save our country from these outside forces. We should serve the world population by providing them healthcare facilities. NGOs and other big non-governmental associations should indulge in coordination. For example, UNICEF, what it is indulging in, it is providing field data to the government. It is helping it generate fund. In Chhattisgarh, what we are doing is we are having this Jan Swasth Samiti, which is a concept where public representatives, they formulate the budget for district hospitals headed by a collector. Our IACTS and NGOs of our country, we can formulate such bodies, and these bodies can then buy equipments and give them for use for a particular cardiac setup, which is just cropped up, and help them till they achieve their break even or they are financially independent, and then transfer those facilities to some other cardiac setup which requires those infrastructure. And this should be done for the purpose, not for the purpose of earning profit, but for making them sustain, making the cardiac surgical setup sustain. Now, NGO can give field data and then help in formulating mechanisms to address the health issues. They can arrange for grant, they can apply for CSR, they can convince the central government and other private industries to invest. What we at SC Heart Foundation we are doing is, we are trying to raise funds from our patrons from individuals and from other associations. We are doing free medical camps, we're giving facilities at PSCs, CSC and district hospitals. We are doing all sort of cases with our NGOs resources at government setups. We are giving field data and we are trying to help the government in formulating a mechanism. We're trying to arrange for grant, applying for CSR to support our industry. We're trying to project at the level of central government and other private industries to invest. So in order to achieve a sustainable goal of equity in health for all, I think it's very important that some of the very real decisions need to be made. Let's all do this together. Thank you so much.
Thank you, Dr. Supreet. We'll call on the next speaker, Dr. Varun, on wire skills for cardiac surgeons.
Good morning. Today's my topic is cath lab for surgeons. You mean hybrid cath lab? Yes, definitely yes. Because everyone knows out of 100 cardiac surgeons, more than 90%. Hello? Yeah. Yeah, out of 100 cardiac surgeons, more than 90 plus surgeons know how to build a cardiac unit, operation theater with proper laminas, proper infrastructure, what is particulate count, recreation time, and better quality operation theater to build. But you name 100 cardiologists, more than 90 doesn't know how to construct a cath lab, how to negotiate, what are the requisites, apart from directly doing angio or angioplasty. Why? Because they not go into the details of the infrastructure, they are more going always seeing the monitor. Nowadays people are cardiologists stopping seeing the face of the patient also. So as a surgeons, if you build a cath lab, we can do in better work in building the hybrid cath lab, which is suitable for our hybrid work also. So we can, how to make a regular cath lab. So many of the present industry like Siemens, Philips, they are promoting their top-end infrastructure with hybrid formulation and they are charging crores together. We can make a regular cath lab into hybrid with regular OT panels, one OT light and changing the channel length little bit to make it immediately we can convert any emergencies during the procedure. So we are the surgeon who can build hybrid cath lab in economy and in a better utilization manner. So before we construct the hybrid cath lab, there are so many questions which we need to discuss ourselves. No need to answer anyone. So what are the definitions, history, training, legality, and what are the supportive documents we have till now, and do we really need 1 year fellowship to get us ready for wire skills or cath skills? So many of the seniors knows, and they did before till 1990, wire skills are under our control. Later which got commercialized by other party. And 1956 Indian Medical Council Act, 70 Amendment till NMC Act, there is definitions of cardiac physician and surgeon didn't change. Nowhere claimed that they have to do, cardiologists only have to do the cath procedure and we are not eligible. Nowhere mentioned, everything studied in detail, that's why I am commenting on this point. Then training. Let us see, just compare our cardiac surgery curriculum with the various DM cardiology curriculums. We did a small research from Indian Association of Interventional Cardiac Surgeons. So this is our 6 years cardiac surgery program where we are eligible to go and work for 6 months of cardiology postings, where we have to do at least 10 cath procedures as per our log. Just compare this. This is the DNB cardiology curriculum, where out of 3 years, they posted only 8 months in cath lab. And if they do just 100 cath angiograms and 10 angioplasties, that too under supervision, they are awarding DM cardiology degree. This is from MGR University, Tamil Nadu for DM cardiology. where cardiology postings are just cath lab postings are just 6 months. If they do 50 angiograms and 10 plastics under supervision, they are awarding DM degree. This is from Sri Chitra. They are posted for 8 months, and if they do 200 angiograms and 50 plastics under supervision, they are awarding. I just posted in a cardiac surgery group, even AIMS DM cardiology curriculum also. They are posted for 6 months, I think, and 50 angiograms and angioplastics, including 50 procedures, they are awarding DM cardiology degree from AIMS. What is our question? Why can't we increase our cardiac surgery curriculum even from 6 months to 9 months of cardiology posting and change that minimum number of cath procedures that one surgical PG do 50 procedures, and then we will be definitely in legal position in discussion, in comparison, person is getting DM degree. Definitely we will be in position. And there are some other documents where we collected, say Ministry of Health and Family Welfare, TAVI should be done by a surgeon and heart teams should be supporting. We are not questioning why cardiologists are doing TAVI. So another one is GO from Uttar Pradesh, where surgeons are allowed to go and do their cath work independently. So our question is, do we really need 1 year fellowship and duration of postings, and what are the number to cross the learning curve? So as per DM cardiology curriculum itself, they are telling that if anyone do minimum 50 procedures, they pass their learning curve to become a qualified person to practice the wire skills. So so we requested our seniors how to change the curriculum and all. Yesterday we have a detailed discussion. Then once we construct the cath lab, how surgeons can make it economically viable and sustainable? If previously, if you go to the economy part, if you go to MNCs like Philips and Siemens, if you construct a 12 centimeter flat panel detector, that 5C12 model of Philips and corresponding Siemens models, it will be 4.5 crores. If you go to Make in India indigenous models, I am not quoting any companies, we can construct a comfortable, good quality hybrid cath lab within 2 crores, including basic IVS and portable echo machine. So it's definitely cost-effective model where definitely we can generate reasonable quality of economy by means of, if we have basically trained for cath skills, we can do our pre-operative cases angiograms, we can start. Once we have cath lab in hands, we can hire case-based to many of the cardiologists. Definitely initially they may not come, but definitely they will come for their cases to get it done, which will be economy generating, and we can go for more of hybrid procedures, like which we are going to discuss. And anyhow, once we have surgeon have control over cath lab, definitely that percolate into the society, and all the top end cases like TAVI cases will come for us to get it done. This is my experience in the last 6 months. And anyhow, endovascular, aortic stenting and repairs. And in between we used to have some rare procedures, peripheral vascular and SVC stenting, something like that. And definitely, as Vivek Javali sir told, we need our own clientele and own OPD maintenance. So in between we can do mass screening, out of which we can develop clientele as well as generate the cases to get our economy to go on. And once we are good with basic cath skills, doing regularly good number of angios, it's the easiest to do PTCA, which one will appreciate on their own. So let us see some hybrid cases which we did recently. This is 140 kgs person post bariatric down to 97. Post weight reduction, he had severe paralytic bilateral sciatica and almost bedridden. We did lima to LAD mix and PCA to circumflex, and he recovered very fast with minimal interventions. These kind of sick cases we can do hybrid if we have control over cath lab. Even if you have good coordinating cardiology team also, this can be done. But if you have control over this cath lab, we can generate more economy instead of sharing. And recently we did this case, skeletonized lima and radial Y mix, and lama to LAD and radial to OM. And next day, within 24 hours, we did PCI to RCA, and patient discharged on third day. And for example, if you need to do mixed valve cases, if any single vessel disease, we can do PCA if they short segment, uncomplicated lesion, and we can comfortably do the mix in the next day. And next, anyhow, TAVI, many of the respectable senior surgeons started doing and did good numbers. And in India, first TAVI done by a surgeon, everyone knows, and nearly 50,000 cases of tissue walls which are going to degenerate down the line are waiting for TAVI, which we should not miss the bus. So last 6 months in my center, we did 6 TAVIs. As surgeon having control over cath lab as doing TAVI, many of the patients are directly approaching us, and that is more cost effective. If you do 1 TAVI per month, our cath lab investment will come very soon. And anyhow, vascular work already aggressively presenting since morning. And another thing, alternate economic models are we can do in between single dual chamber pacemakers, which will generate the economy, which is in fact which are the easiest thing. We are not going in detail about EP study and complex work, basic pacemaker implantations. And this is the recently what there are some interesting cases in between. You used to get like popliteal muscle pseudoaneurysms and fibrosing mediastinitis with SVC. Videos are not playing. Okay, so that patient went everywhere, and it's very difficult to operate those fibrosing mediastinitis. What we did from left basilic vein, AL1 catheter, I placed denominator to SVC junction, take a shot, and we took 40 mm barred covered stent, and I used actually TAVI balloon. I inflated at a very higher pressure, I think I inflated at 40 atmosphere pressures, but still we are not able to open fully. But we made it almost 3 to 4 sizes. What is the stenosis, and patient symptomatically doing well last 4 months. These are the cases which will generate in between some more additional economy. And once you are once after doing 50 NGOs, definitely anyone will get that confidence in doing basic PCAs. And anyhow, we are the surgeons. If we have our control and generate 10 cases, definitely 1/3 of the cases will be the positive, and out of 3 cases, 1 will be straightforward PCA, and 2 cases we can post for CABG. This is the last case we did in IACTS workshop. One tight osteal isolated left main lesion. We did PCA. Real scary things to do, but it's easy, and one will appreciate and love to do over time. So I am presenting the one last workshop results. We did totally 169 cases. I think we did 107 cases in 5 days, followed by 3-4 days we completed remaining cases. We totally screened 320 patients, and we posted 280 patients. But we finally closed the workshop for 169 patients, out of which almost 64 cases are positive, means almost 40% of the cases are positive cases, out of which 21 for PCA and 43 for CABG. Anyhow, 15-20 cases they will go for shopping, but remaining cases will be feed for us for next few weeks. So what I want to insist in this contest, like cardiologists regularly they used to conduct mass screening, they pull the patients for their feed. Like that, surgeons also, if they have control over cath lab, they can also do these mass screenings. Definitely 1/3 will be the positive and feed for 1 or 2 months. So this is what we did recently, training. Dr. Ahmadullah sir already showed. We trained youngsters, 36 young surgeons got trained every day, on average 2 to 5 cases hands-on. So, and almost 54 surgeons attended the inauguration session on April 8th. Already we informed second hands-on wide skills program will be held on July 2023 at Mumbai. So we're requesting all your support. What I want to finalize in a nutshell, we are eligible to do the wide skills. No one is going to stop. Don't too much scare of legality. It will be there, and we are also planning indemnity legal support from IACTS for those kind of things. Anything will happen down the line. Thank you very much.
Thank you, Dr. Varun. I invite Dr. Bhaskar Rao for his talk on entrepreneurship for cardiac surgeons.
Good afternoon, everybody. So, these two are two different aspects, I feel. Respected Organizing Chairman, Dr. Bhupesh Shah, Organizing Secretary, Dr. Gaurav Goyal, the other members of the committee, and our distinguished participants. And I confess, I feel like I'm doing an adventure coming to Gujarat and speaking about entrepreneurs is like trying to teach fish how to swim. Gujarats are born entrepreneurs with the qualities of head and heart required for success. So this brief introduction, we'll go about our talk. I am Dr. Bhaskar Rao, cardiac surgeon, build KIMS hospitals. We have 4,000 beds in 14 hospitals. So, the prospects for a cardiac surgeon as an entrepreneur, the entrepreneurial journey will go on. There is nothing, not only in entrepreneurial journey, everywhere. I is the one which is killing us. If you convert that I into we, automatically everything will set right. That has to come into your mind first. That includes we means our employees, our patients, our customers, whatever we call, our investors and other stakeholders. As long as you take care of all of them, you are successful. You don't take a decision if you put on that hold, you will not be able to achieve anything. Team building, not yes. You should not be feel when you are always team, there are many people who will join with you as a yes man. If you listen to them, then you will ruin yourself. Risk tolerance, more than 50% of the units do not take off well. You may counter a lot of turbulence, persistence is the key. Don't think everything will be smooth. The smoothness you will never be able to enjoy the success. Not only you will not be really a successful person. The failures are the one which teaches a lot, provided you put it in a right direction. Ability to observe the failures. We need to have that, put a lot of analysis, why I have been failed and what is the things that I need to do. If you have that ability, definitely you will be successful. Passion for what you do. If you like what you are doing, you think about it even when you are doing, not working. Passion leads to persistency, persistency leads to success. Long-term view. Entrepreneurship is not a short-term sprint, but a long-term journey. You need to have vision for next 10 to 20 years, even more. Renovations and innovations are always be there. To adapt to changes times, to invent new techniques like what we are talking about my previous speaker. A house will not last forever. It requires renovations. Also, we have to go for new innovations. Before embarking on an entrepreneurial journey, it is necessary to have a SWOT analysis. How many people know what you mean by the SWOT analysis realistically? 1, 2, 3, 4, 5, 6. So this is the entire life lies here only. You know your strengths, you should know your weaknesses, Convert all your weaknesses into your strengths. Find out the opportunities. Convert all your threats into opportunity. That is the success story, whether you are in a profession, whether you are in an entrepreneur. The day when you do follow these things, you are definitely a successful person. It is imperative to indulge in a honest appraisal. When you want to do your strength, weakness, opportunities and threats, you should be crystal clear. There are two aspects of any personality: what you are and what you think you are. The day when your thinking may not help you to build your entrepreneurial journey. To be meaningful, SWOT analysis is the honest, realistic and rational. Don't fool yourself with the imaginary qualities or situations that what you come across. 5 mantras for successful journey as an entrepreneur. Vision, where you aspire to go when you start your seed. Mission, how you propose to go about it. Ambition is the driving force that propels you into action. Core adherence to your core concept, principles and values, notwithstanding hurdles. Attitude, it is the way you look at life and you run your life. Positive outlook, optimism, confidence arising out of your adherence to your core values, appreciation, acceptance, and above all is gratitude. It is your attitude that can make you or break you in life. If you have a positive attitude all the time, you can able to grow. If for small things you go into a negative attitude, you will never able to grow. The negative attitude has to convert into yourself as a positive attitude. Overcome that, being an analysis and everything. Entrepreneurial journey is a challenging, but rewards are plenty and fulfilling. Social recognition it will give you, self-satisfaction, you can't measure without money. Service to society, as an individual you may be able to do 20 or 30 patients a day, but in a hospital you can see more than 100 or 200 patients or 1,000 patients a day. I know what you are looking for, financial growth. Yes, it will follow. We are been educating only on two aspects, the professional growth and the financial growth. The people who go after financial growth, they will never able to get into neither finance nor the professional growth. The people who are going after professional growth, the financial growth is an incidental one. It automatically comes with you. Entrepreneurs was a politician. Who is serving the society better? I think you all know who is the better one. Entrepreneurship is a great, besides our own, you are meeting the needs of many, the society at large. That is the junction. Today we have 4,000 beds, nearly 20,000 employees are working for this organization. So we could be able to create more and more. Why do you want to be an entrepreneur? So as I mentioned about the professional growth and financial growth, make your mark in the society. These are the three important things will definitely make. As a single individual, doctor also can make all these things, but it is only multiplies, that's all. There are two different streams. A person like we are all there, able doctors who made their mark. They are also achieved, but it is only the quantity. These are the two different streams, both cannot be done by a single person. Very difficult. So professional growth, what you are expecting? You expect volumes, quality of treatment, research and subspecialization, balancing of professional and family, make a name in the nation and international level in our community. But this can be, if you're able to concentrate on your own, as a profession, you achieve these things definitely. But if you want to be both, you have to compromise certain things. That many of the people who start small nursing homes or small home, these are the things we can able to. Mixing these two, the good individual growing as a practitioner, joining with a right mindset of the entrepreneur, the financial growth will be much more than what you singly achieve. There are people who have been invested in KIMS about nearly 10 crores about in 20 years back. Can you expect how much they would get in 20 years' time? Anybody? Huh? 150. Anybody? Any other number? Huh? 300. So he got 1200 crores in 20 years. The 10 crores become 1200 crores. Even if you want to do your own, but realistically, that is a lucky for them. They invested at that time, but may not be all the time. Still, there is a chance. You can make at least 30, 40 times, provided if you're able to run very efficiently, properly, sustain the growth. Every one of the organization will definitely make money. See, basically one thing which we miss, all of us are work hard, much harder than many of the professionals in different fields. We know only how to work hard, nothing else. That's the pity of our profession. But what will happen if you're able to put it in a proper direction, in a proper manner? We can able to achieve both our professional satisfaction and as well as our financial satisfaction. The people who invested with us, they only concentrate on their profession, they reach to the level what they want. But the finance growth will be different. See, many of the hospitals, you see, there are a lot of investors who invest us. They make more money. We are working like a class 4 employees. Work hard day and night for our own small things which we looking for. This, I want to start a cath lab, we want to do TAVI, we want to do angiograms. Why? We want to do screening and all those things. For what is the purpose? Ultimately, we do all these things is to get more number of patients. Why do you want to kill yourself? Work 7 to 8 hours, spend time with family, and invest in your own organization where you are contributing. That makes the standard of growth we expect. So, of course, financial aspects, lucrative provided you will be, okay. Requirements for an internship, you should have a business knowledge, financial knowledge. Financial knowledge means CapEx, OpEx, loss funding, returns to investors. So as we said, if you understand these words, no no entrepreneur journey will never be a failure. And you also know the exit plan. There are many people who build a small nursing home, they don't know how to exit plan. By the time whatever they created, it will go on. Here in the corporate style, the exit plan is very clear. Whenever you want to cash out, you can cash out. There are so many people who build a nursing homes, their sons will not practice here, there is no legacy. So they continue to go outside, and this will have no value. So as an entrepreneur, you think less of yourself and more of others, then only you will be able to grow. Family means responsibility. Here your family becomes much bigger, your employees, your colleagues, investors, and society at large. An entrepreneur crosses the boundaries of self. He may make a living out of it, but more than that, he gives life to so many others. If you have the heart, we are at heart specialist, right? You can plunge into entrepreneurship. You see, many of the people who have been seen, Denton Cooley, from there it has been started, Doug Baird. The prospects are bright, but the journey is not a cakewalk. Be prepared for tough road, but ample rewards. You can make a difference to the society. A customer is the most important visitor in our premises. He is not dependent on us, we are dependent on him. He is not an interruption to our work, he is the purpose of it. Let us substitute a word from customer with a partner, imbibe the spirit. Thank you very much. I don't know how much I can able to impress on you.
Thank you, Dr. Bhaskara. We'll have the discussion now. Are there any questions which any of you would like to ask any of the speakers? Dr. Shukla?
I've got a very serious issue. And we are thinking of opening more seats for the training purpose for the doctors. I have a very, very serious issue that we are not getting all the seats which we have at present being occupied by trainees. So we are going to open more seats and then more vacancies. What are we going to do? At present, I'm sure all of you will join me in saying that wherever we have a training program, the trainees are not coming forward to occupy the seats. That is the first issue. And the second issue is of this 6-year course that we are opting everywhere. It has got plus points and minus points both. I want to know exactly what is the dropout rate. How many people are joining for a 6-year course and not completing the course? Because he joins after MBBS, he cannot do a circumcision properly, he's taking up a surgical specialty, and then after 2 years he gets fed up. He says, I don't want to continue this.
Dr. Shukla sir, I think Dr. Bajpai, do you think there is a attrition for cardiac surgery because there is, there's a lack of 6-year course, people have to give multiple exams to get into cardiothoracic surgery. The generation next wants to become, they want to get there earlier than what is, we say it's a passion. Like Dr. Bhaskar Rao also said, I mean, we need to really work hard, but then why is there so much of attrition, sir? I think the first question is to you, sir.
Thank you very much, Dr. Shukla. I think...
Can I answer that?
I think Dr. Bajpai can do that, sir.
Okay. See, I also have medical school. What we are talking about, we are producing the doctors more, seats are more. It's not correct.
Bajpai, sir.
I have required 20 cardiac surgeons as of now, but I could not able to get. There are degrees, but there is no stuff. Today, I can able to get last 20-year patient to me saying that I am perfect. We are not training the people. There is nothing like the moment when you get trained, you should be in a position to handle independently, which is not there. Not only in cardiac surgery, anywhere, even MBBS, there are plenty of doctors required for this country to handle. We are killing ourselves. We are doing every day 100, 200 patients by a single person. But the training is lacking, that's why people are not joining. Once you get the degree, it's not only medicine, I am telling you. Today there are plenty of people who are having degrees, not only non-medical people, but there are so many jobs are available in the organizations. There is no matching, there is no knowledge, only degrees are there. The day when we focus on knowledge side, there is no unemployment.
Can I just ask one addendum to Dr. Bajpai? That is, sir, your... So your expansion plans for the postgraduate seats are admirable, but are we tracking the healthcare infrastructure properly? Because if we look at our healthcare infrastructure numbers, somewhere last 4 to 5 years, the total hospital beds in the country are stuck at somewhere around 19 to 20 lakhs. So currently, even if you go by some speculation, our population to doctors ratio is standing at 1:800. Yes. And many of the basic level employment will go justifiably, that's a different question, will go justifiably to the Ayush level. Many of your hospital infrastructure, preventive health, Ayushman Bharat screening, I think more than 60% of the jobs will go to the Ayush level. So do you see a paradox over there that we are already at 1:800? You are trying to increase the number of doctors into the system. And if you track the infrastructure, say for the number of beds, hospitals you referred to, we are not moving much faster in terms of 20 lakh to 19 lakh hospital beds is where we are stuck for about 4 years.
So basically, first of all, thank you Dr. Shukla and Dr. Bhaskar Rao and you also about raising on the issue. You see, try to understand that NMC is a regulatory body, national board is an executing body. You can take the horse to the water. We are all stakeholders, and Dr. Bhaskar Rao and the speaker before that was very clear on this. We have to understand what our roles are. We are trying to facilitate, when I mentioned, for example, that there are 70,000 hospitals in our country, and this is the Lok Sabha figures quoted by a minister. Now, we understand when such a mapping has been carried out, there are very small hospitals, there are mid-segment hospitals, there are large corporate hospitals. Not every hospital would be a trainable hospital space.
Corporates are less than 10%.
Yeah. So corporates are huge, but there are many accredited hospitals which are not corporate, but they are participating. 100-bed plus hospitals are part of the program. Now, what I'm trying to say that we are creating a paradigm facilitating by way of MOUs or tripartite arrangement, making it easy for people who want to come and do. The horse would drink water. If we don't take the horse to the water, how will it drink? I'm trying to take an example which I think in a short time I can transmit across all of us. It addresses all of us. So we stand at a deficit of 10 to 15 lakh specialists in our country. We're short of doctors, you rightly said. How do we go about it? Now, post-COVID, one earth, one health, there'll be a seamless movement of exodus of hospital. Even if small number of doctors are there, they will go for greater pastures. If you're an economy of that kind, and that industry will give them twice the money and we'll be left with nothing. Our part of the job is to create, facilitate. Now, somebody, Dr. Shukla very rightly, he's from Vellore and we understand what it means when you talk about academics and training, just like all of us in the room know about it. That before we actually launched joint accreditation, we spent months and months on the drawing board as to how will we enable the type of training, high standards and uniformity. Let me tell you, the national board, after conducting need for National Medical Commission also, keeps only 1/4 or 1/3 of seats. These seats are with them for the next 3 years. Centrally monitored, each and everything, the logbook, the digital transmission of all the work and communications. We keep an eagle's eye. We have been doing FAT test every year, alternate years. We have gone down to the more granular level to create an app on their phone and available with Tata consultancy service costing crores of rupees, so that every boy or a girl or a student who goes through a round or a clinic or an operation said, I feel very proud that in a private Ganga hospital, I was doing private practice, now I'm a teacher. We are very proud of it. We do a lot of hard work. Eventually it will boil down to us, sir. We can, as a body, facilitate. It comes to us. And in order to keep good monitoring, to facilitate, to keep our eyes open, this app might help. If there is any other bright idea to do it, we will welcome it, sir. I think it's the right place. I found this session, last 4 talks were just brilliant. In fact, I requested one of the speakers to give it to me so that on my phone I can keep going through it and see exactly what filtered points, distilled point could be taken to the right people. So yes, I mean, if there's a better idea, if you can do something more, we are there to listen to you. Please, we are all part of it. We have a 4,500 task force. We'll make it 9,000. You will have to deliver, sir. We have to do our bits. I can only say that. Thank you so much.
Thank you, Dr. Bajpai. Dr. Bhaskar, one question to you. Would you like an equity or a debt model? Because many of the founder promoters in many of the hospitals, they go into the equity model and then you find the exit plan is that the promoter and the founder has gone. His dream is left, he's got tons of money, but then you leave it. So what is your model when you start doing entrepreneurship? Are you into a debt or an equity?
You should have both. Okay, so I'll tell you what he's asking. Equity means some other people will put money, like I said, some people will put on money. Every 4 years they want to exit, they make the tons of money and they will go. Debt means we borrow from the banks and then we keep paying in a monthly for the next 10 years or 15 years. When we cannot able to pay for the equity, the people who invested with us, they buy out. That's why whoever is started with a good intention, they disappear from the scene. Only the money-making people will come and they rule the entire army.
Correct. Correct, sir.
So, it has to be balanced. So, we need to, that's where I said, initially I took partnership from the equity from doctors. I took, when we invested 25 crores, 10 crores I took from the doctors as an equity. When I keep growing, when I want to make it bigger and bigger, I keep diluting it. Then I went into IPO. Once I go IPO, that is a listed company, then there is no burden on anyone else. Everybody, anybody, it is like a platform. Anybody can buy the shares, you can able to disinvest the shares. If it is a private equity, they put lot of clauses. If you don't perform well, it's like a horse. They put money on us, they sleep well, we work hard like donkeys. If you don't perform, then they will buy out. because they have the money power.
Correct.
So you need to have both. So the important thing what we need if we want to improvise our healthcare, the NABH and all those things should start in the medical school. The student should be able to understand. Once he passed out and come and start practicing, he doesn't know what he wants to do. So the entire thing, if the medical profession has to improve, it has to be done during the medical education time. They are all sitting on the NEET, all these things. They never see. There are many colleges, they don't even see the patients. They get a number distinction marks by sitting in the library. So the moment we close 8 to 4 the library first and sit on the patients, make them to work, every patient is going to be a teacher. The day when we do like all of us has been done training during that time. And now unless that changes, and second important things, every 5 years what we have done in UK or USA, we need to upgrade ourselves. The moment when we see one tabby, we will go and see, I feel bad. The mortality is much more is an iatrogenic rather than anything else. If you don't have hospitals, I don't think mortality rate will come down, to be honest.
Thank you.
Regarding the group practice, just one this thing. See, the SIMS model, Dr. Javli sir, I think it's very important to understand, Dhiren bhai, if you can just throw light on what is the SIMS model for group practice and entrepreneurship and sort of shareholding by the doctors. It's very interesting to understand from them because they have understood the concept from the US, and the group practice system actually started from the US on how you distribute, as sorry Dr. Tendulkar, equity among the doctors themselves. There are different layers, how you earn profits from the hospital, from your own practice as individual consultants. Dhiren bhai, would you like to share something on the group practice system which you have?
Thanks, Dr. Manoj. First of all, fantastic session. I really enjoyed the session. Apart from the first talk, if I look into the rest of the 4 talks, based on my last 20 years experience and our group practice that we have been performing, it is a very unique practice. We as a cardiac surgeon and cardiologist and cardiac anesthetist have been working together for last 20 years. We are sharing money, we are sharing income, we are sharing the responsibilities. As per my understanding, and I would like to have Dr. Bhaskar Rao's opinion also, the crux of last 4 talks is, if you want to be an entrepreneur, the first stepping stone is create a group practice. Group practice not only of the cardiac surgeons, you have to have an open mind and take along the cardiologist also. That is where I differ with Dr. Javli, his opinion that it was a baggage for me. I would say, if you want to move further and have a big heart, have people along with you, and then only, that is the first stepping stone for an entrepreneur. Once the people are there with you in the group, then you have that guts, you have that courage, you have that money power, you have that long-term power that you can go for entrepreneurship, go for the hospitals, go for expanding your business. From our experience, let me share that we started with a small private limited company wherein we were the only investors. So there were 7 cardiologists and myself surgeon. We invested, we created a company, and from that company, we built the SIMS hospital. And then SIMS hospital, over a period of time from a 100-bedded hospital, now we had a 350-bedded hospital. And recently, we had an handshake, or there was a merger acquisition with the Maringo Group. And let me tell you, the amount of money that I've earned in last 20 years, I've earned more than that by this merger and acquisition. So that should be the mindset. You should not be just working day in, day out. A cardiac surgeon, I would say, is always a leader. Whether you look at Dr. Bhaskar Rao, Dr. Devi Shetty or Dr. Naresh Trehan. These are the people I think that they are the role model. They have shown us the path that we as a cardiac surgeons can be an entrepreneur, can be the leader of the group practice, and can move forward. In our group practice, just 2-3 points that I would like to highlight. We share income. We have a very complex formula wherein we share the money, how to share the money. If you want, I can teach you sometimes whenever you are ready to absorb that thing. But yes, there is a complex formula, there is a point system, how incentivized people can be done, made so that they can run around, do more work, get more work. And probably with this incentivization and this group practice, I may say, okay, we are the leaders in cardiac sciences in the state of Gujarat or Western India, because whatever the first that has occurred in the state of Gujarat, it is the R group that has done in Gujarat. So that is the strength of the group practice and entrepreneur mindset. Dr. Bhaskar Rao, I would like to have your opinion. To be an entrepreneur, what is the first thing for the cardiac surgeon to have in his mind?
No, not that one. Just see what I think he has mentioned very clearly. That's my first slide. I and we. That's where the difference. When I started my career, I trained along with IR. That is the theme. Even we have 3 cardiologists. Now we have 10 cardiologists in one place. They do everywhere. TAVR will be done by separately. The complex angioplasty is done by someone. The pacemaker is done by someone. The IACD is done by someone. Like that, you need to live your life. We are not living life. We are killing ourselves by doing everything. Going on the volume, I want to do everything. I want to do everything. You also have a family. Okay, you can't marry the hospital. So like that, when you people think, the moment you convert I into we, everything will come into the mind. There will be some giving, some takings. He has put a lot of complex thing how to share. It's a matter how an aortic dissection fellow will be able to get little more than a mitral valve replacement or a straightforward angiogram or a heart-lung transplant. Like that, if you're able to put, if you're able to understand, the only thing is we feel our person is our enemy. That is the biggest problem. The day when we convert it I into we, automatically everything will change. Today, in my organization, we start with 40 consultants. In one area in Secunderabad, we have 450 consultants. In each branch, we have not less than 7-8 consultants. Keep growing. All are doing group practice. The patient will be the most centric person. The entire importance is the group practices. When you can't be 365 days, 24/7. Your patient has to be safe. So that is the reason the group practice will help the patient. In turn, the volume keeps on increasing.
I just want to, I just
Yeah,
take a
Dr.
minute.
Hamdullah, please.
Yeah.
Yeah.
So I just wanted to give my input. I work independently, not as a group or something. But one thing I realized, if you want to do something, these 2 chairs are completely different. One chair which is an entrepreneur, you're sitting, and the second chair as a professional. Don't mix them, you will never go far ahead. Now, so that's what I wanted to say, that's how you can. When I go and sit into my director's cabin, I think completely different than a cardiac surgeon. I need to know how my hospital runs, my OPEX, my CAPEX, my return of investment. That is all completely different chair. Don't mix them. It's a different thing for a group practice. Yes, it's a part and parcel of growing your institution. But then the individual level also you can do similar remarkable things. And you have to set your vision. You want to grow, and then accordingly you have to put yourself, your goal in that way. Don't overdo, don't be under serious debt. Other people who can just change your direction of your thinking. That's all I want to say.
Yeah, thanks.
It's been a wonderful session. One thing that I wanted to change in this techno college was that we've always been talking science, 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 trying to show our feathers, trying to become a bigger surgeon or a better surgeon from the other. These are some facets which we are discussing today in this session, which I really wanted even the youngsters to realize so that we can train them from the beginning. Nobody talking all this used to be thought as a curse, as a no-go area during our MBBS trainings or our MCH trainings or anything. But believe me, these trainings and these exchange of thoughts is equally important. For long we've lived into a complex situation where I consider myself the biggest surgeon in my city. And I believe that my patients are going to die without me. And what happens is, it kills me. So as Bhaskar Rao said, sir said, from I we have to become we. मेरा patient किसी का नहीं होता है, patient अपनी बीमारी का होता है. Half of the times we amongst ourselves are just living into a farce area where we believe that it is me who is doing everything. It is mine. The day we change that thing, we make our life simpler for ourselves and a happier life for ourselves. Can I please invite all the speakers to come on the dais, please, so that we can Thank you.
Thank you, everyone. Thank you, everyone, for.
Very nicely you stopped the discussion. Sir, I have to manage another 4 sessions.
Thank you. It's on. May I request Thank you for a wonderful presentation. And this session, the morning sessions, if you see, have all been sort of life and life management sessions, which is what Bhupesh actually wanted to involve. So may I invite Bhupesh also onto the stage so that thank you for a wonderful session, and may I request the chairpersons to present the mementos, please. Dr. Varun. Dr. Lokesh, can you please present to Dr. Varun? Thank you. Thank you, sirs.
Thanks to each and every speaker for accepting our invitations. We took a lot of time to make this session, and we selected a speaker to deliver their experience in a very deep way and which is helpful to us for our future. I am thankful to each and every speaker.
Thank you very much, sirs. We'll just move on quickly to the next session. May I invite the chairpersons, Dr. Atul Maslekar and Dr. Malkesh Tersaria, to please come on to the stage and take over.
When we get an invitation to talk on some topic, it is likely that it is misunderstood. A few years back, we had invited Dr. Tendulkar to talk on complications in cardiac surgery, and he received an email from Dr. Tushar Shah, which started as, looking at your vast experience, we invite you to talk on complications. So this can be misunderstood. So I hope Bhupesh Bhai has not misunderstood that I am having a large number of skirmishes with black coat, and that's why I should be selected. Okay, now let's come to the topic. When we start any talk, we normally remember people who should be remembered and who are relevant to the topic. Now, I would like to share 2 videos of social activists civil rights activists who have really awakened our country about the civil rights and how the doctors are bad and all that. So this is the first one. He is the pioneer in our recent memory. How do I start this video? Yes.
हमारे हेल्थ केयर सिस्टम में कई डॉक्टर्स ऐसे हैं जो सिर्फ पैसा बनाने में लगे हैं, अपने मरीजों की सेहत के साथ खिलवाड़ कर रहे हैं.
Okay, so now if we are seeing more of the black coat in our lives, some credit goes to this gentleman. Credit also goes to the makers of this film and this scene.
ये बॉडी अभी कहीं नहीं चलेगी जब तक आप लोग 50 लाख का चेक शांति नागपाल के नाम का नहीं बना दोगे. चलिए आप लोगों का नाटक खत्म हो गया. बुलाएं अपने बॉस को. Come on, बॉस को बुलाएं. Come on, out. Out. Out.
See how much ahead of time Akshay Kumar was. Nowadays we see every patient keeping in his pocket a mobile phone, secretly recording your audio, video, sometimes assaulting the hospital people, and this is the situation in which we have to perform and give our best. Media and celebrities have created a doctor-patient mistrust for their own populist gains, as it is very obvious. And people say that doctors and hospitals, they loot us. And then the problem is that any poor outcome is attributed to the doctor, whether there is an act of commission or omission, or even if there is some rude conversation with the doctor, any medical outcome which is not good will be attributed to that rudeness. So this is the problem. I have had some experiences in legal matters, and I'm sure this list is not exclusive to my practice. Death after cardiac surgery leads to litigation. Deep sternal infection, not uncommon, and we have faced litigations. Forgotten swab also I have seen, and I have prepared a defense to support the doctor. Mismatched transfusion, currently I am defending one case and preparing these grounds to defend a case of mismatched transfusion. One patient's blood given to another patient, and the groups were different. Surgery without consent, I have also, I just helped a colleague in arguing a case which he operated in 1989 or probably 1980, and he had forgotten to take consent, or at least the case went to civil court and he was not able to produce the consent paper. My colleague says that the consent paper was snatched by the patient and it was torn off. He won the case, of course, because the court took the view that probably the consent was implied. But we have to remember blocked stents, blocked grafts, these are going to happen. Early recurrent symptoms, early repeat procedure, infections, blood loss, these things can give rise to our skirmish with the law. Legal liability is not very new. Even 5,000 years back, Hammurabi had made a code, and in that code of rules and law, if the physician erred, his fingers and hands were cut off. But he was still different from today's world if the surgeon saved somebody's life. He was very nicely rewarded, which is not the case in our practice today. Now, after thousands of years, even today, our regulation has remained more or less the same in basics, that it is based on the principle of revenge and punishment. Punishment given by the law, revenge apparently, which motivates the patients to go to the court. Now, the expectations of everyone from our fraternity are very high. Everyone wants to live longer. Everyone really wants to have a better quality of life. And the notion has come that if we are going to a good hospital, good doctor, money can buy everything. If we have got a lot of money, even a serious patient should not die. That's the notion. Even we have seen rich patients are willing to pay more. Insurance sector and investors have put a lot of money in the healthcare. And how can lawyers be far behind? They are also in the field and fray. And it is in our interest to avoid the medical legal trap. Why we should avoid this medical legal trap is because we will incur a lot of legal expense, and the lawyers are always more expensive than the doctors. Media reporting gives us bad name, stigma, and the rights activists, politicians, they also sometimes come in the picture. We lose our time, we remain stressed, and the entire process, which is going to last for 5 to 10 years, that process itself is punishment. It impacts our self-confidence. So, increasing mistrust and unhappiness in patient's mind, it does not help the doctors, but it ends up helping the law industry. So what's the reality of litigation these days? The idea is to take money from the doctor or the hospital, and people know that the court will give compensation which is going to run into millions if they win the case. And patients have nothing at stake. They have to just approach the court and sit tight. If they get the compensation, then they are into profit. Even according to the law, compensation is linked to many factors like patient's age, his annual income, income tax return, dependents, and all those things. And there is a formula, and compensation awarded will be huge. But the law doesn't take into account the actual fees that we charged, maybe 25,000, 50,000, or even 5,000 rupees. That doesn't matter. Irrespective of the amount of the fee you have charged, the compensation amount can be much more than that, even if you have done a free operation. So the amount of money which was paid to the doctor to save the life of a patient was peanuts as compared to the compensation. So this is where the present law differs from Hammurabi's code. And another irony, Bajpayee Sahib is there or he has left? Another irony, Bajpayee Sahib, is that the law applies to the licensed and qualified and trained and educated doctors. And we find it difficult to practice medicine. But on the other hand, the unqualified, unlicensed doctors, they have a field day. Strict regulations that we face and we are governed by, they do not apply to those doctors. Our regulation is trying to regulate us who are already regulated. And the law is trying to punish those who are qualified and licensed, but turns a blind eye towards unlicensed and unqualified doctors. And what encourages this litigation? Zero fees system. As you know, the lawyer says, you just sign a few papers, no fees to be paid just now, I will fight the case. And they also promise hefty reimbursement. Oh, your case is very good, doctor has been very negligent. And he has really killed your father intentionally, and we will get a huge compensation, so you just sign this paper. And third thing is that once the compensation is given, the lawyer splits the compensation with the complainant. And moreover, there is no dearth of relatives in the patient's family, lawyers, who are ready to try their luck to extract money from the hospital or the doctor, and also for some sense of vengeance. Doctors are at a disadvantage because in our profession, there is no accurate demarcation line between the negligence and the error of judgment or genuine mistake and natural complications. Because doctor is not in many cases able to prevent natural complications. Even natural poor prognosis with which the patient came, it can be labeled and proved as an error in the court of law. Because when the matter goes to the court of law, the court does a retrospective analysis. The court has got a lot of time. Tarikh pe tarikh. And they've got a lot of time. We didn't have the luxury of that time when we treated the patient in ER or in our ICU or in our operation room when he presented in a serious condition. So this is the disadvantage that we face. And we also face other risks, not just the risk of litigation in the civil court, criminal court, or consumer court, but any patient who enters the hospital, he has got a theoretical risk of death, whether it is a static risk or a progressive risk. And it is very easy to blame the doctor, although genuinely it was a case of poor prognosis. And patient has got all the options to harm the doctor, whether it's media, and as I said, all three types of courts, and even physical assault on doctor or his family, and especially if the victim happens to be a VIP or a criminal person or a goon. So we have to, whenever there is a case of litigation, we have to try and tell the court that this was a error of judgment or a genuine mistake, not intentional, and it was not negligence. There are some advantages of Consumer Protection Act. We know that we have all become aware, we are constantly upgrading and improving ourselves, and we have become more cautious, more careful. That is good. But there are several disadvantages, especially that it promotes defensive medicine, lot of investigations, and sometimes the onset of the treatment or beginning can be delayed because of the constant fear in our mind that I have to document properly, I have to get a CT scan, then only I will do the treatment. So these are the advantages. And what happens if the patient starts a frivolous litigation against us? Now, we have seen many instances when the doctor is penalized, but patients are never penalized, hardly ever penalized. For example, there have been cases in which court has gone on the other side and inflicted a fine on the patient for frivolous punishment, frivolous complaint. But do you know, that particular case, the compensation demanded by the patient was more than 1 crore. The court dismissed the complaint and imposed a fine on the patient. How much was that fine? 10,000 or 15,000. So there is a lot of imbalance. So you might get an idea that is judicial system totally against us? Is it heavily loaded against us? No. And these two particular judgments are really landmark judgments which are very fair, very balanced, and they really are on the side of the doctors. One principle is law of torts, and it defines the negligence. And every bad outcome is not a negligence. For proving a negligence, patient has to prove that doctor has done something which a reasonable doctor of the same field, the same society would not have done. Or he has missed doing something, he has not done something, omitted, that other person would not have omitted. Similarly, this principle of Boehm's test is also very important. And let us remember, law requires us to bring to the patient only the reasonable standard of care, not the best standard of care, best in India, best in Gujarat. Whatever is reasonable standard of skill is to be provided to the patient, neither the very highest nor the lowest. And another thing is that if my colleague would have treated the patient with a different medicine, different surgery, different procedure, that doesn't automatically make me negligent. So there are some safeguards in the law for us. Difference of opinion is not negligence, and the courts have recognized that there is ample scope of genuine difference of opinion. And courts have also said in their judgments that no sensible professional would intentionally commit an act of omission or a commission because the professional reputation is at stake. Even the principle of res ipsa loquitur is not very freely and easily applied in medical cases. Criminal liability, we have got enough protection from the law by the Supreme Court for criminal liability and FIR and arrest. So we have got that kind of a protection. Judges are aware of the limitations of legal process. Judges have gone on record in their judgments to say that they are not medical experts. Human body is a very complex mechanism, and they have admitted that the courts are not in a position to evaluate unless there is a assistance by an expert opinion. So judges are not experts in medical science, that is, they have accepted and understood. And they have also prohibited indiscriminate proceedings and decisions against the doctor because they say that such a thing would be counterproductive and serve the society no good. But there are certain examples which are clearly due to negligence, and we cannot escape our liability from this. Recently only, section IPC 304, last week such a punishment was, this a criminal liability, and 304. It's a culpable homicide. This is the date. So, that's 23. It should have been 23, 2023. IPC 304, culpable homicide amounting or not amounting to murder. So this doctor has a prima facie criminal case against him. The reason being the patient was suffering after cesarean section, and doctor was called several times, but he did not come. And when he came, it was very late. Again, we are all aware about high-risk cases and how high-risk consent should be taken. Preferably, it should be handwritten by the patient, and video consent will help us. There are situations, I would like to take half a minute on this. These are the situations in which there are more likelihood of legal complications arising. Especially, read this. Only operations. What is an only operation? Only operation means, what is the next case? Okay, it's only ASD. What is the next case? It's only Lima to LAD. Only single graft. Whenever we affix the word only to the operation, the entire team is likely to become negligent and relax. So only operations, these are simplest operations, are most likely to result in re-explorations, litigations. Live workshops are another place where we have to be careful. Social media discussion nowadays in cardiac surgery forum and all that, these things can be taken as a screenshot and may be used as evidence against us. If a telejournalist like Navika Kumar can claim to have access to the chat of one deceased Bollywood actor and the actress, similarly our chat also can become public. So communication, I do not have to say much about how the better the communication, more the communication with the family, better it is. Please read the first point. There is always we find some family member annoying, asking questions, cross questions, not allowing us to complete. He will cut off our talk in halfway. So this particular person, we don't like it, and let's say it's bilateral. He will also not like, because he will know from us. But he can be a problem. So it's better to choose the most difficult relative and keep him in confidence, explain to him any number of times that he wants. More important is, nowadays we cannot play God, we cannot have ego issues with the relatives. Naturally, we all have degrees, studies, medals, but we cannot tell the patient that, look, who is the doctor? Am I the doctor or you are the doctor? Because many times patients have asked the doctor, because of his insulting behavior, the doctor, is this your consulting room or insulting room? Another thing is, in conferences, in discussions, making comments, taking mic in our hands, we tend to exaggerate our opinion and put it more emphatically by using the word criminal. I'll just give one example. I may get up in the audience and say, you have done replacement in this case. It's criminal. I would have repaired the wall. So these words like criminal and all that, we are using very lightly and casually, but it should not be done. Bitching about the colleague should not be done. So lastly, law is a watchdog, not a bloodhound. But we have to remain on the right side of the medicine and right side of the law. Do what is correct medically and do what is correct legally. However, once in a while, we may still receive a khaki envelope from the court, and we will discuss later on sometime what to do if we indeed receive a notice from the consumer court. Lastly, one anecdote. Black coat actually helped me get into my MCH admission. My father, who was a practicing lawyer in Gujarat High Court, and I wanted to get into KEM, but because I was not a resident of Bombay, Maharashtra or Goa, I was not considered for admission. So we had gone to Flora Fountain one day, and you see the Yusuf building, it is still there even today. I am talking about 1984. In Yusuf building, my father's friend was having an office, he was practicing in Bombay High Court. So we approached Bombay High Court, we convinced the judge, Lady Sujata Manohar, that I am also having merits and I deserve to be admitted, irrespective of my domiciliary status. And she issued an interim order to the Bombay Municipal Corporation. That's how I got admission to GS Medical College, KEM Hospital. So black coat is not always bad. We can also have black coat in our support on our side. And let's remember, the harder we work, the luckier we get. So there is no substitute to remaining cautious and dedicated to the stakeholder who is the patient and his welfare. Thank you.
Thank you, sir. I think this session is also going to ask for answers. We'll take it afterwards. Sanjit, who's one of my colleagues and another fantastic surgeon from Nadiyad, to give his talk on where are the lights gone? Burnout, I think, mind and undermined, staying ahead, preventing the burnout. So let's hear what Sanjeev has to say about it. Lights are gone, is it?
The lights have burned out.
In the meanwhile, sir, Sukumar sir, what would you suggest to the younger generation is, you did mention about litigations, like in US, there are lawyers going around in the hospital asking for families, are you unhappy, are you unhappy, if we win, we'll share 50-50. I think that is also likely to come or very much into process in India, coming up in big cities. And but for the future generation that we are seeing here, what is the approach to the patient and patient's family? You did mention, because I would be a bit critical here in mentioning in my last 39 years of practice that I have seen surgeons, when the patient starts going bad, they try to avoid the family. Whereas I went abroad and got trained in Australia, where I was taught the first thing, if you have done nothing wrong or you're not guilty of doing something wrong, there's no need to avoid the family. And basically the family has come to you with a problem. You should not become a problem to them. You may not be able to treat the patient. So I would like to know, something advice for the future generation, anything you would like to say?
Yeah. In the previous session, the speaker quoted Gandhiji, that customer, that patient is a continuation of our work and he is not an interruption, and we should respect the patient. And it is really true, because the family has come to us and handed over the patient's body and all the decisions to us. So we must exercise the highest skill that we have. And nowadays we have so much good communication that the advice of a colleague is very easy to get, as Dr. Tendulkar sir said last evening. And even in the same institution, I am getting phone calls from my colleagues in the city when they are going to do a case. It's not going to be a difficult case. Even then they call me, and they, just to confirm their line of action, they talk to me on phone, and then they say, okay, I was going to do the same thing, but I wanted to make sure. So always take second opinion, involve more people. They may be less experienced or more experienced than us, but involving more people is also good. And we have to do what is right medically, prepare properly. Even these days, when I'm going to do some operation which I'm not doing every day, then I go to YouTube and CTSNet and see the videos and learn about it before putting the incision on the next day. For example, we are all doing CABG very often, but we are not doing carotid endarterectomy very often. So whenever there is a case of carotid endarterectomy, I will revise my knowledge with that video. And communication, as you said, the surgeon must meet the family more often, should not hide his face, and he should show that he is the team leader, he is responsible for the good that happens to the patient, and he also is taking responsibility for the bad things that may happen to the patient. That kind of boldness is required, and we should not hand over the communication to anesthesiologist or a resident doctor or anybody else.
I think before Sanjit starts, just sometimes, as you said, rightly said, we should have a very much control on our language. I made a mistake once. Of course, it didn't go into litigation. It was just for fun because the family took it. Patient is being wheeled into the operation theater. The patient's daughter, trying to show her smartness. We have discussed risk, everything, and that time she is asking me, sir, if you can tell me exactly how many such operations have you done in your life? I just gave a stern look at her. I said, didn't I tell you when you entered the hospital and asked about me? He's going to be my first case. So he looked at me. Are you joking? I said, were you not joking? She took it lightly, but then after, we can't do this kind of language also, because sometimes it can be taken very badly, and we may be, we can't be casual, right? Even in OT, even before OT, or even after OT.
Like it is said in the case of justice, that not only justice should be done, but justice should appear to have been done. Similarly, not only we should be sincere, but we should also appear sincere.
All over to you, Sanjit.
Thank you, chairpersons, and everyone for being here and actually wanting to listen to this topic. Mind undermined. Undermined means it's at that time where we feel overwhelmed and we feel we are undermined. And that is when I think this preventing of burnout and beyond really comes in. I have some disclosures to make. There are some of my beliefs that you should chase your dreams, but don't be scared of waking up in the middle of those dreams. While cardiac surgery dwells in my heart, there are several other of my passions which are close to my heart. Humans have been made the most intelligent creatures on earth, on the planet, by a long shot. But there is only for one reason, and that is so that we can use our intelligence. I have a questioning personality, so I question to the point that it should make sense to me. This is my office. This is my last disclosure. This is my office. A very good friend and colleague of mine walked into my office and was surprised to see that my one wall in my office is of photographs of birds which I have taken in a radius of 15 kilometers. So he looked surprised, and I said, well, this is because, cardiac surgery is such a demanding field. I do this to keep sane. So he looked at me and he said, you are doing this to keep sane? I said, yes. He looked at me and he said, it's not working. So that is another disclosure that I have to make, that I struggle to keep sane sometimes. I don't know what got into me when I said yes to Bhupesh Bhai. When Bhupesh Bhai called me and he said, Apne thodu, let's talk about this burnout problem. Tame burnout upar kaho na thodu? Ha, kahi desh. I said yes. It's only then I realized, what did I say? So I have a disclaimer, which is this is first of a kind of my talk. I have never given talks like this before. I am overall social media shy, so you won't see my presence on WhatsApp or on Facebook or on anywhere else or Instagram. And I am certainly not an expert at preventing burnout. So therefore, if you see through my presentation that there is a mismatch of what the diagram says and what the message is, please don't mind. But the only reason why I agreed is that burnout is officially not a medical condition. And therefore, I think everybody has the right to talk about burnout. As long as it becomes a medical condition, then only psychiatrists will have to talk about burnout. And even at the Mayo Clinic, their site talks about job burnout being a special type of work-related state. And I think when do you feel this burnout? If you wake up one morning and realize that you've become cynical, critical at work, are you dragging yourself to work? Do you lack the energy? Do you find it hard to concentrate? Are you using food, drugs or alcohol to feel better? Have your sleep habits changed? That's when you need to address the real question of, are you suffering burnout? There is no single reason for burnout. And as I said, it's a struggle. Every one of us has felt that burnout at some stage in our lives. And therefore, for me, it's been a 6-point strategy. And I'll take you through the 6-point strategy that we're talking about. The first, I think, is setting yourself realistic goals. We are all not like Messi. That was Messi's brilliant goal. Most of us would relate to this sort of a goal. Roberto Carlos advertisement of Pepsi 2002 World Cup. He has to play against the Japanese. Similar situation. Foul against him. He's given a kick. A barrier of Japanese in front of him. He thinks smart. He suddenly remembers that boy in the morning. So he also bows. The Japanese team bows, and there goes the goal. So let us have realistic goals. We are all not like Messi. I don't know how and why climbers go climbing. This is a photograph of a climber who has gone up on Mount El Capitano in Yosemite. I don't know why they climb. But when they climb, I just want to use their photographs. And several times when we climb up our ladder and we say, my God, there's so much more to go, I would say, why don't you look down? From where have you reached? If you look at this person who is climbing, from where have they reached and where have they come up? And several times we think, there are miles to go. That's fine, there are miles to go, that's okay. But encourage yourself to say from where you have come. You finished your MBBS, you've done your MS, you've done your MCH, you're working. Again, another thing that we can learn from climbers is their teamwork. And we talked about this teamwork this morning. Only teamwork actually works. They protect themselves, they protect each other, they have ropes, and there are several photographs that I can show you to show how exactly the team works. The next is smell the roses. Take your time off. We don't have time to smell roses. It's true that roses, there are two types of roses. There are one roses which smell good, and the other type of roses that just look good. Look good are the Valentine's Day roses. The smell good rose are the perfume roses. But all these rose stems have thorns. So it doesn't matter. But I just want to show you a photograph of
a little flower that I saw on one of my treks in the Western Ghat. This is the Cerupegia. Cerupegia is a beautiful flower, and if you can see, it actually has the petals which converge and form a tip. It's much like our catheters which will remove a thrombus. But the beauty of this is when an insect gets in, it's trying to take the nectar and it tries to go out. It can't go out immediately because it gets caught in that. It finally circles around, and finally when it goes out, it is full of pollen ready to germinate the next flower. Therefore, if you don't have time to smell those roses or actually look at the other roses, it's going to be a problem. I want to talk about the fact that we are not married to cardiac surgery. Last Sunday, while I was preparing for this talk, I called up a few colleagues of mine and said, "What are you doing this morning?" Ajit said, he was on his singing practice that morning. He's formed an NGO to support art. I rang up Atul and said, "Atul, what are you doing?" Atul was paragliding. Look at him. He's paragliding on the Swiss Alps. There he is on the Burj Khalifa. Wow. And now he's here this Sunday. Then I rang up Suresh. I said, "What are you doing?" "अरे वो saxophone का practice कर रहा हूँ यार." Then, pleasantly surprised to see what Jacob does. He's got an astronomy club. He has a telescope. He takes classes for students in photography. And probably one of the best images of the moon has been taken by Jacob. Amit was busy golfing. These are the awards that he has won. And I like to quote Gaurav here, who rings me up without a fail every conference and says, "Sanjeet sir, what is your poison?" He knows that I'm a teetotaler, but yet he will ask me, "What is your poison?" Actually, my poison is bird photography. I have been through the length and breadth of India, from Kashmir to Kanyakumari, from Gujarat to Mizoram and Arunachal Pradesh, photographing birds in all sorts of climates. This is me hiding in a makeshift hide where I learned patience. Great Indian bustard, spectacled finch at a height in the Kashmir, mangrove pitta, and our own lesser florican, where less than 100 birds exist. The most colorful oriental dwarf kingfisher, the most elusive Blythe's kingfisher, the most colorful hornbill, the rufous-necked hornbill. Well, week before last, that Sunday, I was scuba diving. I went scuba diving with my children. And I'm sorry. Which ones, ma'am?
Birds. The birds.
Birds, oh, okay. This is a mallard. This is a Khalij pheasant. This is a mallard. This is a critically endangered bird. This is a great Indian bustard. It would have become our national bird, except somebody thought that the bustard may be misspelt. So this is the spectacled finch. One of the most beautiful, this I photographed in Kashmir. This is a mangrove pitta, found only in the mangroves north part of Odisha. This is a lesser florican. This is the male display of the lesser florican. It's a wonderful display where it jumps up and displays to the females that it is around. Please come. Some females actually decide to go. I was very fortunate to get this, where the mother is feeding the little chick who has just come out of the nest. I was the one who discovered that Blythe's kingfisher is available in a little place called in Arunachal Pradesh, in a Pake National Park. I spent 100 kilometers trekking up and down those rivers and those streams, spent hours in those hides that I talked about, and then took this picture, probably the best picture of the Blythe's kingfisher today. Anyway, I mean, yeah, so now I've just started scuba diving. This is what I did in Seychelles 2 weeks ago. This is with my children. And the marine life, forget about Seychelles, the marine life even in Goa, in Andamans, is fantastic. And I would encourage all of you to take up something that you've not done before. So therefore, we are not married to cardiac surgery. It is all right to flirt. You are permitted, cardiac surgery doesn't mind. But unless you flirt, you will not realize the importance of cardiac surgery. The last 6th point strategy, I have taken up another genre of photography called astrophotography. But I do this when I have enough time. I spent the night of the 16th of April on an absolutely lonely beach called Anse Forbans in Seychelles with my son, who also happens to be interested in this, and took this photograph showing the movement of the stars. This was a 4-hour photograph which showed the movement of the stars. At that same point, I took a photograph of the Milky Way. This is the Milky Way which was rising up on the eastern horizon. That was when I had my me time. And that's the 6th strategy. You need your me time. Ask yourself, who are you? Where are you? Who are you in this universe? And I cannot but not quote Carl Sagan, who said, when you look at the universe and when you look at the Milky Way, when you look at 400 million planets which likely have life, where is the Earth in that? We are not even on the main arms of the Milky Way. One of the side arms of the Milky Way, one of those little specks, the blue dot, that's what Carl Sagan calls it. We are that. Look at that dot again. That's here. That is home. That is us. On it, everyone you love, everyone you know, everyone you ever heard of, every human being who ever was, the aggregate of our joys, suffering, economic doctrines, every hunter, forager, every young couple in love, every mother, father, every teacher, every corrupt politician, every superstar, every saint, every sinner lived there on a mote piece of dust suspended on a sunbeam. That is who we are. And so, what do I see? For a tiny speck of dust, we have such an oversized ego. And that is your me time. And unless we have that humility to know that we are just a speck, having a 6-point strategy to control this constant battle within us is not going to work. Let me show you a photograph that I took very close to where I live on the 23rd of July 2020 when the comet Neowise showed its face to us. I don't know how many of you know about comet Neowise, but basically what I'm trying to say is there is life beyond the operating room and the ICU. If at the end of it, I have encouraged you to start your first love. What was your first love before you took up cardiac surgery? Was it just a pen and paper where you can draw? Was it just creating an app? Was it just learning a new software? Was it just embroidery maybe? Was it dancing? Was it music? If I have encouraged you to look back at your first love, I think the purpose of this talk is done. Thank you.
Thank you, Sanjit. Fantastic. I always knew Sanjit was, very much an avid photographer, but what he has shown today. Now, if you look at these two topics which we had today, one, a far extreme one when Sir has mentioned, how we are and what can happen to us if we don't behave, versus the burnout thing. I think the take-home message is, all of us, before we joined medical college, we had some passion with us. For me, 14 years I have played tabla. I studied in Dehradun, so I got 4 diplomas from Allahabad Sangeet Samiti Vidyalaya. But I gave it up because mera khud ka tabla bajne laga when I joined MBBS. Today, I always dream, when I see yesterday from UN Mehta, our colleague was playing the electronic guitar. That is what I'm developing that passion. I'm not finding time, but that's again an excuse that I don't have time for running my passion. But my dream is to give up cardiac surgery and go on the stage for an electric guitar. So I will do it one day. What Sanjit has been doing is fantastic. So this is a message for all of us, is just don't go behind cardiac surgery. Cardiac surgery is what you're going to do in your life, but you're a human being first, you got a family there with you, and then comes cardiac surgery. It is very unfortunate. Means I got this message in myself quite late in my life, so I'm talking to you today. But it's very, very unfortunate when 2 cardiac surgeons meet in a conference, they don't ask each other, how are you or how's your family? They only ask, kitne kiye? How many cases you have done? Is that it? You have joined this profession for that? And if you do that, continue to do that, I'm sure the burnout will come faster. So please chase your dreams. Less cardiac surgery, be part of your dream, but let it, a profession is a profession. You are human beings first. Treat your colleagues as human beings, treat your families as human beings, treat your people who are working with you as human beings. You may grow in stature, but these guys are working with you. They also look after you as a senior person. So I think this is a very open session, fabulous, and I'm sure there will be some discussion. He's already standing here with a question.
For people who don't know, the biggest and the most cherished New Year gift that I get every year from Nadiad is Sir's calendar. Yes. He makes an annual calendar of the birds, and that I've been preserving, sir, for the last 4 years that you've been sending it to me. And you've got to see those things. So there has to be something in you more than a cardiac surgery. A sternotomy will remain a sternotomy. A lima will remain a lima. But you are not only meant for that. You are not a robot. That should be inbuilt in you. Okay, I was also telling some students, be disciplined. But that does not come with a cost. The cost should never be you and your dreams. Whatever you achieve, you can put a lot of material into it, but not yourself into it. So that should be more important, because ultimately you land up burning yourself. अपनी आहुति नहीं देनी है इस यज्ञ में. आप रहोगे तो ये ब्रांच रहेगी. So manage yourself first.
Just a small
thank you very much. Shall we? Oh, sorry.
So, as I said, it's very important for us to regenerate ourselves, and it cannot be just after once in a year or once in 6 months. It has to be at least once in a week. That's why, for the same purpose, I just took a small piece of land outside Mumbai, and I have made a small, beautiful farmhouse. And I think I'm just enjoying farming, like last 4 months of the year at least. No vegetables come from outside. We don't buy any vegetable. Everything comes from our farmhouse, and me working on it. So I have beautiful pictures I could have shared with him. The cauliflower, the tomatoes and everything. They are all built, done up by me. So even when I'm eating them, even if they are sour, they taste most sweetest thing in this world. So I think every one of us as a cardiac surgeon to take out some time and do something like this, what Sanjit has said here. It's a marvelous thing. It will keep us going. Thank you.
I think I must say Dr. Hamdullah has all 5 fingers in ghee. The amount of, he makes us jealous by the amount of work that he is doing at his center. Fabulous. And now that you are talking about this means you feel, yaar, hum kya kar rahe hain? So anyway, I think at the outset, Sanjit has given us a good talk, but let me also thank him for what he has been doing last 2 days, working morning to evening, guiding us and taking this conference for, I think a big hand, he needs a big hand for him. Thank you, Sanjit. Thank you for everything.
We move on to the next session, which is a very, very interesting session. So because it's going to be almost a 1.5 hour session before lunch, therefore let's take a 5-minute break now and then come back for this session so that you don't have to take a break after that. So we break now for 5 minutes and we join back again for the next session on innovations in cardiac surgery. Friends, we are ready to start our next session. The next session is a very interesting session. It's on innovations in cardiac surgery. And Dr. Bhupesh and Gaurav have contacted people who have done innovations in cardiac surgery from all over India, who have sent in their videos or their presentations and have come in to present to us and show us what type of innovations they do. So may I request Dr. Bhupesh Shah, Dr. Bijoy Kuti, Dr. Dhaval, if he's here, Dr. Manoj Pradhan, Dr. Manoj Dureraj can take his place instead. Please come on the dais to chair the next session and take it forward. Dr. Tushar Shah, he's also presenting, so please come, sir.
Can I invite Dr. Ajay Patil to carry on?
Good afternoon, and I will start with this. This is a next generation in sternal closure, and that is a sternal closure device. So there's no standard classification of sternal closure devices, but here I have broadly put them under these headings like sutures, devices, the sternal plates and the types of sternal plates, and sternal devices like something like talons and staplers and other devices. So we all know, we have all been using the wires, and we all know that the wires, they cut through very easily in the sternum, especially in patients who have osteoporotic sternums and maybe old age also. And the wire lacks mechanical strength. So it's either the wire gives way or the sternum gives way. Can I come down on the light, please? This is hurting me here. So to take care of that, we have come up with bands. So bands will have the advantage that they'll have a broad contact surface area, so there won't be any cut through, and the strength is going to be better. But a disadvantage is, it does not give a 360 degrees protection. The other types, the sternal plates, we have a lot of companies who are with sternal plates, a lot of configurations of sternal plates. What is the disadvantage of this sternal plates is, if you can see here, it has got variable or no compression. So to add on the compression, the sternal plates have come up. Can you get down this light also? This one, please. Yeah. So to add on the compression, the sternal plates have come with either the cables or the bands. And the sternal devices, the most common is the sternal talon. So what is the problem with the sternal talon? It is time consuming. It is not a simple procedure to be done. It has got complex sizing. A device is in two pieces, so you have to put one device on one side of the sternum in one half and the other side in the other half, and then align them in 3 dimensions and then close it. And another thing, this device has got a fixed legs. So if you see that the device is of 14 millimeters and the sternum is of 12 millimeters, there's always going to be a play between the device and the sternum. And that is why it does not give a 360 degrees protection. The cost is high, of course. And these are the number of devices which are there in the, which has to be provided. That is almost 16 devices, 16 sizes with single leg and 16 sizes with double leg. These are certain other things like cannulated screws and all, and the cannulated plate and screws. So coming to this next other common thing after the bands is the plates. And the plates have been shown to give a lot of advantage, like it has got a rigid fixation, it has got great stiffness, it has got high mechanical strength. A lot of papers who have shown that these things are good, they work well. The response to this paper has come from Italy, Rome, and what this is trying to ask is, though the rigid plate fixation has proved to be biomechanically so superior, why wires are still popular among the surgeons? Why we are not using the plates? And the answer to this is, it is very easy to perform. The wires are very easy to perform. It has got a very short learning curve. Even my junior can put the wires. Even a staff member can put the wires. It is effective, and it can accommodate all size and types of sternum, whatever. Even if the sternum is abnormal, it can accommodate that. Whereas when it comes to the plating, it is more complex in terms of implantation techniques. Second, it has got a learning curve, and it cannot be put suddenly by a junior. He has to learn how to put it. And third is, it requires long time. So another paper which is very surprising is unexpected results after a sternal reconstruction with plates. And what it says here, the incidence of post-operative infection is very high with plates. So it was supposed to be less. So, but here the papers are showing that the incidence is high. And why the incidence is high? You see, sternal bone is hurt by each drilling mechanism. So every time you are putting a screw, or you are basically damaging the sternum. You are damaging the blood circulation of the microcirculation of the sternum. And when we are putting plates, we are putting almost 20 to 22 screws in the sternum. So actually, what are we doing? We are actually weakening the sternum. So there has to be an ideal sternal closure device. So what is a most ideal sternal closure device? It should have mechanical properties which can withstand the maximum forces of coughing and sneezing. It should be easy to perform. It should have a dynamic compression, and it should not injure the sternum. So we come to this, the next generation, that is the sternal closure device. So what is this? It's the first real bone stapler in the world. It has been designed by me as a surgeon. I have tried to include all the advantages of the previous devices what we have seen. So what does it consist of? It consists of 2 plates, collapsible plates, 2 legs, and 2 claws. And as we lower the device on the sternum, the claws are going to turn in and hold the whole sternum. So this is how it does. I can show it to you. So once the claws turn in, it holds the sternum. It holds the sternum very tightly. It does not allow the sternum to move in any direction. It has got a broad base, and its sternal stapler is an isoelastic. I'll tell you what isoelastic is. Sternal fixation device with a broad base, it does not allow sternal instability. So it is a single piece device which is loaded on its applicator and requires a single action for its closure, like a stapler. Only single piece device on an applicator and requires only a single action for the closure. So that is how it makes, it is easy, very simple, very fast, strong and flexible. Strong and flexible. And the learning curve, stapler is an idiot-proof device. And elasticity, it maintains dynamic compression. So what does this dynamic compression means, and how does it help us? So isoelastic device, or a device which gives a constant compressive force on the sternum once the physiological load is removed. It acts like a shock absorber to neutralize the violent load during coughing, sneezing, and during the movement of the patient. As a shock absorber, what it does, it protects the sternum, it protects the ribs, and it protects the costal cartilages. Otherwise, the stress of the cuffing, even if the device is very strong, the stress of the cuffing will be transferred to the costal cartilage, and there are damages to the costal cartilages which happens. So to decrease that, it has to have like a shock absorber like effect. So this video actually shows how the bending of the plate happens. Of course, this is exaggerated bending. The bending happens only about 0.5 millimeters, half a millimeter to 0.75 millimeters, just to act like just to absorb the shocks of coughing and sneezing. So this is actually, this is again rotated. So basically what we are trying to show is every time, this is a fatigue testing what we have done. So the load of 30 kilograms was given on each device. And the moment the load is removed, the sternum sticks back and it goes back to the original position what we have put in. And the surgical procedure. So before, once we finished our whatever surgery we are doing, either wall replacement or CABG, before we look for the hemostasis, first what we do is make parasternal spaces. Once the parasternal spaces are made, then we put this rib approximator. This rib approximator is a modification what I have made from, the sternal approximator, which is a modification of the rib approximator. And then you take this device, it is loaded on an applicator. Just make sure that the claws goes inside the holes what we have created. After that, you just have to press the device down and close it. And that's all. The sternum will be closed. The device will be closed. So once this is done, you put the second device. The total number of devices will be, depending on the length of the sternum, it will be about 3 devices to 5 devices. The space in the intercostal, look at this one. Now we are removing the approximator and putting the third device. See how easy it is to put this device. Make sure that just press down and close. That's all. And the sternum is closed. So the claws are about 5 millimeters. So every space which can allow 5 millimeters device to enter in, that is the space where we put these devices. If the space is less than 5 millimeters, you add on a wire. See, the idea is to have a firm closure of the sternum. So you can use additional wires, that is one put. And removal of the device, especially during the re-exploration, is also very easy. You just unlock it, slide out, and lift up. It will come out the way it has gone in. Then you put a approximator again, and you remove all other devices. In case if you have used wires, don't cut the wires first. First remove the device, and then cut the wires. Just unlock, slide out, and lift up. You have to unlock, slide out, and lift up. It will just come out very easily. So disadvantages, are we reached the stage where it is an ideal device? Not yet. The cost, we cannot compare the cost with, definitely can't compare with stainless steel wires. Inventory has to be there because it's a device. It has got, it will require at least about 5 to 6 sizes to be kept inside the operation theater. Imaging for any device, whether it is a stainless steel wire or whether it is a plate or whether it is a talon, whenever there's a metal, there's some distortion of images will happen in MRIs or CT scan. But the future developments is a plastic sternal strip. As Dr. Anil Jain has said yesterday, plastics is going to be a part of our body in the future. And the advantages will be radiological imaging will be very clear and the cost should be cheaper. Yes. Thank you. Thank you very much for your attention. Thank you.
Thank you, Dr. Ajay. Can we have the next speaker, Dr. Srikant Mahapatra? He'll be talking about automation in aortic valve reconstruction, smart solutions for the new age surgeons and startups, I think. I think this is a brilliant session for us to understand what is there available and what the Indian surgeons are doing as a Make in India concept. This is a sort of innovative session which I think Dr. Bhupesh Bhai, Dr. Gaurav and I think we also contributed to that idea. And we want to showcase the talent what is there, and I think we need to promote our own surgeons by, once the devices are patented, then I think we need to go ahead and do our own stuff and support all of you who are doing so much work.
Hello. Hello everybody. Good afternoon. First of all, let me thank Dr. Shah, Dr. Goel and everybody on the Technocollege team for inviting me here and giving me a chance to present my work. I am Dr. Shrikant Mahapatra from Bhubaneswar. It's a tier 2 city, but we are working on some innovative aspects of cardiac surgery, which I want to showcase here. Basically, a little bit of background here. What I'm going to present today is basically in two parts. First, I'll be talking about how I got into this. I rather stumbled into this and business of startup ecosystem, and then what second part will be about the work we have done so far. So basically, it is born out of frustration as a cardiac surgeon. Frustration not in the sense of work, but frustration about the status quo. We have been doing the same old thing for the past 50 years. Nothing has changed in CABG, nothing has changed in valves. We haven't found a ideal heart valve. And a lot of work remains to be done in the field of heart failure surgery, and it is vanishing, especially with all these devices coming in. So this is what we have started to concentrate on. The background was basically when I worked in Australia for a couple of years for a fellowship, and then TAVI was is a newborn thing. 2010-11, Edward Sapiens, the valve was being launched, and my center was one of the trial centers where they tried it, and we were part of the heart team, so to say. And our job was limited to exposing the femoral artery, and by the time the device was being implanted, we are shown the door. So that was the situation. Then, so that was pretty underwhelming. And second experience that we have, I got a chance to visit Korea, where we watched a brilliant surgeon, Dr. Myung Ke Song, who used to be a pioneer in aortic valve repairs. The modern aspect of it, so many have done before that, but he had a scientific approach. He would do it so beautifully. And then we got the news that around 2013, his business had collapsed. He was driven out by his own cardiologist, who reported very badly, by his own hospital cardiologist, who reported very badly about his work, and he was never given a chance to explain, and the government itself turned him in. So that's the background. So that's what basically pushed me into this. And I came back to India. I turned to a few opinion leaders in this. I've literally talked to everyone and anyone who is into valve repairs. Particular inputs from, actually, I'll thank Dr. Jowli. He's not here, but he had some inputs there which goaded me on. So this is what we decided, that we would try to find out the problem areas and try to address that. And this is how this startup came up. I joined hands with, back in 2015, we joined hands with two of my schoolmates who were with Infosys and working with AI and machine learning. So we joined hands, started a startup called Acoustics Acoustics Solutions rather, and I am a co-founder and lead of the medtech sector there. So this is what it is. When you speak of startups, it's a very fancy word, like very something like that churns out millionaires by the month or by the year. And that's what the impression is. So it's very glamorized. And the only equivalent I can think of is basically movies. how you make movies. Everyone thinks one who makes movies is a millionaire overnight or crorepati overnight. That is not the case. So, but I'll draw similes between the two situations as I go on with this presentation. So, and a disclaimer: I am neither an expert on startups nor a master cardiac surgeon, but I know a bit of each, and I have traversed this course. Basically, it's about lessons I have learned. So, coming to my headings will be as per movies. A movie, if you know, it has 5 stages: development, pre-production, production, post-production, and then distribution. So I categorize my presentation that way. So basically, when you start out with a startup idea or something, it's not a overnight job. You don't feel like you have a brainwave sitting over a mug of coffee over a weekend and you come up with a flash of idea. It has to have a clarity of ideation. As Dr. Rao earlier emphasized, the idea has to be there, the feasibility analysis has to be there, the SWOT analysis, that what is so said, and then it has to be scalable, it has to be up to date with the technology and prepared for the future technology, especially when we're talking of medical technology. It's not Zomato, it is Oyo Hotels or Rapido that I'm talking about, that you aggregate a few things and then go into market and get profits. It's medical device, medical innovations take pretty long. Maybe I'm ready with the technology here, but to get approval, to get the patient approvals takes ages. And we have to be prepared for that. So profits, you really have to think about thinking of making profits in maybe a couple of years. So that's the first reality that I learned the hard way. And then basically team building. The second things that says you have to have a project timelines as well. The financial roadmap, the project timelines have to be very precisely and very realistically outlined. Otherwise, you're going to land up in a mess. And there's a caveat here. There are almost 1,000 movies being shot in India every year. Only a few are blockbusters. The rest just can't even get back their money. And same with startups. So that's a lesson. So when I start out in a medtech sector, even the success rate is much less. Hardly 1%, even less than that of the medtech startups survive. So that's the area we're trading in. So reality, there has to be a reality touch. So coming to the casting, we're comparing with the movie. Coming to casting, basically you have to find a director. You have to find the movie cast and you have to find the support, the crew. So this is what it is all about. You have to have full-time employees there. A few core employees have to be full-time. You have the set of directors who don't have conflict of interest. They have subject area expertise, and you have to have some mentorship. So that is all there. You can't have chief actors shooting 4 movies. You know what a nightmare that is to get their times. So that is how. And then, of course, you have to know what you can do, what you cannot, and then you have to know limitations, what to outsource, and that has to be done. And third-party engagement has to be planned in advance. Second is basically when you come to the pre-production, when you get down to write the script, a good script is required, and then you have to the dialogue writers get, so that is the same equivalent. You have to do the paperwork. All paperworks have to be in place before you take the plunge, otherwise it's going to be a mess. And registration, first thing to start with, most of us did not know when we started the company that we need to register with the government organization and we have some tax benefits as well. We started our startup in 2015, and 2015-16 government came up with this Startup India initiative. This is such a great initiative by the government, and we really appreciate it, and you have to explore it to really enjoy the benefits. And so we have been funded by that. So we know the advantages. You have to get registered with the Department of Industrial Policy and Promotion if you want to get the tax benefits and the support funding initial, which is very crucial. Most startups fail because they run out of steam midway, they can't get the adequate funds. So that is important, and where your agreements are, you have to put in place the agreements, the founders agreements, the accelerator agreements, employee agreements, the third-party agreements. And of course, very important thing is basically since you are dealing with patients and medical conditions, the privacy and confidentiality clauses, non-disclosure agreements, patient partner, data protection, all these has to be taken care of immediately. And of course, you have to protect your IP rights. So the scouting has to start from this stage even before you start the project. Finding the funding, basically, this is the soul of a startup. If you don't find the funding, forget about having a startup. So you can't, nobody is assured when you are a startup, basically nobody is assured of the funding. We just, जैसे हिंदी में बोलते हैं जितना चादर है उतना पैर फैलाना उतना ही करते हैं. So that is what we do, and then but we have to really think of the next step. You can't really abandon the project midway after having maybe spent 1 crore or 2 crores and then you having coming to a point of no return. So it has to be planned adequately in advance. So it's basically about putting your money where your mouth is, or finding someone who does that for you. And it's basically several sources of funding. This is more, the startup ecosystem has developed quite significantly as we have experienced it over the past 7-8 years. So there is much support from the government coming in. Actually, our first funding was from the government. We won a biotechnology ignition grant back in 2018. And that was a 50 lakhs grant given to us for a proof of concept, which we have developed, and I'll be presenting that project in the next presentation that follows. And so that's a lot of funds that the government has earmarked. Dr. Bajpayee was speaking about it. The government has earmarked almost 5,000 crores every year. That is 20,000 for the next 4 years, like 20,000 crores for startups. And for the medtech arena is given emphasis. So we can take advantage of that. Apart from that, there is, of course, there is a scope of debt funding. Banks provide you loans on discounted rates. And there are, of course, angel investors who are interested, family trusts. But then, as I said, there is, the more private you get from the government spectrum to the private spectrum, it moves from no strings attached relationship to friends with benefits relationships. So it basically, you have to decide what you are going to compromise to get your share of funds. So it can be either equity dilation, it can be right sharing, or just simply paying interest. So it has to be very clearly delineated when you start out. And then we come to the main part of the project, the lights, camera, action part. Basically, this is when you go into production, you have the camera rolling, you have to have documentation, proper documentation, every step, every failures have been documented so that you can get the validation, and all this will come into, we didn't realize that early, but then we worked retrospectively, but that spends time. So all these have to be documented. Whatever you're doing, documentation is important. Your documentation of failures is more important than documentation of your successes. So that's the important part. We can't gloss over that. We'll be caught red-handed in the final approval when you come to FDA or maybe for a C certification or something. They look into the facts why you failed more than why you succeeded. So that is important. And then obviously the medico-legal conundrum is always be there, the regulatory certifications, as I said, patient data protection, what steps you have taken to ensure patient safety, and ethical issues. Suppose, like, I'll give an example, you're developing an anti-cancer drug and you are going to try it in pregnancy. Then it's a different scenario. You have to look at the ethical issues there. So, and then obviously this is post-production where you go for the special effects and all those editing, and this is where you ensure that it's sleekly presented, sleekly published. That is a part of ensuring your copyright over it. And you protect your trademarks, copyrights, and everything. Not for financing. Even if you want to be a good Samaritan and give it for free, then also you have to have a copyright over it. Because if you don't, somebody else takes a copyright and monetizes it, and then you are left out. So whatever be your intentions, first secure your copyrights, then you can decide what to do with your product, and be it a product or service. Then collaborations and expansions, basically this is finding a distributor for your product, and who will screen the movie for you and collect the returns. So this is the time to explore future commercialization and upgradation partnerships. So the distribution, basically commercializing the idea, you have to partner with private industries and government sector. We actually have a preliminary talk, like with my project, we are working on aortic valve reconstruction. We have a project offer from the government, initial plans, initial discussions, where if it succeeds, they might offer it for free in government sectors to try. So that is basically a win-win situation. We'll have more numbers. More number of surgeons trying our technique, and then the government is also saving money by replacing a valve replacement with a valve reconstruction. So this is a win-win situation. And the second is basically hand-holding, basically conversing industrial support. There are several kinds of support that you get, and most of it, we have to really be very careful about what you are walking into. Because industry supports, we have realized, comes in several forms. It can be just a good intention, hand-holding, guardian angel set of relationship, or the reciprocating partner, where we give something, you give some, you take some, a relationship. But then some industry elements we have encountered are meddling big brothers. They don't allow you to take your decisions. You have to be careful about that. And basically, we have actually encountered a few companies who really want to take over your, come with the intention of taking over your business and killing it, because it is competing with one of their future innovations. So you have to be careful what is the intention behind someone coming to help you. You don't accept all help, even if you are cash strapped. So that is an important decision. You can't lose control on your project if you don't do that. Then obviously that's the final rule every startup should follow. That's the only rule we follow. There are 3 rules for success, and you can read the rest. Thank you.
Thanks, Dr. Mahapatra. I think what we'll do is we'll have your next talk a little later, after a couple of talks, if you don't mind. So that, yeah, if you don't mind. So we'll have Dr. Hamdullah talking about his own sternal saw.
Hi. I think it's been excellent morning sessions here, and we have come to know the different facet of cardiac surgeon. Yesterday there was a discussion that when a cardiac surgeon starts thinking, he becomes a physician. But I think cardiac surgeons are an exception here, because I have always felt, and we grew up in that way, that you are supposed to be a hawk. When you are in an OT, you are supposed to be, you have the sharpest eye, the best skill hands, and the very innovative mind, because many times we ourselves put ourselves into trouble. Sometimes you make an easy surgery into a difficult, take it in a difficult path, and we try to get out of it, especially when it's a small aortic root. And there is where you start thinking, widely. And once upon a time, I always say that that concept of sutureless valve was far in my mind when I was doing my MCH, and we had encountered a very small aortic root and nothing going. And where at that time, even doing root enlargement was a taboo when it was a sure shot death certificate for a patient in a center where we never had done aortic root out. I had not seen aortic root enlargements. So such things is, as I said, that adversity is always the mother of invention. We always keep on reading it. So one fine day, this is what exactly happened, and somebody had packed my 3 sternal saw batteries without charging them and autoclaved them. So when I was about to open the sternum, 3 of the set, none of them functioned because they were not charged, and they were just. And then what came to my rescue was a giggly saw. So it is still there in my tray, the giggly saw, and I just was, unfortunately, the video was not taken, or I am not able to recover it. Then I had to just knock it off and open the sternum at that time. There is where I started thinking that there has to be alternatives here. So as I said, a person with new idea is always called a crank. So most of the cardiac surgeons don't need to be told, like without any offense, they say, pagal Parsi nahi bataya jata hai. When they say Parsi, it has to be a pagal. So it is something like cardiac surgeons are always cranks. Then only thing is, that is why the new ideas come in, and then that is how they move on. So innovation in turn is a creative idea that come up with into a viable solution. And the value of idea lies in using it. It's just not that you have ideas. You have to start thinking in that line, in that way, and try to come up with something which can be helpful in a larger interest of your of cardiac surgery. And the way to get started is just stop talking. I mean, you have to start thinking about it, and you begin to doing it. Till then, it doesn't really materialize. You'll be just talking in one fine forum. Oh, I also thought about it. I also knew that this way it can be done. It happens with our presentation. When somebody comes and puts up his paper with so many cases, oh, I've been doing this for last 50 years, last 20 years. But hello, you have not presented it, you have not put it up, you have not worked upon it, so it has no value. So you have to start developing on the idea and just start putting it up and bringing it into existence. So thus, don't acknowledge ideas, act on them, register them, and start working on them. Now, how to create on an invention? That's a lot of my work has been taken care by Shrikant, and he has given in detail how we go about. Now, if you say that, first decide on your invention. When you have an idea, put it on paper, start thinking whether it's worth it or not. Now, then once you have put it on paper, start doing a research. Just don't go off hat, oh, I have developed this and all that. It needs a lot of research before you start really conceptualizing it. And once you start conceptualizing it, then you need to start the document what Shrikant said. Everything has to be documented, put properly. Otherwise, it is those hyenas, when you make a kill and the hyenas take it away. So you have to start documenting things so that you don't lose your efforts into. So once I put it up, there are a lot of people who may be looking into it, and then once it is not registered product, they may just start doing it quickly, because it's very easy to imitate and move forward, like what China is doing. They have just picked it up and then moved forward, and then the whole rest of the world is just looking at, oh, they are so far ahead. But that is how it happens. You have to do a market research. You have to design your invention that you don't infringe on anybody's copyright. So all those things have to be done. Even if a small, your logo, there's so much of research that needs to be done into it, that it has to be copyrighted. It has not to, even the color combination can become a problem at times. So then you start prototyping it. I'm going to just concise the whole thing. That can be a whole lot of lecture here, because I think it's only 5 minutes. Then most important is, once everything is conceptualized, it's on paper and into action, don't forget to patent your invention, and then the manufacturing part, which all Shrikant has covered in his lecture. So this is how it started. So one fine day, as I said, when this thing happened, then I had thought there has to be a different way of doing these things. What happens if the same thing happens to somebody else? A lot of us use this sternal saw with batteries, and many times the battery is dead, or battery is not adequately charged, and then you are in middle of things, shouting, screaming, and started blaming other people. That's lose your temper, and it's an important surgery. This reflects on your surgery later on. So after that day, I just took a paper and started drawing simple drawings which have come into it. This is what I start doing now. Any ideas, Even if I'm in middle of my dreams and I get up in the morning, I remember it, I've started noting it down. That's a very good habit. Any idea, however foolish it may be, however stupid it may be, it may look to you, it may be a valuable thing for the world around, and it can become a great discovery, it can become a great invention, and it can really help. So this was told to me by one surgeon, a senior surgeon in UK. He said, however stupid idea, just jot it down. And someday you will realize, oh, this can come to your use. So this is what they say. Drawing a diagram, whatever, at that minute you have thought about it. So this is what I did. I just took a paper, pencil, and started writing down. Took a ruler, and somebody came into it. An orthopedic guy said, hey, what are you doing? I said, I'm trying to bring in a new type of a sternal saw. He said, it looks like you don't have much of a practice. I said, yes, I have to think about alternatives. The day I stop practice, there has to be an alternative way of earning money. I can't go hungry, I said. So then started painting it. I involved my son to start painting that whole thing up and giving nice imaging to it. Then I started looking into other saws, how they go about. I never imagined there is so much of technology, so much of thing in it, the magnetic rolling, the motor, the everything. It means a lot. And it was started becoming really fun, something different from cardiac surgery. Of course, I didn't leave my cardiac surgery the next day and started doing this. So whenever I got a time, I started reading about it. And there's a wealth of information. And it really enthuses you or encourages you to do cardiac surgery much better after all these side things that you do. As we said in the morning in one of the lectures, you have to develop something, a side hobby. So this is whatever interests you, please start doing it. And then as you go on, the first day may be difficult, but if you start reading, it may be all, something which is off hat, you don't understand anything. But then once you start getting into it, you start talking to people, sharing your ideas with somebody who understand all those things, then he comes back to you. And then you start reading about it, then you start getting into it. Then once I got this, then I just took another help of another friend who made all the diagrams of it on an AutoCAD and gave me the precise sizings and everything. That is how it moved on. But then ultimately this whole thing was coming to a battery operated thing. Then I went into an electrical guy. So your school friends are the best friends. They come to your help anytime. And you can just share things with them like you, as if you are a childhood buddies, and you share your toffee, you share your ideas with them, and then they start helping you with an open heart. So one of my friend in US who is working in IT, I shared him all those things. And then he came back with a design, and so all those things started moving around. Eventually it conceptualized into a little more now body or more realistic thing. So he gave it a steel appearance from a colorful appearance, and then we said, okay, this is going to be a battery. So a lot of thinking, a lot of work has been going on for last 1 year. It is still not final product, but then we are nearly there. So as I said to you, then I started comparing with other saw, because the minute you do something, it is always going to be in the market comparable with something else, and you have to compete. You have to take it in a positive way. So I had a striker battery sternal saw. So I said, how different is going to be from this? Well, my product has to be better than something else which I'm going to put into the market. One is the cost, maybe other additional things which I can bring in. Without that, your model is not going to function and work. So then that's where I said, can I put in an electrical wire into the whole thing? Can this video work, please? I don't know how it's going to work. It's a video, proper video. We tried. That's the reason I wanted my own laptop. No, it's not. So we decided to, it was working then, and it's not coming again. So it's a beautiful video. I mean, then we decided that it cannot be just battery operated. Then we took up a wire and we connected it. We converted DC into AC, AC into DC, and then we started using that thing, just made a small wire. So now this wire has to be autoclavable. Then it has to be or ETO. So then we can, no need to sterile. So we got that done in. So when we thought about a dual system. We had a battery also and electric also. If the batteries are there, you can use a battery. When the batteries are down, there is an additional thing, electric thing. So now it works much better with electric things. So I wish I could show you. So there, the same box we developed there, it can be an electrical port as well as it can be a charger port for my battery. So one box takes care of everything. There can be the other two, the 4 ports there. Then we decided for multi-use of this box, how we can go about. Even this video is not. So this was the first trial I used on my own patients. So initially when I started it, the raves were much lesser. I thought okay, that cutting was not perfect or it was really rough, because then we went back again to the my office and then in my lab, and then I started increasing the rave. From 14,000 I increased the rave to around 20,000, and then that is how we got. So now the current model what I have developed, it has 20,000 linear oscillation per minute. It has a 3 millimeter stroke, and then you should see when you use a battery, you just take it as a surgeon, we just open it and give it away. But then the minute you just have an inquisitiveness that just take a battery and see how it is functioning, what is the thing, press the button, whether it is a full flow in one go or it can be done. So all those things help you to think about it. So it is a 14.4 volt batteries, and it works both on mains as well as on batteries, and their wires are autoclavable. There's a variable speed. Sometimes the sternum in pediatric or something, you just don't need those 20,000 oscillation. So we have clicked it down into 4,000 at the 8. It can be like 16,000, it can be around 12,000. If there's a softer bone, it can just cut it easily. So those variable things we have thought about it. Then weight was very, very important. Certain sternal saws are very, very heavy. So we made it as light as possible, getting into 1.5 kilos. It is competitively to the what other saws are there. The noise, it can really give bad noise. It can heat it up. So that's all we have taken. We have put a coolant inside. And that's why I said it's so interesting. When you, as a surgeon, you start getting into it, you say that, oh, I can earn much better than doing this whole cardiac surgery at times. So noise decibel, we got it to 75 decibels, and the blade thickness. So first time we saw that the thickness, the gap in between was much higher. So in case if it goes more the depth of your sternum, then it can really injure your tissue. If it is short, then it won't cater to all sizes of height of the sternum. So the ideal height, we went around, we studied what is the decent height that we should give. And then that is how we got the length has to be 35 millimeter with a width of 7 millimeters. So this is what continuous thinking process and refining your product is very, very important when you are doing this. And so that's how a product comes out. It needs a lot of inputs, it needs a lot of efforts. It's not an overnight thing. You dream it and you conceptualize it and you bring it into the market. We have a lot of potentials. India has a lot of potentials. We have been only imitating the West, but I think all this product can be made here very much, and we can bring in products at much more. See, you go and buy this strikers, it's 10 lakhs, 12 lakhs rupees, and now if I have not yet decided the cost, it has costed me less than a lakh of rupees, and so is going to be a competition in the market. So a product which is 10 lakh rupees, 12 lakh rupees, if I can float into the market in a lakh of rupees, the centers.
We were just discussing the other day that he thought that as he grows senior or older, he might get less cases to do, but I think the complexity of work is so much for him that he has to do things on his own. So I'm sure that you have innovated quite a few things so that it's idiot proof.
Yes, I know it's not. This is your first slide.
Dr. Zainul, Dr. Zainul, I have a question for you. I think he's getting a type A dissection. Dr. Zainul, what about the sternal blade as such? That do you have to, you have to outsource from some company, or how does that work? Because that's the only thing which seems to be the one which will need reusing, right? Say, for example, when you talk about a needle and swedging, You know, you're always talking about the switch technology. So what do you do about
So
the...
right now, when I'm developing all those things, so byproducts keeps on coming later on. So now, right now, I'm using the same striker blades for myself. It fits into the same thing, into the assembly. So that's not an issue. But later on, suppose it becomes a product in market, then I have to think about it. Then the additional byproduct, I can talk to some companies and make these blades for me. So that can go about.
Dr. Mishra, over to you, sir.
Yeah. Thank you. Thank you, organizers, friends, colleagues, for giving me this opportunity. I'll start with a couple of innovative operations which I performed. I was lucky enough to get such a huge number of cases so that I can perform and exactly tell how this operation has to be done. So first of all, I'll come with the transposition of great artery. We know arterial switch is a standard operation for this situation. And there is only 20 cases till recent publication of transposition with a large aortopulmonary window is published. I was fortunate to get 4 patients during the 2007 to 2011-12. And then I have published this. This is one of the CT scan of one of my patients showing transposition with aortopulmonary window. And I operated first patient, and I was the second complex operation. Again, I'll say I was lucky. He was a 22-year-old software engineer from Vapi. He's a transposition with supracardiac TAPVC. So it was a natural setting for him. The already TAPVC is coming to right side, so it was a natural setting. But around 22, 23 years of age, he started developing severe cyanosis, and he is from the age of 5-6 years, he was going to different doctors, and nobody could do anything for him. The situation was acceptable, so they said, okay, you continue. When he's become software engineer, then he has somehow come in touch with me. So I thought a lot then how it should be done, and then finally I came to conclusion. This was the preoperative CT showing transposition with TAPVC. And then I did a sending. I just modified the entire sending operation. In fact, this is a simpler than the standard sending operation. Again, the video is available on the CTS net. So it's a modified sendings. And I could do 2 such operations. Before that, I did a standard correction for TAPVC, and then I did the sending. But this is an advanced technique where I use that common chamber as a pulmonary venous baffle because it is lying outside the heart, so I use that common chamber as a pulmonary venous baffle. So this was again one of the innovative operations. Then I published, and I feel very happy to share with all of you that this is the largest series of Al-Kappa. It's a very rare congenital anomaly, which I published 2 years back. It's the largest series in the world from India. So while I was analyzing the cases of Al-Kappa, thrice I came across a condition called congenital left main coronary artery atresia, where the presentation is 100% like Al-Kappa, but suddenly on table you find that it's a left main atresia. So first, I could not understand in my first patient what exactly it was. Then I discussed with my senior that this could be a possibility. The second and third, when Al-Kappa was not there, I could identify. And then again, I decided it should be done in this way, that you cut open, it's a bulbous end, you just cut open it, and then you can transfer it, the coronary artery ostium, to the ascending aorta, simply just like a proximal anastomosis. This is again one of the rare conditions. Again, going back to Al-Kappa. Al-Kappa is a cousin of Al-Kappa, where the left coronary artery is arising from the right pulmonary artery. You can see here that the left coronary artery is arising from the junction of right and the main pulmonary artery. And sometimes when the coronary artery is coming up, it is so firmly adherent to the ascending aorta that it is difficult to transfer it as a button or any other means. So this was a technique where I turned this button upside down. This button is actually facing towards the spine, and then I just turned it upside down, making sure that the slit is slightly lower down in the ascending aorta. And this technique, I did 4 patients with this technique. This is one of the operative photograph where just the button is excised from the MPA and right pulmonary artery junction, and now I'm going to turn it upside down and going to transfer to the ascending aorta. So these are a couple of the innovative operative technique. Now I'll come to the my device, which I started thinking about it in 2010. Actually, that was the era of so much of perventricular device. So people will leave 2 residual VSD and do 1 mid-muscular device closure. But unfortunately, cardiologists have no answer to the apical VSD. They just cannot do anything because they don't have any, in the apex, they don't have any space to inflate the right ventricular or the left ventricular device. What motivated me, in one of the case report, the cardiologists have inflated device in the left ventricle, then they don't have a space to inflate the right ventricular device. So they inflated the right ventricular device on the apex of the right ventricle. So one disc was lying inside the heart, other was lying outside the heart. So what I thought, if this a single disc can work, why can't we do something surgically? So this is the device. I made it with the hand. It is nothing great. We'll see the video. It's a very simple thing. Anyone can make it after you watch this video. So this is an echocardiograph showing the apical VSD. Now this is how the device is constructed. In-house Teflon felt, Gore-Tex patch, and a shunt graft, BT shunt graft, what we commonly use. Everything is easily available in our operation theater. So you suture the Teflon felt with the PTFE patch. It is just to give some strength to the device. And the PTFE patch gets firmly adherent to the septum, like we use in the mitral repair and all that. And in the center of it, the shunt graft is connected. So this is how your device is ready. Handmade device, just 10 minutes you can prepare inside the operation theater. So this device is ready. Now how we use it. So once you go on cardiopulmonary bypass, open the interatrial septum nicely, and with a right angle, you probe that right angle into the apical VSD. Anything more than 5 millimeter, you can easily probe with a right angle. You see the tip through the mitral valve and feed the shaft of the device in the right angle and then pull it to the right ventricle. Now the disc has gone with the septum. You just zigzag movement and pull it out and fix it with the interventricular septum. And fix it so that at least 2 places so that it will not move anywhere. And now your disc is close the apical VSD. Just we can cut the remaining portion. Close intra-arterial septum, pass a feeding tube, push some saline into the left ventricle and see if there is any residual leak. Most of the time it is not there. If at all, then some tiny VSD may be there. I'll just try to, no, sorry. So this is basically a simplified diagram for this. Echocardiography, you get an idea where exactly the apical VSD. The problem is your instrument will not go there. You can't identify exact margin of the right VSD from the RV side. Pass a right angle, which you can easily feel that your right angle has gone to the left ventricle side. Ask your assistant to retract the mitral valve. Feed the device in the right angle and pull it gently. Make sure that it didn't stuck up with the mitral valve leaflet. You have to be very careful, inspect it, and most of the time it will not happen. Just pull it and fix it with the septum. If you have any, most of the time you can see it, but sometimes it is difficult to see the apex from the left ventricle. You can use the dental mirror. Nowadays, self-illuminating dental mirrors are there. So you pass it, you can see that your device is nicely stuck up with the septum. So it's a handmade device, hardly cost anything. Recently, I got a patent also about this device. And this is working very well. In my hands, a couple of my colleagues, friends are also using it all over the country, and they are also quite happy with it. Now, pacing wire, this is again a modification of the standard pacing wire. It is just, I will not call as an innovation, but definitely if somebody likes, they can use it. These are commercially available pacing wire. The problem with the pacing wire, whenever you put a pacing wire, the sharp portion is always protruding, and there is a chance that it may hit any vital structure around. So I just modified long back this technique of preparing the pacing wire, and we'll see the video, you will understand it better. This is commercially available pacing wire. Just cut this covered portion, plastic portion, and then move it slightly onto the wire. Cut it distally, and again slightly move it so that your tip of the metallic portion is perfectly covered, and you can put it like this. It will, even if it touch adjacent structure, nothing will go wrong. There will not be any injury. So the traumatic things is taken care of. Just a modification of standard pacing wire. Now, this is a self-retaining retractor. Long back, I used to think that I should be going into minimally invasive cardiac surgery, should be doing, that was a dream almost 15 years, 16 years back. So I just designed it, took a help from an engineer from Bangalore. He has helped me to make this retractor. And this is how it's difficult to understand how you will use this retractor, but this is how it is used. You can just use this blade, fix it suprasternally and attach with the anesthetist bar. So it will give you a permanent, like a Langenbeck. It is always, it is there. So that gives you adequate space to work. But I am using only in the central shunt where you need to work on innominate artery or sometime an arch operation. But I am not using it regularly. And I never applied for the patent of this technique. So these are a couple of things which over a period of time I just modified or innovated on. But the device is really working well. Thank you. Thank you very much.
Thank you, Dr.
Okay,
Amit. We'll take the questions later. Can I call upon Dr. Tushar Shah for new sizer for TTK valve?
Good afternoon. My presentation is going to be an ultra short presentation. There's nothing great about the presentation, and I don't know whether it should be called an innovation or not. But it is important because once I was replacing a mitral valve, heavily calcific, using TTK valve, all sutures were taken. Valve was inside the heart, and to our horror we realized that the disc is not moving. As usual, we tried to rotate the disc to a different position, but there was no position which was comfortable. Ultimately, with the taster, we kept the disc open, tried to remove some tissue and calcium. We were so scared that something might go inside the left ventricle, and we were doing something which is forbidden. But still we could remove that impending tissue and calcium. This started moving well. But then I started thinking, if there had been something which could tell me before I implant the valve that this will hinder the movement of the disc, how nice it would have been. And that was the day when this design came to my mind. Innovation is taking two things that exist and putting them together in a new way. So there is nothing new inside under the sun, but still, if there are two things available and if you start putting them together, it might turn to an innovation. TTK Chitra valve is the commonest tilting disc valve being used in our country. 1.5 lakh valves have been implanted. Approximately 70% of them are mitral. And present innovation can be used not just for TTK valve, but it can be used for any tilting disc valve. This is the current mitral sizer. There is a handle and there is a blind end which is of different sizes so that we can know the size of the annulus. But what are the limitations of these current sizes? Surgeon's sizes only the annulus. While implanting the valve, he is unaware, as we were, of the disc movements after all stitches are taken and the holder is removed. Easy and free movement of the disc is pivotal to the success of the operation. And the disc needs an arc of 70 degrees. And that can sometimes create a problem as we faced it. Current sizer does not give us the vital information beforehand. And if the disc does not move, what are the options surgeon has? Rotate the valve. Rotation can be sometimes difficult, as it was in our case, and it doesn't solve the problem. Another option, which is even worse, is remove the obstruction through the valve, which we did, a forbidden thing. Things may not work out as you want. You may lose the tissue in the left ventricle and you are in trouble. Obstruction could be calcium, which was not removed adequately, or excess unemployed annular tissue, muscle, chordae, anything can hamper the disc movements. Removal can be dangerous and even sometimes impossible. And third option is even worse. Excise the valve, reimplant after taking care of the obstruction. Excise the valve and reimplant an undersized valve, or excise the valve and choose a valve of different design. They are dangerous because they extend the clamp time, increase the morbidity and mortality. Thus, there is a felt need for a better sizer design. Surgeon wants complete knowledge of the disc movements before he selects and implants a valve. This is the only way he can avoid unpleasant options which I narrated before. Current sizer fails to give this much needed information in time. And where are these situations where this knowledge is very important? When you want to preserve the mitral valve completely or partially, disc movement becomes even more important. Left ventricular cavity is small, or calcium has to be left in situ on PML or left ventricular valve. And sometimes in redo cases, extra tissues may not be completely removed. So introducing a new valve design. The design is extremely simple. And I always felt why I did not think of this design before. There is a handle and a dummy valve is attached to the cardiac end of the sizer. So while sizing, surgeon has an opportunity to check the movements of the disc. He can make sure that the disc will move well after the chosen valve is implanted. He can decide the best option in which the position in which the valve will be implanted. And if necessary, he can further excise the tissue calcium as needed. This is what I'm talking about. There is a dummy valve at the cardiac end of the handle. This handle from the top end, you can see the disc movement. You can use your taster, move the disc as an up and about as if you have already implanted the valve. And once you are happy, then only choose that valve. This different views of the same proposed design of the sizer. This is how it would work. Here the mitral valve is completely preserved. The proposed sizer is inside the left ventricle, and you can see the disc movement at the annulus. This is the proposed design of the sizer. There is a handle and there is a dummy valve at the end. So you know beforehand what will be the situation after the valve is implanted. What are the disadvantages of this novel design? It helps avoiding the unpleasant post-implantation situation. It guides the surgeon to take timely corrective measures. It gives added confidence to preserve the posterior mitral leaflet. There is no added cost or there is no time lost in achieving this. And it promises to be a new standard of care for sizing the valve for a tilting disc valve. My gratitude to Dr. Paresh, with whom I was operating, and we realized the need for such a sizer. To the TTK president of Heart Division, Dr. Sunil, who helped me in making a prototype which I have brought here, and Maitri, who also contributed in writing up. This is a very simple design, but again, simplicity is the ultimate sophistication. Thank you so much.
Thank you, Dr. Shah. I think it takes a lot of imagination to take two innovations and put it together. So don't underestimate your imagination too. Thank you, sir. Can I get Dr. Sudhir Srivastava, sir? He's, I think, one of the pioneering Indian surgeons who have actually transfigured robotic cardiac surgery, robotic CABG. He published a lot of data 22 years back, and now we are so excited that he's, created the Indian robo. We're looking forward to this talk, sir. And we're so happy to see the coronary anastomotic devices which you have, the octopus. It's all indigenous and made for, our country.
Good afternoon, and thanks, Dr. Shah and Dr. Goel, and dear colleagues here. So I'm going to talk about the surgical robot that we have created truly in India. And let's see, how does this work? So just to point out very briefly, it is different than Da Vinci in its entirety. I had done over 1,400 or so robotic cardiac cases when I was in US and other places, and 800 TCAPs. So the whole idea was to really create something which will be different, so we don't blame that we have copied things. Secondly, to add features that can be better for the surgeons, although Da Vinci is a great machine, and I think I'm eternally grateful to them for having shown a different pathway to do very complex operations that otherwise will not be possible, and particularly in cardiac surgery, whereby most people still do sternotomies because we don't have other endoscopic options. And so the idea was to make it different and also make it safer, more user-friendly, and keeping in mind a lot of things that are in the pipeline to be able to incorporate them. So with that, we have created this. I did create this SS Innovation Company, and currently lead the effort as chairman and CEO. So if you look at the current landscape, a lot of the robotic systems are basically economy-centric, and there's very uneven penetration, including United States. Everybody probably thinks that US must have, every hospital has a robot. That's not true. Only 30-35% hospitals have robot because a lot of these big universities have multiple systems. So the curve is skewed. And if you take the US, Europe, and Japan together, it's 93%. With a world population of 8 billion today, and that means 7 billion people do not have easy access. And the biggest issue was cost. And so the whole idea was to really change that. And not only the cost, but also the steep learning curve. And it kind of is a catch-22 situation. If you don't do enough cases because of the cost, you don't become good at it, and you don't want to pursue it. I operated the first case ever in India back in 2002 at Escorts, and Dr. Naresh Trihani there, President Abdul Kalam was inaugurating. And I show this picture mainly to point out that over 20 years, we have only 140 some robotic systems today in our country, with a population of 1.4 billion and 70,000 hospitals that we heard from our leaders here. And that's a shame. And so if you look at the volumes also, so it's less than 1% of the global volumes. Most cases are non-cardiac, and there is no organized teaching and training program in relation to robotic cardiac surgery today. So with this, we created this company with the vision of creating something that will be technologically more advanced. Hopefully, it will leapfrog the existing ones. And ultimately, the goal was to make it cost-effective, so more patients, not only just in India, but around the world can benefit from it. Because this is a universal problem. So the system was designed with the idea that it's, first of all, more ergonomic. So surgeon gets to sit straight. It's an open-faced console. There's a head tracking camera for safety, so if you look away from the monitor, system would not respond. Then large 32-inch 4K resolution monitor, beautiful images, depth perception, etc. And also we have given a large 23-inch 2D monitor. So if you, people who are familiar with Da Vinci, you have tiny 1.5-inch or so tile pros underneath. If you pull any image or EKG, it's meaningless. When I used to do TCAP, every time I have to ask anesthesia, are the STs changing? So the idea was to really give this thing where all the controls are there on a touch screen. And you can pull all of these things, hemodynamic, CT, MRI, or any angio. Don't have to get up and go on the computer to see the angiogram. So it's all right there in front of you. And secondly, we have a team and what we call SSI Maya. So they're really working on this whole virtual concept, and also any of these DICOM images can be converted on the fly into a hologram. So right there you have absolute exact anatomy of that patient, that view that you can manipulate, rotate, and slice, dice. So you have all in front of you. Sometimes we have intramyocardial LED. We don't know how deep it is. So do we keep digging? So you'll know exactly from the surface how deep it is. And also ergonomic hand controls, so they come differently. So you get to sit straight. And then standard foot paddles. And also the console is prepared right from the beginning for up to 5 arms. So we have developed some technology, as was mentioned about the anastomotic connector, and we'll use the 5th arm to be able to deploy, or other enabling technology. So it is quite advanced to my knowledge, at least at this point, nobody else has it. Hand controls, and modular design. So each arm is mounted separately, and it attains a height of roughly 7.5 foot. And so there's a human space and extensive reach. And you can use 3, 4, or 5 arms. And you have the freedom to place them wherever required based on the body habitus, target, anatomy, operating room environment. So it gives you the flexibility. So you're not locked in. And this way you can absolutely avoid collision. I have used the systems, and we had to reposition the arms multiple times, or they will collide, and sometimes it can be actually dangerous. And you can use up to 5 arms. Vision cart, right from the beginning, we have given 3D vision, same 32-inch large 4K monitor for entire team. So it is great for people who are training. They see exactly the same view. You don't need a dual console, as Da Vinci tries to do to sell. It's, in my opinion, it's a waste of money, because if you're training somebody, you are seeing exactly what your trainee is doing, and you need to take over 10 seconds, you change the seat, because you have. And then also nurses are seeing exactly where to go. So it is safer, no accidents occur because you know where to go. I was operating in South Korea, launching the program back in 2008. A nurse put the knife right through the heart. I asked her what happened, and she said I couldn't tell how deep I was going. So these things occur, and unfortunately we have accepted it and we figured out what to do. But the idea was to not only make it safer, more efficient, so the learning curve for the team is shortened, because there is hesitation when a new nurse is being trained to put the instruments in, if they don't know where to go. So this way it makes it safer, better quality outcomes, and the cart is prepared right from the beginning for tele-mentoring. So there is a recording playback capability, and we are working with the telecom companies in India to really be able to proctor people, because this is one of the challenges in cardiac surgery. Not many people are doing. You cannot just fly here and there. I used to do that in US. Every time I didn't like it, because you have no idea about what skill level the surgeon has, what do we need to do. So this way we can actually pull these 3D images on a high-speed network or upcoming 5G, and put a camera in the operating room. And we can guide the person from wherever. So it will make the procedures more efficient. And also, it will be, the team will be comfortable that somebody is watching you. They may not be in the room, but they're willing to guide you. And also, our next step is telesurgery. So literally, it's like having an attending in the room. And if you cannot do it, take over and finish it. We have partnered, and also on the back side, there is a separate 2D monitor. So the nurse does not come in front of the console or the vision card to block the surgeon's view. We are partnered with Olympus, It has an articulating tip, so you get rid of 30 and 0 degree, and it is also 4K. Beautiful view, and you can literally turn the camera with a little joystick. And a lot of time the bleeding in cardiac surgery, particularly when we are using heparin, will occur from the port, because we see everything else in a magnified way. So you can literally turn it and look inside. And so whatever you need to do, you deal with it. We also have developed pre-op guidance for the tableside team, whereby based on the menu, it will tell you what you are trying to do. It will tell you where to place the ports based on our experience, table position, and placement of the card based on our system. So really try to take the guesswork out. And these cards are motorized, so one of these days we will have literally on an iPad you punch in, and these guys will move on their own after the nurses have draped it. So again, the idea is to make it more efficient and remove some of the human errors. Over 30 different types of instruments for multi-specialty use, including cardiac. And I really wanted to revive the cardiac field that, as you know, Da Vinci does not make the stabilizer anymore. No other company is touching cardiac. And other specialties, and no disrespect to them, they have endoscopic options. You know, laparoscopic options are there. In cardiac, very small number of people are attempting. If you look at globally, India is probably one of the very advanced countries in terms of the adoption of minimally invasive surgeries. You know, I hear a lot, and that's wonderful. But it's still, if you can get beyond that to closed chest, it will be great. And so we have the stabilizer, atrial retractor of 2 sizes, left atrium and the right shorter blades, Resano forceps. And this is really what I call our crown jewel, anastomotic automated connector. It's a very miniaturized version with a 1 millimeter anvil, so you can put it in 1 millimeter vessel. It has a built-in knife and a row of micro-level staples. So literally in 6 seconds, you're done with the anastomosis. It is reproducible, mechanized firing. It doesn't matter what your human skill level is of sewing, especially on a beating heart, which has been the biggest challenge. That's why most people just don't do TCAPs today. So we hope to address that. And there are 2 versions. One is the handheld, another robotic, because not everybody will have the robot. So hopefully this can literally change, and this will make procedure more efficient. This is a lifeline for the patient if he can give better anastomosis, and will make it cost effective.
Introducing NADI, a miniature automated coronary anastomotic connector that revolutionizes the treatment of coronary artery disease. With its advanced technology, NADI enables a completely automated anastomosis that can be operated by the surgeon remotely or by the patient side assistant. The NADI procedure involves the use of robotic instruments that are inserted into trocars placed through fingertip-sized holes through the left thoracic cavity. Once the robotic instruments are in place, the automated coronary connector or NADI is inserted through one of the holes. Through a previously completed IMA takedown procedure, a graft is created and inserted between the cartridges of the NADI. The graft is then secured firmly with the help of other robotic instruments. To provide a stable surface for the anastomosis, a cardiac stabilizer is introduced to hold the coronary artery distal to the diseased part. A small incision is made on the coronary artery to insert the anvil of the NADI. With the press of a button, the cartridge comes down on the coronary artery with the IMA graft, and multiple staples are fired around the graft for a successful anastomosis. After the anvil is removed, the incision for its entry is closed with previously placed sutures. The NADI has 2 major components within its structure that facilitate such anastomosis. The knife performs an arteriotomy from inside the coronary artery, and the staples secure the IMA graft for a complete automated anastomosis. This restores blood flow to the coronary artery. NADI is also available as a handheld device that can be manually operated by surgeons for open procedures. Precise, rapid, and efficiently reproducible anastomosis by NADI.
So we also have developed multi-fire clip applier, so that each time when taking the IMA down, you don't have to take it out. Sometimes I have seen the clips will fall down or not loaded correctly, it will scissor or cut through. So this way one has ability in another arm to be able to just use them as needed, different sizes. We are really focused also on this whole new upcoming metaverse and this virtual reality, and our engineers have called it Maya. It doesn't exist, but you still see it. And so we are really working, and this will transform how we teach, train, make the procedures very efficient. And one of these days, we will actually get rid of Surgeon Command Center, where you have these classes with a projected large view, and you have hand controls. You just sit down in the chair and operate without a bunch of things that we have today. It will take us time, but we are heading towards that. We have Indian registration, CDSCO, ISO certification for medical devices, Make in India, which is given through an audit based on the percentage of things made in India, and we are on the government e-marketplace. We are going to initiate these overseas application, but we will get them. But we are not concerned because now CDSCO, and sometimes when I see that people put FDA and C, why do we not respect Indian regulatory body? It is high time, and we have had some meetings with the government people. They should, just like C is accepted, why is CDSCO not accepted in so many countries around us? So somewhere I think through our body or so on, we should see that, it's like government, these tenders come, only thing is FDA and CE. It's a shame that we don't even recognize our own regulatory body. So hopefully that will change. I show this picture. I operated on this 80-year-old farmer. Did 2 grafts, of course, with Da Vinci that time at Escort. And he went home in 2 days. A week later, he's back on the farm. And that's really what keeps me going, that we must do something to not only advance the science, but make life easy for our patients. So this is our young team of engineers, average age 26, 27, all homegrown talent. No one knew about the robotics, but just working with them day and night, we have produced. And one of the things that you may recognize, Dr. Fred Moll in the middle. So he came here in November. He is the founder of Da Vinci system, Intuitive Surgical, back in '95. He has joined us at this point in time, which is a huge endorsement that somebody who created Da Vinci is now part of SSI. So with that, thank you very much. I have some videos. I don't think there is time for that. So thank you very much.
Moment for us to give just big hand to the sir for his innovation. Sandeep Atta. Quench. I will invite Prabhat Datta to speak about the ex vivo lung perfusion.
Good afternoon. Actually, this talk was supposed to give by Dr. Sandeep Attawar, but he couldn't come. So from the KIMS team, heart lung team, I came to give this talk. See, we are for a heart lung transplant unit. So lung utilization rate is very low due to the lung retrieval rate is around 20 to 25%. Waitlist mortality is nearly 20%. As per Mohn Foundation data, in 2018, we utilized only less than 200 lungs, where the donation was more than 875. So thus to overcome this, there is one machine which is ex vivo lung transfusion, where you take the borderline lungs and treat it well. It's a Swedish machine which is quite expensive, but the concept actually came before Second World War, 1935. But the first case, successful case was done 2001. Then it got a CE approved, but it took another 18 years till 2019 to get its approval by the FDA. So these are the parts of this machine, which is Saipel and all described it. It has a ICU ventilator, one chamber, lung chamber, one centrifugal pump, heater cooler unit,
quick gas delivery combination like more of nitrogen, basically it is a deoxygenated gases, and one leukocyte filter. So the benefit of it is improving the donor lung function, increase the lung utilization, treat the donor lung without a systemic effect. Like you can give the higher antibodies without the effect to the kidney or lungs, kidney or liver. You can treat the pulmonary embolism with streptokinase or urokinase without any effect to the any body. And some hepatitis C patients are organ also taken for this. CMV patients also taken from the ex vivo treated with the CMV patient, the CMV immunoglobulins and all. So it gives the opportunity to reassess, otherwise just straight away disconnect the lung. And it helps us to detect the chemical biomarker like IL-6 and IL-8 and increase the duration of preservation. So these are the lot of clinical trials has been given. So you can see the conversion rate between the normal lung transplant and through ex vivo is nearly 70 to 100%, and post-op results are nearly same in terms of PGD, primary graft dysfunction, ECMO, ICU stay and all. Even a longer run of allograft dysfunction at the age of 1 year, 3 years and 5 years nearly same, except one study they says EVLP patients take a longer time to the extubation or ICU stays. So these machines are quite expensive. So in our KIMS, we have a R&D section, so we talked with them. So we made our own ex vivo machine. That is our innovations. Usually normally these machines cost us around 2 crores, which we made it in our own. You can see the oxygenator. You can see the rotor pump. These are the sensors. So getting a sensor for the vascular circuit for oxygen and carbon monoxide is very difficult. So we talked, this is the donor lung in the ex vivo chamber, which are not ventilating because the temperature is low. This solution is steam solution, which still we borrow from got it from Sweden. These sensors, getting the oxygen and carbon dioxide from this vascular substrate is very difficult. So we talked with our R&D section. The head of our R&D in KIMS Hospital is Dr. Bhujang Rao. He's from the DRTO. So he helped us to get these sensors through which we can online monitor the oxygen, carbon dioxide and pH. So these are the main innovation we have done to reduce the cost of this ex vivo. So these are the main components of this oxygen chamber. It can get its weight online. You can get the weight, real-time weight. You can get an X-ray in this, and steam solution still we are getting from outside, and centrifugal pump. So once you decide for the patient to take the ex vivo, you get your surgeons to put this cannulas, this funnel-shaped cannulas for the LA. It has to be stitched very properly. If it loose, it causes leak of the steam solution, which is quite expensive. So there are 2 protocols for VLP. Usually we follow the Toronto protocol, where we don't use any blood, we use the only steam solution, and we give the 40% of the cardiac output. A maximum of the donor cardiac output is flow. So running a VLP is a 4 components like circulation, then rearming, which has to be very gradually rearm. We need a team to run it, then ventilation followed by assessments. So in circulation, you use the perfusion solution, which is a steam solution, which is basically 40% dextran 40 and albumin. We add some heparin and steroids to it, and you can add any antibiotics whichever you like, depending on patient culture and sensitivity. Flow rate, maximum flow rate is a 40% cardiac output of the donor. So when you get this organ, you should know the donor body weight and height. So gas mixture, this is a special gas mixture we have to make it. That is another thing. You have to talk to the gas supply agents to give you the 86% nitrogen to 8% carbon dioxide and 6% oxygen. Maintain that is little difficult, and monitor the LA pressure and mean pressure. LA 3 to 5 and mean PA is 15. Steam solution have to reused. You have to replace the steam solution first or 500, second horizontal 250 ml. You can run this system 4 to 6 hours, and initially you add around 2 liters steam solution to the circuit. So ventilation, you don't start the ventilation in the beginning. When the temperature goes to 30 degree, you start 33 degree, you start the ventilation. It's a very low target value of FI of 21%. Target PCO 35 to 40. With the online sensor, you can see the PCO2 online. Recruitment done every 30 minutes and assessment done every hourly. Before starting the assessment, you should, before 5 minutes, you increase the tidal volume to 10 ml per kg, respiratory 10 per minute, and increase the FiO2. Then after 5 minutes, you take the ABG, see how the PF ratios. So these are strategies, these are in a nutshell. This chart will be always fixed in the perfusion table who runs the pump. So lung assessment done, we need the serial ABGs, monitoring ventilator parameters, especially the compliance and the peak air pressure. PA and LA pressures we monitor. PA PA less than 15, LA 3 to 5. It is more than that, you should have to discard it. X-ray, you can, in this machine you can take a X-ray also. It has to be X-ray compatible machine, and bronchoscopy done, just, and weight of the lung. The machine has a weighing machine. If lungs weight is going up, you know lungs is getting water, so that lung may not be good for the retrieval and retransplant. So X-ray in the ex vivo looks like this, and you can repeat it, and these are the monitor where you can the LA and PA pressures. This is the bronchoscopy. Our chief of pulmonologist vigil is doing on ex vivo. We are doing bronchoscopy. Usually you have to repeat a bronchoscopy. Initially when you start the thing, you do one bronchoscopy. Once you do till 37, after 1 hour you do bronchoscopy. See any repulling is there or any fluid is accumulating. So acceptance criteria, if after FVLP 3 to 4 hours, PA pressure is more than 400 and stable PA pressure and airway pressure, you can take this organ. If otherwise, if PA pressure is low and your compliance and airway pressure is coming down, it should not, compliance increasing, coming down, you should not take it. So we have done few cases. The first case is we run the EVLP for 3 hours, extubated on 4th post-op day. On 7th post-op day, was out of ICU and discharged on 7th. This is his testimonial. Next to our Kim's Hospital, we have a beautiful Hussain Sagar. He was walking there and he gave a testimonial for us over the EVLP. But it is not all the organs.
Myself, Uruj Abbas,
few are not able to use also because the PF
I am 42 years old,
so you have to discuss. So you have to talk to the organ donation agencies like government, Noto and Soto, they should allow you to do it. So in conclusion, clinical evidence shows EVLP is a useful tool to salvage a rejected donor lung with a comparable outcome as a standard lung transplant. It has a potential to targeted therapies like endothelial protection, immunological modification, and gene therapy, which is coming a big way. In future, most of the lungs will go through this so that post-op complications can be avoided and immunogenicity can modified. And it needs a team to manage it, especially the R&D. This is our HIMSS team. Thank you.
Thank you for nice presentation and good innovation. Now I will invite Dr. Srikant Mahapatra.
Well, good afternoon again. I'm back with my work as we discussed earlier. This is something that we have been working on since the past 8 years and with our startup initiative, and this is about automation in aortic valve reconstruction. Before we proceed further into the nitty-gritties of the technique, I'll just request you to watch a short clip that that will introduce.
A patient with a damaged heart valve is taken for imaging studies. The images from his echocardiogram, CT scan, and MRI are automatically transferred via smart interfaces to Aura, a cloud-based software solution. The patented algorithmic software does complex number crunching and is able to generate the computer-simulated model of the valve with unprecedented accuracy. The software facilitates testing of the model via simulations of physiological variables like blood pressure, viscosity, etc. After validation, the CAD valve model, dimensions, and simulation results are transmitted to the operating room via a smart device as the surgeon is starting the procedure. The surgeon quickly compares the computer-generated valve dimensions with the key in situ measured dimensions of the patient's diseased valve and approves the results. The 3D printing is initiated in the OT, and an appropriately shaped valve mold is printed using a specially chosen medical grade material. The mold is flash sterilized and passed on to the surgeon who proceeds to fashion an exact replica of the same using the patient's own pericardial tissue, which is sewn in place to form the neo valve. Aura thus ensures accuracy in delivering a customized and low-cost biocompatible valve substitute with reasonable longevity to recreate the patient's valve from his own tissue. Post-surgery, an echocardiography is done in the OT to validate a functionally satisfactory result. Thanks to Aura, all this is achieved in just 45 minutes.
So that was part of the elevator pitch, as we call it in the startup environment. You get just 2 minutes to project your idea to the investor or whoever is funding you, and you have to get appreciation or get a yes or no. So that's it. Let me proceed with the nitty-gritty, as I said. If we see the current challenges, whatever is displacing here is not displaying there. Okay, please get back. So, as we are all familiar with the current challenge, it's basically wire skill versus suture skill that we are struggling all the time. We don't know whether our friend cardiologist is our collaborator or a competitor. So, and so far our reaction's been like this or this. So none of it basically helping us, and really we have the actual solution, if we think about it, is basically this. We need to invest in innovations which I have been shying away from, and the cardiologists have embraced it. And that is where we need to really focus on. And our little effort is in that direction only. So if you come to consider the valve problem, around more than 3 lakh valve surgeries done worldwide per year, majority of them being aortic valve surgeries, and this cardiac valve market is growing at a CAGR of more than stuck at 2% for over the last 3 decades. And one reason for that is basically we're yet to find, after 50 years or so of working in the valve replacement and repairs, we are yet to find an ideal valve substitute. Dr. Joint talked about it. We are obviously innovating. We are going into plastics and polymers to look for it, but still we are without a perfect solution. But then why the perfect valve repair still eludes us? Obviously the answer lies in there are many ways to skin the cat, as they say. There are many masters and few learners, and basically there we don't still have, after all the work done by stalwarts, we don't have any big scale randomized control trial or any other big study to really compare those results. And a very strange fact again is that whoever proposes a new solution, the follows cannot replicate the same results. Obviously there is something amiss there, and this is not hard to explain if you look at the armamentarium that we have so far been exposed to for aortic valve repairs, starting with Dr. Duron's famous balls, and Mazzozzi technique, the Carver and Comber devices by Dr. Song in South Korea, and obviously latest flavor of the season, Ozaki. But if you really look at them, they're not the common thread that runs through them is basically they're all molds, sizes, templates fixed in shape, fixed in shape, but there is no uniformity in technique, no standardization of instruments and measurements. Every surgeon or every operator chooses his own, and there is no scope for objective validation. We don't really know whether an anatomically correct repair is basically going to stand the test of time. That is why there is a lack of universal applicability. And obviously, last but not the least, is biased, strong operator or surgeon bias exists. So these are the potential roadblocks which we try to address in our innovation. So what is Aura? Aura is a short form for basically automated universal reconstruction of the aortic valve. Each of those words carries a significance. Automated, we try to do away with the bias. Universal, we make it applicable to all types of patients, be it a pediatric, be it an elderly patient, be it big-sized, heavyweight patient or a small patient. So Aura is a cloud computing-based innovation that uses image-guided precision algorithm. It's guided by AI and machine learning in the background to basically virtually recreate what a valve would have looked like had it been normal in that patient, and then we recreate that in a 3D image and then customized to the patient and print it out in the OT and then use that to basically create a new valve for the patient. So, and it's compatible with any biocompatible material. So we are all familiar with the aortic anatomy, and when we simplify it further, that's how an engineer looks at it, maybe a hemodynamic scientist. So, so this is all, but sometimes we ignore when we design a valve solution, we ignore the physics behind it. There are so many kinds of forces that are acting on the aortic valve leaflets that when we simplify the solution, these are ignored, and that is one of the major causes for failure. The shear forces, the tensile strength, the cyclic bending, the oscillatory shear, all that has to be taken care of if we are really going to give a good result. But as I said, nobody beyond an echo, nobody assesses all these features in the OR before we say that the operation is done. So what is the concept behind Aura? Basically, it comes in 3 prongs. First is basically a seamless integration, co-registration of DICOM images acquired from at least 2 sources from echo, CT, and MRI 3D images. And then we apply a self-learning algorithm to really combine all those images and generate a 3D model which we virtually test. Before even printing it out, we virtually test in a lab using an algorithm that is cloud-based and that can be downloadable on your, say, a mobile app, and you can do it then and there once the CD images are processed. And all this can be done in a 45-minute sequence that we have time now. And then once that is validated, we go for a real-time customized 3D printing. As the patient, say we have an elective patient that's for AVR, we can process the images, get the CT done, process the images, get everything ready, get the virtual testing done as the patient is wheeled into the OR. And once the chest is opened and the patient is on bypass, the surgeon validates the sizes, then we can go ahead with the 3D printing, which takes around maybe say 20 minutes, and we can give the template sterilized. So, I'm sorry. Yeah, so that's the technology behind it. I don't really need to go into the details, but basically it has 3 steps, as you see. The data ingestion, that is basically DICOM images absorption and combining it to basically create a 3D model. Then the simulation that happens virtually on the computer to study the hemodynamic parameters. And then the in situ 3D printing. But the most important part of it is this continuously self-learning algorithm. That means the more you use it, more the machine refines itself, the algorithm refines itself, and maybe you do 10, 15, 20 cases, you will be more approaching precision than your first case. So this is what works and makes it an ongoing process behind the scene. And more the details of the imaging, basically this is how we acquire 3D images from a standard 3D echo. The beauty of it is all these technologies that I'm talking about are readily available, that have been there for the at least past 5 to 10 years with us. We are just providing a virtual platform to integrate all this. And then use these technologies to process it, the data that we get from the patient, and create a model for a valve reconstruction that we hope that will be more precise and more hemodynamic. So this is all, this is how we acquire images from the CT and maybe MRI images. These are softwares inbuilt into the algorithm that process. Once you feed the DICOM images, you are done. The algorithm does the rest. Those green lines we ignore. This is for a normal valve, but then the apart from the valve, actually the algorithm works by subtracting the valve from the whole mechanism. It reconstructs the aortic root, the aortic annulus, then imagines this is where the AI kicks in. It imagines how the valve would have looked had it been normal. And then for that patient, it recreates that valve. So that is the user interface. We have several parameters, base radius and all those things. We enter it, and then some of the measurements are picked up automatically, and then it is processed to generate a STL or stereolithography code that is used for geometric modeling. This is the virtual modeling, and this is the validation on your left. That is, we see virtually before going on for the printing. And this is a virtual simulation actually. Whatever the computer creates, we run it through a simulation mechanism where you actually see for yourself, the surgeon can see before scrubbing up that yes, this is the design, this is how it is going to work, and this is what he has in the back of the mind when he opens the aorta and takes the measurement himself. That is a mechanism for that, for the surgeon to override these measurements, and then again we can run it through this software that will tell whether the correction the surgeon is suggesting, whether that will work or not. So there is a double validation there, and this is the further after the testing is done and all that, we have this stability testing and stress analysis. I'd like to focus on this thing. This allows you to choose the kind of thickness of pericardium that you need to implant, because you know thickness with increased thickness there is increased tensile strength, and so you can plan for the patient what thickness of pericardium suits best, what orientation fibers. We have now companies making basically fibers pericardium that is decellularized without this aldehyde treating, and they can make it in a proper fiber orientation also for us. This is an Indian company that's making it. So this is possible. This is not a thing of the future. And of course, it tells you when the valve is not centered in the aorta. It tells you if the fiber orientation is unstable for this patient. We can adapt before going for the final surgery. Sorry, I don't know how to clear this. So, allow me this minute. So this is basically the final model. After all this testing, this is the final model that we get. And then this is the STL file that we generate. This is the subtraction model. Basically, the gaps you see on the side of the aorta is basically the space that we use to recreate the pericardial valve. This summarizes the process workflow. We get the dichromy images, then we convert it into STL or stereolithography model, or maybe any other technology, fused deposition modeling, the solar techniques of 3D printing. And please allow me one more minute to finish this. And then the process workflow is basically I can go for a direct mold, and we would use to cut a case pericardium and stew it in, or you can use for 3D bioprinting. So this is the final slide. So basically, I'll just summarize the USP of the technique. As you see, it's a democratized solution. It's a cloud-based algorithm, globally accessible, and we intend to make it available free of cost to anyone and everyone who's interested to try it out. And no logistic issues, free of supply chain dynamics of this on the bench manufacturing. No need to wait for the suppliers to supply it. There's no operator bias, automatic geometric modeling and validation, and this is self-learning module. Accuracy improves with usage. And then sizing issues obviously is not there because it's customized to patient by using software. It is user-friendly, allows manual override in the surgery. It's not going to fit in. You can make adjustments in the coaptation margin and the other aspects of the correction. And then it's universal. You can fix the
Vastav has shown, can be stapling technique can be used for coronary. So obviously this is possible. This is an existing technique, technology that we can do. And it is upgradable. It is compatible with future advances in medical imaging, AI, and machine learning. And then, if in future you have technology that can that allows rapid bioprinting, we can skip that mold stage and we can directly print the valve and implant it. Thank you. And this is thank you. Opportunity to invite you all to Bhubaneswar next year for the national conference.
Hey, careful.
So, see you in Bhubaneswar next year.
Thank you. Thank you very much. We'll just go with the next presentation with Dr. Jacob Jamsraj from Chennai. And Jacob is always remaining an interesting surgeon and innovative part also in Chennai. So we're just going to have discussion about and filming the heart. After all presentation, we'll take few questions from everyone, I believe.
Gives me great pleasure to be here. One of my favorite cities, and I've been teaching here for the greater part of the decade, mostly at the UN Mehta Hospital. Thank you, Gaurav. Thank you, Bhupeshji. Nawal. Thanks, everybody. We saw some of those beautiful pictures which Dr. Sanjeev Peter had shown us as he so beautifully flirted. How do we take baby steps when we want to do the same thing? My talk is going to be on that today. How do you document all the beautiful things that you do? So we do this for recording purposes. We want to document it. We like to teach, so we need to have that as good teaching material. We want to publish. So these are the various reasons why we do this. We can end up doing this with a lot of material, a lot of high-end gear that we may choose to procure, or just a simple iPhone or one of the mobile phones that you may have it. And whichever way you choose to do it, you need to have certain basics clearly understood. So I would advise you to use an SLR camera or a DSLR camera these days, and simple things that you need to know. So there are three things you need to know when you want to do your photography. How long you would expose the film or your CCD to, how much sensitive you want your CCD or your film to be, and how big an aperture would you choose. And each of these things has bearing on the end result. So you can use a small aperture, you can use a large aperture. The apertures go by numbers, and when you use a smaller aperture, you probably let in lesser light. And when you open up the aperture, you might, get a slightly brighter picture. So that's sort of difference. But it's something more to that. If you use a finer aperture, the things before and after your subject would still be in good focus, which means you get a good depth of focus, which is what you see on that side when you see that the entire thing is in focus. But when you don't want the entire thing to be in focus, and then you want just what you want to show to be in focus, then you use a larger aperture, so you bouquet the rest of the things, like as you do in portrait. So you get something like this, where only your relief is in focus, and the rest of the thing have gone out of focus. So if you want something to be in focus, just like that cap alone, you use a larger aperture, but if you want the entire field to be in good focus, you use a finer aperture. So a finer aperture is having a higher f number those stuff. You might have learned these things about the television and how the image is created on television, because you learn these things, it has some memory, but not the camera. So if you want the camera to get that, you need to have a longer exposure. Okay. So this gives you picture-wise, think of how your longer exposure versus your shorter exposure is going to be. Okay. Well, so using these two things, you can kind of get any situation under your control. But supposing you want to, show more detail, but you do not have the time. The thing is moving very fast. At the same time, you really can't. If these two things manage your show, then you need to get your sensitivity changed. Which means if you want to, get more out of your, say you want a more sensitive film, that means something which is dark can still be shown in a brighter light. Okay, so some people call it the ISO, some people call it the ASA, or the AGC, the automated gain control. So your CCD, how sensitive you're getting your CCD to be. The down play of this is when you make it too sensitive, it sometimes gives you grains. So, if you have a very sensitive film or your CCD to that, it can grain a bit. So you need to have it optimum. For normal pictures, one would choose an ISO 100, maybe 200. If you really want to take it more, 400. But if you really have a dark object, then maybe 800 or even 1600. Okay. So these are the three things which you need to play around with when you're taking your pictures. So if you have, so to summarize it, if you have a slower shutter, you can have motion blur, but in a static object you get more detail. And if it's your subject is moving, you have a shorter exposure. If you really want only to show that one particular thing, you choose a larger aperture. But if you want to have a depth of focus in your picture, you use a finer aperture. And if you want to tweak up your sensitivity of your CCD, you have a higher ISO. Okay. White balance. You need to balance out the whites in your pictures, and that is important. Okay. So this would tell you what exactly white balance is. If you're off white balance, you get something which you see to your left, and this is having a better white balance on your right. Okay. So you go to your shooting menu, you choose white balance, and then you can exactly tell what exactly you want. So if you choose something which is more incandescent or a lower number, then it becomes a little bit more orangish. But if you choose something which is a bit more, say, whitish or bluish, a bit more hotter or a higher number in your white balance, then you will get something which is more whitish or bluish. So you need to know where you need to take it. So this is how the numbers go. So if you have lower numbers, it's like more reddish and more, like candle lights and that sort of things, or lights like these. But if you have a more LED light and all that, it's a higher number. Okay. So you have something called a gray card. So you balance your white on the gray card, and then you use that balanced camera for your picture. So you get good pictures. Which has got credibility in its color. So see, this is membranous septum, but if you go a little bit more incandescent, you get this sort of a color, and if you go a little bit more hotter, you get that sort of a color. So that's something which you don't want. Okay, so that's one thing. So some little tips when you're starting off. Be sure that the image is in focus. It may sound very superfluous, but many of us take pictures and see it in a small screen. So you need to really see it in a bigger screen, at least on your laptop, to make sure that what you've taken is actually in focus. Okay, so that's very important. Focus could be continuous, it could be single shot, or it could be manual. I would advise you to get used to a manual focus. Then you know exactly what to focus and what has to be absolutely in focus. If you're not too keen on a manual focus, then you can go the automatic way. But then you need to take a few pictures to to get the ones which are actually good and the ones you are happy with. So this is something which is good and well focused, and the background is nicely bokeh'd out. So this is again well focused with the background bokeh'd out. So these are things that you need to play around with. And for medical photography, get the distractions out. And most of the distractions that we would encounter are, suction, cannulae, and your perfusion tubing and all that. And control the background. Okay, so what else is there also needs to be thought about. Not only what you want to show, but also what you don't want to show. So background. So say like specimen photography, then you need to have your background nice. This background is a galaxy granite, which is good, which kind of brings out these things, well. But if you choose a background like this, then it looks very awkward. And something which is reflecting too much also is not very good. So don't put your specimen in a stainless steel bowl and take a picture. Rather, you keep it on something. This is a dissected heart which I have kept on. Thermocol, white background is also good, even though blue seems to be the favorite with many of us. So see, this is a good background. And iron out the sheet. If you keep a sheet which is a little folded, as the nurse gives you, then you get that sort of appearance. So have a nicely ironed out sheet for this. It's a bit better. Okay. The background is very important. And frame the image with a reference shot. So what are you trying to show? Show a little bit more so that people will know what exactly you're showing and the size of it, and they get a mental image. And how do you light up your thing? Okay. So how do you manage your lighting? Flash is one thing, and how do you control your flash? It's probably better if you have lights, and then as you focus and take your pictures, you know exactly how you do it. This is more of a spotlighting. This is what you use from the OT. And please don't use OT lights at all. It's better to take without OT lights. It's probably just okay to take just with a tube light. You get much better pictures. So try to get the OT light out to actually take your pictures. The light should reach the depth. Okay, there is a papillary muscle cortex shortening which is shown, and that's got a little bit of a shadow. So you need to get rid of that shadow. So between that and this, you know what I'm talking about. And many times, don't use just a single light. Use multiple lights. Okay, using multiple lights will make sure that you will get rid of shadows. Okay, so this is a much better picture than this one. Okay, an angle of shoot. Your perspective, the depth, what exactly you're trying to show. Okay, so from the angle in which you're taking it, okay, it will tell the viewer, you give him a good perspective of what exactly you're trying to show. This is just a burst cake in a hot oven, but the depth of the crust, the texture of what has been burned and what has not been burned comes out so beautifully. So that angle of shoot is also important. And provide a scale. This, you can either provide a scale by itself, or many people like to have a scissors or a faucet, but I think a scale is a lot more nicer. And never be satisfied with your pictures. Keep on taking. And the same thing, picture, you take it 20, 30 times and you choose the better one. And you figure out in your mind what you did to get that and what was lost in something you didn't like. So be your worst critic. And of course, for medical legal purposes, you need to make sure that patient identifying things are not there. Even if you have the consent of a patient, please be very careful, because now I think one of the regulatory bodies have said that all patients will anyway give consent if you ask, so a consent is not valid. So believe me, consent is not valid today. So even if you have consent, try not to, try to be as preventive of the patient's privacy as
just to illustrate, okay? And try to get rid of as much blood when you are actually taking the pictures. You know, blood doesn't go well with what you're trying to show, and you're not trying to show blood anyway. So try to wash it all off, and even that little bit which is left there, I think is better washed off. The other thing is when you mount something for a picture, you know, you can float it. Okay, that is something I learned from my wife who's a pathologist. When you show, say, a cardiac tumor which has been taken out, especially when I took a picture of a fibrous fibroelastoma, it didn't look so nice. But then she showed me that when you float it, it looks so beautiful. It just spreads all its wings out and you can take beautiful picture. So float it out. So this is also a little bit floating. It gives a better appearance to that compared to what you saw before. And this is without floating it, and this is with floating it. And the sucked off the little ripened droplets, it will look even a lot better. So you display more details when you actually float it. And when you're floating it, you can add a little salt if you think it doesn't float so well. So if you increase the specific gravity. And points, you can add pointers to what you're trying to show. And colors and contrast they always show. And always keep a camera handy. Because you never know when you get something which you're interested in. This is just a clock which came out so beautifully from the LA village. This is the chicken wing in that big classification that you cannot remember. So always keep your camera handy. Always it has to be right next to you. A few tips on videos if you want to take them. Normally you shoot at 24 frames per second for a medical thing, and when you want to shoot the heart, it comes good. If you want to shoot more frames, like 2 or 3 times that many frames, you can show the whole thing in slow motion, but that's entirely up to you. That's when you become like some meter. And you use 150 for a natural blur. When you really do, that is twice the frame rate. So you know it doesn't come in staccato. It flows. Okay, so that's what you do. I'm just trying to show you 1 or 2 videos. I think I might need somebody like to show you this. Decided not to play a and I have something which used to simulate the beating heart, which I used for this. It's an air puffing machine, and you could show tricuspid valve actually working, and this is what we did. So a lot of innovations can go into filming for your teaching. A lot of these things we do in our yearly cardiac morphology course, so this is from that. And believe me, we are married to cardiac surgery. You can flirt. One of the best way to flirt is through the lens of the camera. And it's always better to flirt with your own wife. So photography is one way of flirting with your own wife. Thank you.
Brings us to the end of this session. May I request the chairpersons to give the mementos to all speakers. May I request the speakers please come on stage and give the mementos. Dr. Ajay Patil. Dr. Srikant Mohapatra. Dr. Hamdule. Dr. Tushar Shah. Jacob James Raj, We'll move on to the next session of the evening. May I request Dr. Devguru to please come on the dais to moderate the session. Dr. Ramasubramanian.
These are the parameters which were defined by American Heart Association, what is cardiogenic shock, with a systolic BP of less than 90, the cardiac index of less than 2.2 liters per square minute, and the pulmonary capillaries. Other forms of management of the cardiogenic shock, and these are the various temporary mechanical support devices that exist for us to use. If ILB was kept in descending thoracic aorta and then the mechanical support device, and in left ventricle to aorta, generally we use the impeller, and from left atrium to systemic artery is a tandem heart, and right atrium to systemic artery is a peripheral VA. If you take this impeller theory, it is a continuous flow microaxial pump with the propellers at the tips of the catheter that are portioned across aortic valve. This is based on Archimedes' screw principle. They deliver the blood from LV into the aorta by creating the negative pressure at the propeller tip, which draws the blood into the envelope and through the cannula. And the various insertion techniques, generally percutaneously they use femoral route. The other route is surgical technique, axillary route. These are the various types of impeller family, ranging between impeller 2.5, impeller CP, and impeller 5, and LD means it is the direct implantation, and impeller RP is the right side impeller, and the latest is impeller 5.5 with smart assist. These are controlled by automated impeller controller. So if you take the impeller parts of the impeller at the insertion side, distal end will be the flexible pigtail, next is the tear drop, next is the inlet, the following the cannula, and then outlet followed by the motor housing, next is the shaft. impella. So the principle of impella is that once they place in impella placed at the outflow, at the aortic root, it increases the blood flow, aortic pressure, and thus increasing the coronary flow, leading to increased oxygen blood supply to the myocardium. And simultaneously, it increases the cardiac power output. And at the inflow level, it decreases the end-diastolic pressure and end-diastolic volume, thus decreasing the wall tension and mechanical work, and also decrease the microvascular resistance, thus increasing the coronary flow. And it decreases the oxygen demand of the myocardium. And the mechanism is the rotating impeller pulls the blood to the cannula, which was shown there, and with an automatic impeller control, controls how fast the impeller rotates. So the faster the rotation, the higher the blood flow. So once hemodynamic stabilization occurs, we unloads the left ventricle and coronary perfusion, enlargement perfusion increases, and the right side support if there is a right ventricular dysfunction. This also helps in early mobilization of the patient. If you see the pressure volume loops, what changes up in the cardiac shaft when impeller increases. The right side is the normal pressure volume with acute cardiac shaft, and left side is the once the impeller is used and implanted and working. Typically the end-diastolic and systolic volume and diastolic volume gets reduced, and the cardiac output increases, and the end-diastolic pressure volume relationship also comes down. So typically it goes to a triangular shape once the impeller is used. The indications for impeller is mainly in cardiac shock, or generally in patients with acute MI situation, and also in advanced heart failure, and post-cardiac shock, pulmonary myocarditis, refractory arrhythmias, and also used in right heart failure. Generally, cardiologists use for high risk chip PCI, and some literature shows that in optom also with complex anastomosis people are using, and also use preoperatively in patients with ventricular septal rupture at the bridge to transplant, and also in acute rejection post-transplant, and also used in post-ECMO to reduce afterload in the form of ECMO. So the technical considerations are the larger the impeller size, that is 5 or 5.5, it requires surgical insertion, and once the impeller is connected to the extracorporeal control system, it helps to regulate the function, and it has 9 different speed settings, P0 to P8 for the propeller, and also has a purge system that infuses 5% exposed with heparin to the impeller to minimize the clotting, and forms a hydraulic shield that prevents blood from migrating into the motor housing. Surgical techniques of insertion is most of us know the right axillary exposure, and that is the right intracardiac incision. Once before that, generally the size of the axillary artery should be measured with the ultrasound or CT. It should be generally 6.2 millimeters, and after that, once it is exposed, we can put a 8 millimeter background graft, and this can be brought down with the subcutaneously 10 centimeters below the clavicule, and then brought out. And also, then once it is brought out to the graft, we can put the axillary insertion that was shown there. We can keep that, and then for passing the impeller, we have to use guidewise 0.035 initially, followed by exchange with 0.018 impeller guide wire, and then connect to the automatic impeller control. So this shows us how to fix, and then at the first say that torque level, the 2 burst adapter site is shown there, and how to fix the down the red impeller part and other things. And if you want to after implantation, sometimes the impeller moves sometimes up or down. So to adjust that, then you have to adjust at the level of 2 burst catheter only, not at the left bucket. So these are the complications of impella. Hemolysis can occur owing to mechanical shear red blood cells is a common, and sometimes there will be persistent hemolysis which can lead to kidney injury, acute kidney injury and worsening anemia, and sometimes the manual trauma, local trauma to the impella device and produce aortic insufficiency. And sometimes if there is a severe peripheral arterial disease, then it increases the vascular complications. These are general complications related to implantation to the healing level. There are other complications that occurs in ICU. So in some patients, the impella was inserted after that impella impression in cardiogenic shock. They operated after 4 days, 5 days later once the hemodynamics are stabilized. And so once pre-impella, all the parameters of lactate, creatinine and aspartate, AST and ALT was very high. And once the impella was implanted before surgery, all the parameters has come down, which helps faster recovery of the patient. And after implantation, some problems can occur with the impella cannulas and other things, how to manage this. The contraindications for impella is mural thrombus in the left ventricle if the patient has a bleeding disorders in presence of mechanical aortic valve and sometimes severe aortic stenosis, severe aortic insufficiency, or if it is severe peripheral vascular disease. These are the contraindications. So this impella 5.5 is recently developed and then FDA approved. This is the sumptuous heart pump. This is the latest generation microaxial valve. It has a smart assist system. It can support longer duration. FDA approved is 14 days. But clinically, articles says that they have used more than 50 days. Some articles have 70, 80 days also. And it has a good cardiac output. Maintenance 6.2 liters per minute, and it has a better unloading of heartbeat, can be used as a bridge to transplant. Some of the things which have to be taken care when the impella was inserted pre-operatively and then taken for surgery. At the time of aortic transplant, we have to do epi-aortic echocardiography and check the impella motor proportion, where exactly it is. And at the site of cross-clamping, if the impella motor is at the site of cross-clamping, then the impella is pushed forward down into the heart, and then the catheter shaft comes across the aortic transplant. And at that time, the pump speed should be set at T1 and then put the cross-clamp. So after cross-clamping, first dose of cardiac can be given antigrade and then check the aortic root pressure is sufficient or not, because the cannula goes through the aortic wall, the pressure may not be sufficient. So if it is so, then they increase the pump impella speed to P2 level and then complete cardiac rhythm. And after completion of cardiac rhythm, keep the pump on surgical mode. And if second dose of cardiac rhythm is required, you can go for use the route of recovery. And once the procedure is over, then we want to remove the cross clamp, then impella pump speed is kept at P0 to P1 and remove the intracardiac aid, and then impella portion is reduced to the help of the TE, and after that the cardiac pulmonary bypass support is gradually decreased and impella support is increased. So impella, what is surgical mode is the pump can be stopped without impella alarm and then persisting into the system. We have one case with 62-year-old male with diabetes, hypertension, with antiviral severe LV systolic dysfunction, with ejection fraction of 27%, with a severe triple vessel disease, dilated LV, and with a myocardial edema on the septum. And this is the angiogram of this patient, severe triple vessel disease. And has dilated early, elevated territory is mechanical, severe early dysfunction, equivalent F is 26%. And this is a cardiac MRI with 25 to 50% subarachnoid cardiac scar in the proximal radial level, and with the transmural scar in the medial distal radial, the scar is 43%. So once the patient is taken for surgery, these are the parameters, and we have done CFEG with 6 grams, and later the patient was shifted to the cath lab and we inserted the impella. After the impella insertion, we have to see the placement signal waveform on motor current waveforms and check the impella position. And these are the various measures depending on the type of impella, how length should be there below the aortic annulus. And post-implantation, this is the routine care to be taken. This is the post-implantation of the impella, and then how to check by echo. And after placement of the impella, these are the aortic signals and the motor current levels, that is with a mean pressure of 72 and cardiac output of 3.5, which is for now. And after that, every day we have to measure all these parameters like cardiac output, mean heart rate pressure, COP, urine output, all those parameters to be measured. And then post-implantation, cardiac output has increased to 4.7 liters per minute. And then after 3 to 4 days, patient was extubated on post-operative one, and impella was removed on post-operative 3 days, 4 days of support. And next, this is at the end of 5 days, the patient is mobile, and this is our team. Post-operatively, the time of discharge, the 2D equilibrium showed the yield of 34%. These are the published literature where the very rapid temporary mechanical subject is support the people and cardiac certifications. And the UNOS has organ sharings, UNOS has changed the policy recently, and accordingly the use of mechanical sublatries about temporary mechanical has increased. So in 2015 to 2019, the impella is increased from 1% to 4%, because the waiting list has the higher priority with temporary sublator as
Dr. Rama, thank you, Dr. Rama. Any questions from the audience? What's the cost of the impella?
Impella 2.5 is 22 lakhs, and this impella CP is 24 lakhs.
How much ACT do you maintain?
160 to 180.
On it. Any questions? Thank you.
Thank you, sir. May I request Dr. Dev Guru to present a moment? We move on to the last session this evening. May I request Dr. Dev Guru to continue? May I request Dr. Tushar Shah to please chair this last session? I request Dr. Sri Krishna to please come forward and
Can there not be a session without chairman?
Good evening. I am the last batsman for today, and at the outset, I would like to thank and congratulate Dr. Bhupesh and Gaurav, Abhishek, and Tushar for an excellent conference all this time. And thank you for giving me this opportunity. My topic for today is chest wall reconstructions. Chest wall reconstructions are probably necessary in these following situations: tumors of the chest, primary and metastatic, repair of congenital defects, infections, both bacterial sepsis, Pseudoaneurysms, as well as radionecrosis, and in extensive trauma. Tumors of the chest wall, this is some of the common tumors that we see, both malignant and benign. There are other tumors from the surrounding organs, especially the breast and the lungs, which can invade the chest wall and which may require excision and reconstruction, or they could be metastatic from a distant site. These are generally slow-growing masses. About a quarter of them are asymptomatic, and the elderly people are more likely to have malignant lesions. These are a few common tumors that we see in the chest wall: osteochondroma, fibrous dysplasia, plasmacytoma, or a chondrosarcoma of the sternum in the back. So the principles of chest wall reconstruction, resection and reconstruction involves a full thickness wide excision of the tumor with one rib margin. The goals in reconstruction is that obliteration of the dead space, restoration of the skeletal rigidity, prevention of lung herniation and scapular impaction, protection of the underlying organs, and maintenance of respiratory mechanics. The three major tenets of chest wall reconstruction are wide excision, management of the pleural cavity, skeletal support to prevent physiological flail, and soft tissue coverage. Management of the pleura involves restoration of an airtight seam, obliteration of the residual space, and closure of an existing bronchopleural fistula or a tracheoesophageal fistula at present. In skeleton, a full thickness skeletal defects that have the potential for paradoxical respiration should be reconstructed. Patient with a large chest wall defect more than 5 centimeters or defects involving more than 3 ribs require rigid reconstruction. Two factors should be considered: the location of the defect that you leave behind. If it's in the lateral or the anterior wall, then they require rigid reconstruction. If it's in the posterior wall, if it is covered by the scapula, you could close them primarily. The size of the defect also matters, as we already talked about. So the ideal prosthetic material or the used for the chest wall reconstruction would be, they should be rigid, they should be inert to prevent infection and allow fibrous ingrowth of the fibrous tissue. They should be malleable to
be shaped to the contour of the chest and preferably radiolucent to allow radiological follow-up in the future. This is just an algorithm of how we go about tackling the chest wall reconstruction, which we already alluded to. This is available in the Shields textbook. This is an example of chest wall reconstruction with a rolling patch, a Gore-Tex patch, or more commonly, which we commonly use, is a methyl methacrylate sandwich patch between two layers of a rolling mesh. This gives rigidity as well as stability for the defect. Rib fixation can be done by various implants that are available, right from an intramedullary nail to a jurate strut or the more common Stratos system. This is an example of how the multiple chest wall fractures or defects in the chest wall are reconstructed with a plate implantation. This is a titanium mesh that has been used more likely in the sternal reconstruction. Nowadays, 3D printing has come into vogue. The material that is used is polyether ether ketone. It's called PEEK. So this is a rigid structure, and that it can be molded or printed according to the shape of the sternum and the ribs or whatever defect that is there from the CT images, and this can be implanted onto the chest wall defect. These are various examples of sternal reconstruction on this side and the rib reconstruction on your left, on your right, with the PEEK material. Soft tissue reconstruction is necessary whenever you put an implant, and a soft tissue cover is absolutely necessary to close the chest wall. It can be usually be used as pedicle myocutaneous flap, or an augmented flap, or a free myocutaneous flap. It is always prudent to involve the plastic surgeons to help reconstruct these defects. These are various muscle flaps that are available. You have the latissimus dorsi, which is based on the thoracodorsal artery, usually used for the anterior and lateral chest wall defects. Pectoralis major, based on the thoracoacromial artery, used for the anterior and midline chest wall. Serratus anterior from the lateral thoracic artery. Rectus abdominis from the superior epigastric artery, usually meant for anterior, midline, or the sternal defects, and omentum based on the gastroepiploic artery for infected sternal defects. Example of a pectoralis major flap, a latissimus dorsi myocutaneous flap, which is rotated onto the chest wall defect, and the serratus anterior flap as based on the lateral thoracic artery. This is an example of a rectus abdominis flap and an omental flap. Omental flaps are usually used for infected sternal wounds or infected sternal defects. Some of our own patients, this was a rolling mesh reconstruction used in a chondrosarcoma sarcoma of the patient who had a huge tumor extending into the chest, which was removed in total and repaired with a rolling mesh. Here, a latissimus dorsi flap is being used in a patient with a low-grade fibromyosarcoma. And here, in a patient with Ewing sarcoma, a complex myocutaneous latissimus dorsi and a serratus anterior flap has been in combination was used to close the defect. This patient had an angiosarcoma of the second rib high up in the chest posteriorly, and which was more or less underneath the scapular area. So this was excised and closed primarily without any reconstructive material. So the sternum has its own challenges to provide both stability and soft tissue cover, and the commonest material or the commonest things that are used to reconstruct the sternum are the sandwich patch using the methyl methacrylate, or you can have custom made titanium plates and with or without rib reconstruction. This is an example of a titanium plate on the sternum with extension onto the ribs bilaterally over an underlying proline mesh to cover the defect. Recently, sternal allografts have been in vogue, and this is the sternum is harvested from the allograft or cadaveric tissue. This is initially preserved in an antibiotic solution for 72 hours and then irradiated and preserved at minus 80 degrees centigrade till it is used. Just about 12 hours before you use this graft, it has to be thawed at 4 degrees centigrade for 12 hours and then used on the patient. This has been in vogue in many centers. We have not done sternal allograft till now. These are examples of the sternal reconstruction with and without a titanium plate, and these have given good results. The latest technique is to use bone marrow mesenchymal cell therapy, which is injected over a matrix, and this allows both chondrosynthesis and osteosynthesis to develop, and then it become incorporated into the tissues, and then that can be used as to stabilize the chest wall. This is a case of a chondrosarcoma reconstructed with methyl methacrylate patch. Almost the whole sternum needed to be excised, and then we had to repair it with a methyl methacrylate sandwich patch. This is a large protruding tumor in the front of the sternum, which was excised, and a complex myocutaneous flap. With the help of the plastic surgeons, we were able to harvest it and then flip it around and close the defect. This is another algorithm just to show you the different treatment options for just infected chest defects, sternal defects, or tumor defects. Our own experience is about 14 years. In the 14 years, 36 cases. We mainly have used Marlex mesh, methacrylate mesh, 2 had titanium plates, and 16 had major reconstructions. We have had fairly good results with no mortality, and this series does not include the mediastinitis following sternal renaissance after cardiac surgery. Although we have had many cases of that, I did not include them in the tumor series. Congenital deformities require reconstruction again. You can do it either by the open procedure, the Ravage method, or by the minimal invasive MES procedure, which and to go about with this in this talk would be a lot of things. I don't think we have the time to discuss these. Rib fixation in trauma has become a major thing nowadays, more so with the industry pressure, and we need to know who, what, and when to do a rib fixation. The standard technique that has been advocated is a flail chest with more than 5 ribs requiring mechanical ventilation. This has been an accepted method to fix the ribs. The other indications for rib fixation is probably more than 3 ribs with extensive bicortical displacement and requiring ventilator, or in a severely displaced fractures formed during a thoracotomy for another reason. For a deeper reason, you need to do a thoracotomy, and on the way out, you can fix these ribs. And this is typically called the on the way out fixation. And again, rib fixation may be used for long-term non-union of the rib fractures causing pain. Again, as we said, the same implants are available. The Tourette stretch or the matrix rib fixation system or the Strato system, the various things that are available depending on the patient's affordability and availability of the implants. In the past, some people have attempted to use bioresorbable chest plates, but these have been prone for non-union and non-healing of the rib fractures, so they are no longer popular. Last two slides. Custom-made implants are available, and these are 3D printed custom-made plates with electron beam melting, and they can be tailored to individual patients and then used on them. So these are examples of the rib fixation following a severe trauma of the chest. And this is a classical on the way out fixation. This was a gunshot wound with a lacerated underlying lung, which we had to go in and then do a excision of the lobe. And on the way out, the shattered chest wall was fixed with the plates, and then we reconstructed this. This was a massive soft tissue injury following a rip of the chest wall in a patient in a person who was working with a timber sawmill. The saw snapped and ripped across his chest, and most of it was soft tissue injury. So we were able to do a primary repair of the chest. So this is again an algorithm for the rib fixation. Literature, among the literature, although people have started using rib fracture fixation quite often, the standard meta-analysis has only advocated rib fracture fixation for flail chests. Isolated rib fractures are still not for fixation, and although the industry and the corporate setup have started doing that more often, and it is not to be recommended for that. So the take-home message, I would say, wide excision of skeletal fixation and soft tissue coverage are the major tenets of chest wall reconstruction. Patients with a large chest wall defects require rigid reconstruction to achieve respiratory mechanics, stabilize respiratory mechanics. Rib fixation for patients with flail chest more than 5 ribs are advocated. It's also recommended for patients with severely displaced fractures on the way out if they have required a thoracotomy for any reason. And rib fixation for isolated rib fractures is not justified. Thank you.
Thank you, sir. We come now to the last talk of this evening and the conference. May I request Dr. Pranav also to please come on stage. Dr. Shukla.
oncologist specializing in thoracic cancers, and today I'll be speaking on fluorescence guided surgery for thoracic cancers. I come from the city of Hyderabad, which is known for its art, science, as well as technology. And the place I work at is called the Metropolitan Cancer Hospital. It's a 650-bedded tertiary cancer center with around more than 7,000 surgeries per year. So, in thoracic services, for an oncologist, these are the procedures we normally do: hysterectomies, lung resections, mediastinal tumor resections, chest wall, and internal mammary lymph node resections for carcinoma breast. So, what's the scope of fluorescence for each of these? We'll see. So, the basic physics of fluorescence is our eyes can see only until a fixed wavelength. Above that is the near infrared, and that's where this camera of fluorescence guided surgery comes into play. It will emit one fluorescence emitter, and there will be absorber which will absorb that. So you would have seen these night vision goggles and cameras and infrared. So these are capturing that wavelength which we are not able to see normally. Even with our camera phone we can capture it, but there will be a filter on our cameras which does not allow that to get captured. So that's the physics. The cost is generally one vial will cost you around 2,000 rupees, and from one vial you'll be able to use it for 10 patients a minimum. So what do we do in our hospital? There's an instruction that in the morning, one vial will be opened and it will be distributed throughout the OTs throughout the day. So it ultimately costs around 250 rupees per patient. Okay. So let's begin one by one for the indications that we earlier saw. The setup is generally you can have an open handheld camera, or you can have it integrated into your lab or robotic systems as well. So the first indication that I'll be speaking is the commonest cancer that we see in our thoracic services, which is the esophageal cancer. Based on the routes of administration, how it affects, I'll discuss in the later slides. So, for esophageectomy, the most common indication that we use it for is generally the thoracic duct mapping. So, lymphangiography of the thoracic duct in real time while operating. We do that by injecting ICG into the groin node via ultrasound. So we only do the ultrasound, we inject 1 ml of ICG in one of the groin nodes, and within 4 to 5 seconds you will see that fluorescence will come into the thoracic duct. So that is done in supine position, we turn the patient in semi-prone, and as soon as you put in your scope, you can see a nice green duct which is seen across your screen before you even started your surgery. And this fluorescence will remain at least for 4 to 5 hours. You don't have to worry that it will go away in 1 hour. So when we are working on the dorsal side of the esophagus, on the mesoesophagus, you can clearly see the ICG in the thoracic duct throughout your procedure. So if you want to clip it, you can clip it. If you want to save it, you can save it. If there are some branches coming from them into the esophagus, you can clip them carefully. And even in situations where there's a lot of fibrosis after radiation, you can still go very near to the thoracic duct, carefully dissect it out, and be sure that you won't get any dye leaks in the post-op. So you can see here, no ICG guidance is there. You can barely make out the thoracic duct. Some experienced surgeons might be able to do it. But for a beginner, it's so easy when you can see the thoracic duct throughout its course, and you can ensure safety of the patient, avoiding dye leaks, which is a very deadly morbid complication in the post-op. So especially for learners, till your eyes get tuned to seeing that thoracic duct even without anything, this ICG can be helpful in those cases. Even if you are doing a transhiatal procedure where you are operating from the abdomen through the crust, even still you can see it. Here I am just showing morphological variation where there are 2 divisions of the duct seen in the supracardial part. So a lot of variations now we are starting to see after when we have used ICG in all our cases. So as I said, the transhiatal view allows you to see through the crust. You can see the aorta, and onto the right side of the aorta you will see the thoracic duct vertically coming down. So if there is need to clip it very near to the crust, you can do it from the abdomen as well. So dye leaks is a problem that for which patients get referred to us. So this was a policeman who got stabbed in the neck while arresting somebody, and he was admitted in a general hospital for 1 month. So we took him, we cleared the chylothorax. You can see the chyle also being green because it was draining into it. So once we cleared it, gave a thorough wash, we went to clip the thoracic duct. Clipping thoracic duct with ICG be sure that you go very near to the azygous vein up to the aorta, not injure any of the spinal vessels or the branches of azygous vein. So as you can see, I've reached the descending aorta above the thoracic duct. Then what you do is you go below the thoracic duct, and again you reach the descending aorta. So now I'm taking the pleural duct below, again opening it up and going up to the descending aorta. And then you just hold the whole tissue between your forceps and you just place one clip across it. You don't have to put 2 clips, 3 clips. One clip is enough. But one clip which has been correctly placed. And the beauty of ICG is on table you can document that you have correctly clipped it. You just flip the switch and you will know for sure that there is no chyle going beyond your clip. And that's why I say with confidence that one clip is 100% enough if put correctly. Bronchial vessel preservation is something that now we have started doing more and more for hysterectomies. Earlier it was not the norm. You just clip the azygous vein, the right bronchial will go with it. You do a very thorough AP window dissection, the left bronchial will go with it. But nowadays we save bronchial vessels because it maintains the perfusion of the trachea, perfusion of the bronchus, and most of the patients are able to, expectorate and get their mucus secretions out. So the post-op pulmonary morbidity has come significantly down once you have started preserving the bronchioles. The most common indication why people use ICG actually is to check the perfusion of your conduit. So gastric conduit is the most common thing to replace the esophagus once you have replaced it. So checking the vascularity based on the gastroepiploic vessels till where the vascularity is perfect, and at that point you will do the anastomosis. This is perhaps the most common indication of ICG in hysterectomy that you hear people talk about. What's also important is check the proximal esophagus vascularity. So we are very keen about the gastric conduit, but we forget to check what's happening with the proximal esophagus. So checking the vascularity of both is important. Let's come to the intermammary lymph nodes. For carcinoma breast, infrequently we get cases referred for which they will be having some bulky lymph nodes along the intermammary chain. So the easiest way to clear them is just to clip the intermammary at the origin and take all the nodes with you. But my plastic surgeon was unhappy with me when I did this because he used the intermammary to do his microvascular flap after a mastectomy. So we had to preserve it for him. And after we have dissected it, we wanted to make sure that there is enough vascularity in the internal mammary. Just because I say I preserved it doesn't mean it's preserved. I have to prove it to him. So I prove it to him by giving ICG, seeing that the perfusion of the internal mammary is intact, the perfusion of the perforators is intact. So my plastic surgeon is now happy with me since I've stopped dissecting the internal mammary. I hope the cardiac surgeons will also agree that I am preserving the left internal mammary carefully. Let's come to the lung dissections. Earlier, when we were not very well versed in segmental anatomy, if we had a small nodule in the lung, which we have seen on CT and we are not sure where it is, how will we resect it in minimal access? So we used to take the patient to CT scan room, we used to see the nodule, put the needle in, inject a little bit of ICG next to it. And in the earlier cases, we also used to put a localization needle in it so that we had 2 ways of finding out where this nodule was there. We were very underconfident as thoracic surgeons that we'll be able to find that small nodule just by passing our finger through that utility incision. So we did a few cases like that and got comfortable with the technique. We used to find that nodule very accurately, and actually in these cases we did not even put the utility incision. It was through a very small incision. We did not put our finger inside. I have very short stubby fingers, so anyway I can't put them inside. So thoracoscopically we used to complete it, get the tumor out, and be very sure that it would be inside. So this was the first use in lung dissections that we used. The second use was whenever we used to do these bronchial sleeve dissections, people used to say put an intercostal flap over it. Even if there's a leak, it will stop. But how vascular is it really? We found that it was not very vascular, and then we shifted from intercostal flap to serratus anterior, which was a much more robust flap. Coming to lobectomy, this is the left lower lobectomy. You can see that's the lower lobe pulmonary artery. You can see the lingular artery here, and one branch going to the basal anterior segment from the lingular artery. This variation was very dangerous for us. We could have knocked out the lingular artery, but then even after dissecting, we passed our stapler, and we were still unsure whether you can inflate the lung, see where it's not getting inflated after the bronchus is cut. But we find fluorescence guided surgery there is very useful. So here you can see this is the left side, that's the segment 6, which is the apical segment of the left lower lobe. I've dissected it, I've taken down my stapler, and I'll clamp it. And then after that, what I'll do is I'll inject ICG, I'll see what part of lower left lobe is getting perfused, what is not getting perfused, and does it match with my expectation. Correct. So only the apical lobe is not getting perfused, rest of the lower lobe is okay. So, but the vein and bronchus is remaining. So what I'll do at this point is use a monopolar, mark it, where is the exact transition line, and then continue with the rest of the vein and the bronchus and everything. 2 hours will easily pass in all this dissection and lymphnectomy. When you come back, after you've divided the bronchus, you'll see that only the monopolar line will remain fluorescence. Okay, the rest of the lower lobe has drained already to the liver, but where you have cut with the monopolar, the ICG also forms a coagulum. So that very nice line where you have to transit is ready for you. All you have to do is just take a parenchymal stapler, gently put your lung across, which you are meaning to staple, and go ahead with your transaction. The problem with segmentectomies is it is not lowering the mortality in certain studies, but when you are very careful that you have removed each and every part that you have cut the blood supply to, then the post-op results improve. And most of these procedures are minimal access, uniportal and biportal these days. So you can see, like anatomy books, you can see a correct line for the apical segment of the left lower lobe. So ensuring that your resection is actually very anatomical is easy with fluorescence guidance. There are other ways to do it, endobronchial, insufflation, all these things, but we choose this one. So the scope of fluorescence guided surgery is mostly perfusion assessments, thoracic duct lymphography, localization of nodules, and many others if you wish to think new ways to troubleshoot your patients. This is some of the work that we have published from our center based on fluorescence guided surgery. Thank you for your kind attention. Thank you.
Dr. Sanjit, how much exactly the dose of ICG when you give intravenous and when you give intranodal?
So for intravenous, generally, based on the weight of the patient, if for every 25 kilogram of the weight, you will give 2.5 milligram generally. Whereas for every other use, which is direct injection or for the ICG, for the node, the lower you give, the better. So there's an effect called as quenching effect for fluorescence. When it gets diluted, the fluorescence improves. So apart from perfusion, every other use, even 0.5 ml is enough. For perfusion, you need according to the weight.
I was seeing that in uniportal VETs, you used ICG for segmentectomy, left upper lobe segment 6 excision, right? So where was the camera actually at that particular time? ICG camera, fluorescent.
So our fluorescence camera is inbuilt into the lab system only.
Okay.
It's enabled. So it is through the uniportal opening only.
Okay.
You just switch a button and it's there. It's
Good.
not a separate camera.
Fine.
Thank you very much for a good presentation and a good discussion. May I request the chairpersons to present the memento to our two speakers, Dr. Sri Krishna and Dr. Shukla. Please come up. May I also request Dr. Gaurav to
Thought and point out that your presentation was flawless. Means since yesterday to today, I'm sorry, many people had their flights and people couldn't see it. The way, sir is a technical guy, I'm not a technical guy. He told me the way you converted it to an MP4 or something, your videos did beautifully, everything. This is how ideal presentation should be. Means flawless. Means for that I could have given you another moment. Believe me, wonderful. And thanks Pranav for means I left thoracic and Pranav and I are batchmates. We are like 94 batch of MBBS going together for the last 3 decades now. So he chose the right path of being a thoracic surgeon and I made the biggest mistake in my life of joining cardiac. So I envy him for his clarity of thoughts. But first we present. Please.
step आगे आइए, एक little bit forward, okay, little bit, okay, ready? Yes. Okay, thank you, sir.
एक फोटो हम तीनों की खिंचवाएं हम तीनों बैचमेट्स हैं पता है we started our journey in cardiac surgery together MBBS together
सबसे नेटवर्क हो आप सब
हाँ
सबसे नेटवर्क हो
सबसे हम ऐसे ही it's been tiring 2 days and I thank you all for your patience to stay till the end and I cannot thank every one of you more. If there have been any shortcomings, it's on me. And thanks to all our teachers and especially Sanjay sir who's been the lifesaver for 2 days. Otherwise I would have been on an ICU on wheels today. Thanks a lot sir. Thank you all, please. We guess we can have coffee before you guys depart. And thanks to Hayat for the hospitality.